So very good evening everyone. I hope all of you are doing really great and I hope the studies are going really good. So I welcome you all in this session, LRR session of psychiatry, and we are in this festivity season, so I'm sure you know this festivity mood might be there. So wishing a very happy Diwali and lots of good wishes from all of you. To all of you from our side, but please remember, in this festivity mood also plan accordingly, so that yes, you can spend some time with the friends, family members, but also you are able to utilize this very important time for your studies. So with this we'll start the session. Yes, it's a live session, so I'm able to see all your chats, so you can put your queries in the chat box. So again, when we talk about INI-CET, these are some important areas, you know, which usually we have seen that they are asking a lot of questions from psychiatry. So very importantly, you will see that basics again they are asking, and the questions are slightly tricky when they ask question from the basics. Also, they are asking questions on various disorders, how to make a diagnosis. Very important, I am sure you all will appreciate that psychopharmacology and also including new drugs is a very important topic for INI-CET. Substance again very important, we will discuss some important points, and especially for INI-CET epidemiology plays an important role. Sometimes you will see even in the PYQs questions on epidemiology. So in the end I will share some of the slides in which I will discuss some important epidemiology. Then we will also discuss some miscellaneous topics, also certain images which we will discuss in the latter part. Acronyms sometimes are asked, so I'll give you a list of some important acronyms also, you can just go through them, and we'll also discuss some potential repeat questions as well as some potential new questions which I say FQs. So I'll also discuss, especially seeing the recent trend, in the end I'll also discuss some very high potential MCQs which may come as it is in the exam. So we'll discuss all those topics. So very important, remember, many times you will see that psychiatry in INI-CET may be integrated in some of the other subjects. So try to answer the question. So we'll discuss some questions also, and I'll discuss some important topics. So let's start, let's begin. Right, so see this question: a 24-year-old male presents to the psychiatrist with laughing at 1 minute and crying the next without any clear stimulus. Which of the following best describes the symptoms? So I'm starting with this very important topic of MSC. What is MSC? Mental status examination. So when we examine a patient with psychiatric illnesses, we do this MSC. Very important, remember. And in this MSC, can you appreciate? Very good. So can you tell me what is this phenomena you can see? So all of us can appreciate it's an abnormality of affect. Affect is the expression of emotion. So our emotions are expressed in the face, in our body language. So we are trying to assess what is the abnormality. What abnormality of affect is seen here? So tell me what is the right answer. Can you appreciate? Patient is laughing and he's crying without any clear stimulus. So here the answer is it incongruent affect? Please remember, incongruent affect ka matlab kya hai beta? What is incongruent affect? Incongruent affect means when the affect is not matching with the mood or thought of the person. So this is incongruent affect. For example, हमने patient से पूछा how is your mood, and the patient says, sir my mood is very sad. Can you appreciate here what is the mood of the patient? The mood of the patient says it is sad, but when you see the affect, he is happy, he is very cheerful. So this is known as incongruent affect. Can anybody tell me what is inappropriate affect? Can anybody tell me what is inappropriate affect? When the affect is not matching with the situation. Suppose patient goes in the funeral of a family member, somebody has died in the family, everybody is very sad in this funeral, but the person sees the dead body and he starts laughing. So can you appreciate here the affect is not matching with the situation. This is inappropriate affect. Remember, both this incongruent and inappropriate affect, they can be seen in conditions such as schizophrenia. Very important topic. Yes, the answer here is labile affect. So again you can see what is the meaning of lability. I always say remember things from the name. Shakespeare has said what's there in the name, but I always say in psychiatry names are very important. Just understand the names, understand the terms, and you'll be able to understand the concept. But a lability means something which is changing rapidly. So there is rapid and abrupt changes in emotion. This is labile affect. Can anybody tell me two important conditions where you can see labile affect? Tell me the two important conditions and remember the order as well. First is, remember, mania. You call it mania or bipolar disorder. I'll take both the answer. And another is organic mental disorder. Then lastly, remember what is flat affect, also sometimes referred to as blunt affect. Again, but what do you mean by flat? See, when we do an ECG, you see a lot of such waves. How is the ECG of a person who is dead? it's a flat line. This is the meaning of flat affect. Flat affect means that the emotion is not changing. So they may ask this question like this. So you're discussing some happy moments of patient's life. For example, he was promoted recently, or you are discussing some sad moments of his life. Let us say recently died in his family. So I'm discussing happy moments, sad moments, but the patient is looking like this. There is no change in his affect, so as if the emotions are dead. So this is the meaning of flat affect. Also, can anybody tell me what a flat affect we'll discuss? It can be seen in conditions like schizophrenia. It is which symptom of schizophrenia? Remember, we'll discuss it is one of the negative symptoms of schizophrenia. So here the answer is, it is labile affect. Without any reason, there is rapid and abrupt changes in emotion. I hope this is clear. So please be very careful. They may ask such questions like this. So let's discuss the next question. The next question is a 35-year-old male admitted in the hospital with a diagnosis of schizophrenia. So patient is admitted with a diagnosis of schizophrenia, and he claims that his wife present in the hospital is not his wife, but a hospital staff who wants to kill him and even tried it 4 days before. He continues to claim it despite being convinced otherwise. So everybody is trying to tell him no, it is not true, but he is not getting convinced. First of all, can you tell me it is which abnormality of thought? So there is a false thought in the mind of the patient. He is thinking that something is true, but although it is not true, it's a false belief in his mind. So can you tell me it's an abnormality? What abnormality you can see here? Beta, यहाँ पे क्या abnormality मिल रही है हमें? Here it is an example of delusion. Very good. And tell me, delusion, if we see thought, we discuss thought under 4 domains, that is flow, content, form and possession. Can you tell me delusion is an abnormality which of the 4? Flow, content, form or possession? Very good. It's an abnormality of content of thought. Very good. So again, please be very careful. Delusion is a very important topic for your exam. So let's talk about delusion. So we know delusion, it's an abnormality of content of thought. What is a delusion? It's a false, fixed, firm idea or belief. So it's a false belief, but it is fixed in his mind. So patient's belief is fixed. No matter what evidence you try to tell him, he is holding this belief with extraordinary conviction. So this is what is known as delusion. Also remember, delusion is unexplained by the social cultural background. Can anybody tell me this last line helps us differentiate delusion from very important phenomena? So sometimes, you know, in societies there are certain beliefs which can be explained by the person's social or cultural background. For example, some people in some societies believe that if a black cat crosses your way, something bad will happen. है ना, काली बिल्ली ने रास्ता काट लिया तो कुछ अपशगुन हो जाएगा. People believe it so firmly that they may wait for half an hour, 1 hour. जब तक somebody else don't cross by, they will not move. So it also seems to be a false belief. It also seems to be fixed in the mind, but it can be explained by the social cultural background. So remember, that is known as very good superstition. So the last line helps us differentiate superstition from delusion. So delusion is not explained by the social or cultural background. Very important, please remember some of these important name delusions. So there are, you know, lots of name delusions. Please remember these, because sometimes in the question they may just ask you which of the following delusion is seen in the patient, and sometimes more than one delusion can also be seen. So patient thinks somebody wants to kill me or harm me. Can you tell me? Can you tell me which delusion is this? Patient को लगता है somebody wants to kill me, somebody wants to harm me. Yes, this is delusion of persecution. Please remember, which is the most common delusion in psychiatric disorders? Remember, it is the most common delusion. Also remember, delusion is a psychotic symptom. Please remember, delusion एक psychotic symptom है. Can be seen in, you know, psychotic disorders like schizophrenia, and can also be seen in other conditions as well. Patient thinks that people are talking about him. Patient को लगता है आसपास के लोग they are talking about me, or somebody is spying on me. So patient thinks that things which are happening around me, they are in reference to me. So what is this delusion known as? This is known as delusion of reference. Very good. So a person thinks, please listen to this question. A person thinks that the news anchor in the television is sending or is giving some secret messages to me. Which delusion can you think here is seen? Patient को लगता है जो news anchor television पे है, she is giving some secret message to the person. So what is this delusion? Can anybody tell me what is this delusion? Again, this is delusion of reference. Patient makes false big claims. Patient says, I am the king of the world. Prime Minister asked me how should I run the country. I made Donald Trump the president of USA again. Although the neighbor does not know him, but he is claiming such famous people know him. So what is this delusion? Remember, this is known as delusion of grandiosity. Very important. So patient has false big claims. In another delusion, patient denies existence of self. Patient says, I am dead, I don't have a brain, I don't have any intestine. Or he may deny the existence of his loved one, my family members are dead. Or this world is a dead world. ये मरे हुए लोगों की दुनिया है. It's a dead world. Everybody is just a plank of card. So patient is negating everything. But what is this delusion? Very good. This is known as delusion of nihilism or delusion of negation. Very good. Now, please tell me again, it's a PYQ, it has been asked in INI-CET before as well. What is Cotard syndrome? Tell me what is Cotard syndrome? Cotard syndrome is if a patient with depression develops delusion of nihilism. So, that is known as Cotard syndrome. Now, a very interesting question was asked in INI-CET. Sometimes they just play with words. So, they had given you an example that a patient has depression, and along with depression, patient is saying that I am dead, I don't have a head. What is the point of eating anything? The question was which delusion is seen in the patient. The options were, option A was delusion of nihilism and option B was Cotard syndrome. Can you tell me what answer would you mark in this question? In such a question, always read the last line very carefully. Question में पूछा था which of the following delusion is seen. So I'm sure all of us would have appreciated it that Cotard syndrome is seen here, but the question was कौन सी delusion है. So then the answer becomes delusion of nihilism. So please be very careful here. Please, again remember all these important points. It's very important to remember these, right? Now let's discuss few more delusions. One important syndrome is delusional misidentification syndrome. Beta misidentification का मतलब क्या है? Patient is identifying someone as someone else. Two important syndrome let's discuss. One is Capgras syndrome. Beta, what is Capgras syndrome? Again, I'll give you a trick. Very simple. Just see the name. In the name itself, see these alternate letters. Capgras syndrome, close person replaced by stranger. Patient को ऐसा लगता है somebody close to me has been replaced by a stranger. Like, can you appreciate in this question? Patient को लग रहा है the wife has been replaced by a stranger. So here the answer is it is Capgras syndrome. Please remember, such question may be asked. Also, there is something known as Fregoli syndrome. Beta, Fregoli syndrome, remember it's opposite. यहाँ पे patient को लगता है familiar person is imposing as a stranger. For example, suppose patient is walking and he sees a stranger. Let's call him S1. He says you're looking like a stranger, but you're not a stranger. You are my wife in disguise. तो patient को लग रहा है उसका familiar person, in this case wife, उसके सामने आ रही है as a stranger, imposing as a stranger. He goes forward, meets another stranger, S2. Again, इस दूसरे stranger को देख के he says, you are not a stranger, you are my wife in disguise. What are you doing here? Let's go home, let's go home. So this is Fregoli syndrome. So again, a very simple trick. I always say have these, tricks in your armory so that जब question आता है, always try to use these tricks. Tell me, in Capgras syndrome, the patient is arguing or fighting with whom? He is arguing, please remember, C say Capgras, he is arguing with C for close person. Like in that question, he is arguing with the wife, you're not my wife, you are somebody else. While in Fregoli, remember, the person is fighting with or arguing with the stranger. Like in this scenario, he is arguing with the strangers, that you're not stranger, you are a person I know. So remember Capgras and Fregoli syndrome. Very good. Let's discuss few more delusions. So sometimes they may ask you these named delusions. Patient claims someone else is in love with the patient. A 25-year-old female says, a patient comes, she says that Salman Khan is in love with me. She says, sir, वो जो movie आई थी किसी का भाई किसी की जान, उसमें वो जो जान है वो मैं थी. She claims that Salman Khan is in love with me. So patient may claim something like this. So what is this delusion known as? Can anybody tell me what is the name of this delusion? Yes, very good. So please remember these names. De Clerambault syndrome, also known as erotomania, also known as delusion of love. So when we say love, we say we love that person, but here the person is claiming somebody else is in love with me, although that person might have never met this patient. So this is delusion of love. Another delusion, patient thinks that my partner, my spouse is having an affair. A 40-year-old male claims that my wife is having an affair. Everybody is trying to convince him otherwise, but he is sure that my wife is having an affair. What is this delusion known as? Very good. This is known as Othello syndrome, also known as delusion of infidelity. Infidelity means that my partner is cheating also known as morbid jealousy. Can anybody tell me a very important substance with which this delusion is associated? So they may just ask you this question, that which of the following substance this 40-year-old male is consuming. Can you tell me which substance we are talking about? कौन से substance? Very good, yes. Remember, alcohol. Very good. So please be very careful. Many questions have been asked on this topic of delusion. So yes, let's see this. So here the answer, it is not delusion of infidelity, Fregolio, delusion of love, it is Capgras syndrome. I hope this is clear to everyone. Right. Let's see the next question. Again, you will see such questions. 65-year-old male is brought to you by his wife as she has noted some personality change in the past few months. While the patient is being interviewed, he answers every question with the same 3 words. So any question you are asking, he is stuck on these 3 words only. So can you tell me which of the following symptoms best fit here? The options are circumstantiality, perseveration, delusion, flight of ideas. So I am sure it is not delusion. So we have ruled out delusion. What is the answer here? Very good. It's perseveration. Very good. So let's discuss what is perseveration. In fact, when we talk about perseveration, it comes under the abnormality of flow or stream. So we have covered what are the abnormalities of content. Now let's talk about the abnormality of flow or stream. So that means, so normally you will see that thoughts are flowing in our mind. So sometimes there can be abnormality of this flow of thought. So in perseveration, what is happening? Remember 3 P's. P say perseveration, a thought persist beyond the point of relevance. So patient के mind में एक ही thought stuck हो गया. Now patient is not able to go forward. He is just stuck at one thought. So can you appreciate it's a problem of flow? So for example, you ask a patient, what is your name? My name is Mukesh. It is correct. This is correct. What do you do? My name is Mukesh. Where do you live? My name is Mukesh. Yes. So what is the name of your wife? My name is Mukesh. So can you appreciate now the person is answering all the question with these same 3 words. So this is perseveration. Can you tell me 2 important conditions where you can find perseveration? Yes, we'll discuss circumstantiality. Very good. So tell me 2 important conditions and also remember the order. First and very important condition is organic mental disorder, and also it can be seen sometimes even in schizophrenia. Very good. I hope this is clear. This is perseveration. Sometimes they may give you example like this. A patient says, I am going. So can you appreciate he's, once he said I am going, but now he's stuck at one word, going. So sometimes again, such questions can be asked. So these are various variants of perseveration may also be present. So remember, what is perseveration? Also, if I ask you in this question, can you tell me the diagnosis also, or possibly which diagnosis might be here? I've given you one clue also. So I've told you perseveration is seen in 2 important conditions. So based on that, can you tell me, can you give me an idea what you think what could have been the diagnosis here? Anybody? देखो, अभी इस question में we have not given any symptom of schizophrenia. We'll discuss how to make a diagnosis. But we have given you this history. It's a 65-year-old male. There are some personality changes. Can you tell me which important lobe may be associated with personality changes? So I'm trying to give you hints. Sometimes they may give you certain clues in the question and they may just ask you the diagnosis. So possibly it could be a case of, so you remember this personality change can occur in the abnormality of which lobe? Remember, frontal lobe. So please remember frontal lobe, a very important area. Many of these psychiatric behavioral symptoms can be seen, personality changes can occur. So again, likely diagnosis or possible diagnosis could have been organic mental disorder here. Very good. Is it clear to everyone? So this is how you have to see the question in totality and answer. Let's see the next question. A patient says, I am lawyer, call my doctor because you are a liar, he is umpire, don't touch that wire, it's hot like today's sun, oh my son is Mohan. Which of the following is seen here? So again, try to see the question, see the option and answer. Options are loosening of association, flight of ideas, derailment, perseveration. Again, we can rule out it is not perseveration. Very good, yes. See, let's now talk about flight of ideas. Just see the name. What is the term flight of ideas telling you? That the ideas are on a flight. So patient ke mind mein the thoughts are coming very fast. One thought is followed by another very fast. So patient will speak also very fast. So apne patient se you ask a question, he will speak very fast, go somewhere and he will not answer back your question. So we say goal is not reached. So patient may be saying things which are not making much sense and he is not reaching the goal. But when you listen to the question, you know what the patient is saying, you will see there are certain connections. So you will see that the thoughts may be connected. One is maybe connected by chance. For example, patient may speak like this. My name is Virat. I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही तो ढूंढे. Something like this. You know, nothing is making sense, but one thought is connected by other by a chance factor. Or person may see things which are connected by rhyming, that is known as clang association. So patient may speak like this: Ram can sing, birds have wing, I am the king, phone goes string string, the weather is spring, bring 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 bring. So can you appreciate things are not making much sense, but you can see some connection. So this is flight of ideas. Very good. Can you tell me in which important condition flight of ideas can be seen? Yes, very good. It can be seen in mania. So please see here. Again you will say, sir, here speed is not mentioned. So the speed is not mentioned here. So again, you know, possible, you know, differential, you may also think of loosening of association, but we will discuss what is loosening of association. It's a problem of form of thought. So here, although the speed is not mentioned, but still, why are we saying it is flight of ideas? Because can you appreciate, you can see a lot of the connection. There is some rhyming also, and also so clang association is also there, and also by chance connection is also here. So this is, yes, very good. This is flight of ideas. We'll discuss loosening of association, derailment. These are abnormalities of form. Is it clear? So these are abnormalities of form. Now let's see this. Let's see one more important abnormality under flow or stream, that is circumstantiality. Now what is the English meaning of circumstantial? Circumstantial का मतलब क्या होता है? That person is giving unnecessary or trivial details. Patient ऐसी चीजें बोल रहा है जो आपने पूछी नहीं है, that are unnecessary. So we'll go here and there, give unnecessary details, but ultimately he will answer back your question. So we say that the goal is reached. For example, if a person has to go from A to B, rather than going straight, he is going like this. He is giving unnecessary trivial information, but ultimately is answering your question. For example, you ask a patient, who is your favorite actress? Very simple question you have asked. So patient may start like this: Sir, Alia Bhatt acts very well. I have seen all her movies. I was upset for a few days when I heard she is getting married, but may God bless her. Even Kareena Kapoor Khan is a wonderful actress. I was upset for a few days when I heard she is getting married, but may God bless her. Katrina Kaif also dances well, acts well. I was upset when I heard she is getting married, but my favorite actress is Kiara Advani. So can you appreciate, he is given unnecessary information, but please understand, here everything is making sense. You are able to understand everything, but it is unnecessary, and ultimately the person is going to the goal. So this is circumstantiality. So in fact, in this question, please appreciate, it is not circumstantiality. First of all, the person is not reaching the goal. Also, you will see in flight of ideas, when the person is saying things, it is not making much sense. While in circumstantiality, you will appreciate that whatever patient is saying, it is making some sense. So this is circumstantiality. Is it clear to everyone? Yes. Okay. And perseveration we have already discussed. In fact, let's see this question. A doctor asks a patient about her age. Please read this question very carefully. I want all of you to read the question, because sometimes you will get such questions. So please don't be in a hurry. Appreciate the question and then answer the question. So when you ask a patient about the age, the patient responds, you know, doctor, I am from a village. We were married at a very young age at 12 with my husband, who is just 5 years older than me. Then I had 2 kids when I was around 18 or something. Now I am 38, but look like their older sister dog. What is the most likely thought disorder displayed here? Can you appreciate, you ask the age, patient gives unnecessary information, but somewhere has she answered your question, she reaches the goal. Yes. So please remember, here it is circumstantiality and not tangentiality. We will discuss tangentiality is an abnormality of form when the person just touches the topic and goes away, and here the goal is not reached. So please remember, very important difference between circumstantiality and tangentiality. See, what is tangent? Just see this. When we draw a tangent, you know, in school days, teacher would come and say, draw a tangent to a circle. It's a line which touches the circle at one point and goes away. Kya tangent kabhi circle par वापस आता है? No. So remember, the goal is not reached. So this is tangentiality, and in this question, you can see the goal is reached. This is circumstantiality. I hope this is clear to everyone. Yes, the patient has reached the topic. So let's discuss some important abnormalities of form. देखो फॉर्म का मतलब क्या है? व्हाट डू यू मीन बाय फॉर्म? फॉर्म मीन्स ऑर्गेनाइजेशन. So normally our thoughts are organized. You know, what do you mean by form? Form का मतलब है structure. Like this pen which I am holding, it has a form, it has a structure. Similarly, our thoughts in our mind, they also have a structure. There is a start, there is a middle point, and there is an end. Everything is logically connected. So normally the form is normal. But when there is abnormality of form, that is known as, remember, formal thought disorder. Very important, remember, that is known as formal thought disorders. So formal, the name is telling you the form is abnormal, isn't it? So formal thought disorder. Can anybody tell me in which condition? Usually you will see formal thought disorders can be seen in condition like schizophrenia. In fact, we'll discuss this. So in schizophrenia, you may see formal thought disorder. They may just ask you which of the following is a abnormality of form or formal thought disorder. Again, just see the name. First is loosening of association. देखो सिर्फ नाम ध्यान से देखो. What do you mean by loosening of association? This term loosening of association is telling us that जो association था between the thoughts, that is loosened. So there is breakdown in the logical connection between the thoughts. For example, you ask a patient, what will you do if you want to have food outside? Patient may speak like this: I will eat, I will pay, I will reach the cafe, I will come back, black umbrella. So you will say, sir, he's saying things, words are making sense, but we're not able to understand the sentences. So that is the meaning of loosening of association. Is it clear? So this is loosening of association. Again, how to differentiate? You know, sometime that question we discussed of flight of ideas, वहाँ पे you will see, although one is very important difference is speed is increased in flight of ideas, but speed was not mentioned in that question, na? So there was some connection. While here in loosening of association, you will just see that there is breakdown in the logical connection between the thought. Next is derailment. Derailment is also known as knight's move thinking. So how does a knight moves in the chessboard? A knight or a horse, how does a knight move on the chessboard? Go straight and suddenly takes a right or left. This is what is happening in derailment. देखो derailment का मतलब क्या है? The train is moving on track and suddenly it gets derailed. So that is jumping off the track. Patient was on the track for some time and suddenly उसने topic change कर दिया. For example, you ask a patient, what will you do if you want to have food outside? Patient says, sir, I will reach cafe, I will order food. So he was on track for some time and suddenly changes the track. Sir, recently India versus West Indies cricket matches were there and India has won the test match series. So can you appreciate he was on track for some time and suddenly उसने track change कर दिया. This is derailment. And tangentiality, I am sure all of us now can say, just touches the topic and goes away. Derailment and tangentiality में difference क्या है? In derailment, remember he is on track for some time and then he changes the track and दोनों जो नया टॉपिक है, it has no connection with the first topic. जबकि tangentiality from the beginning he is off track, he is just touching the topic and he goes away. I hope this is clear है ना? तो please remember this, tangentiality में he is just touching the topic. For example, जैसे हमने circumstantiality में पूछा था, who is your favorite actress? यहाँ पे if we ask a patient who is your favorite actress, patient may just touch the topic. Sir, I like Indian movies, especially the dances. You know, in fact, Shahid Kapoor dances very well and is one of the fine actors in the country we have, and he goes on that point. So उसने बस topic touch कर दिया, who is your favorite actress में movies, and he is went away. So from the beginning he is off track. So this is tangentiality. I hope this is clear. जबकि derailment में for some time he is on the track and then he changes the track and totally goes to a new topic. Is it clear to everyone? Very good. But what do you mean by neologism? देखो again, the term is telling you neo means new, logos means word. So neologism means suddenly there is a new word in the mind of the patient. So you're talking to a patient who knows only English language and he's talking about his daily routine. Sir, I woke up at 5 o'clock in the morning, I went for a run, I came back, took a shower, and suddenly he says, sir, I have bought a new Pratt knit kit with Go. And you are confused, what is this Pratt knit kit with Go? You searched on Google, there is no such word. आपने Oxford Dictionary देखा, there is no such word. He says, sir, it is white in color. It writes very well. Still आपको नहीं समझ में आया, what is this Pratt knit kit with Go? Then he points to his pen. Sir, I bought a new Pratt knit kit with Go. So can you appreciate how has he used this term for this pen? No, we are not able to understand. So this is neologism, as if there is a new word which is popping in his mind. So this is neologism. Then what is verbigeration? Sometimes referred to as word salad. So there is senseless repetition of words, phrases or sounds. I am going hoo, ha, I am going hoo, ha, balle. So he is just repeating some words, some phrases or some sounds which are not making much sense. So this is verbigeration. So these are some important abnormalities of form, and remember these formal thought disorders can be seen in conditions like schizophrenia. I hope this is clear. Let's complete this table. Let's discuss now abnormalities of possession. What do you mean by possession? Normally, if I ask you that thoughts in your mind are your thoughts or your neighbor's thought, you will say, of course, sir, I possess my thought, these are my thoughts. But sometimes patient either is not able to control his thoughts or he is not having the sense of possession of thoughts. So then we call it as abnormality of possession. Please remember two important abnormalities here. One very important is obsession. Please remember for all practical purposes, remember obsession is an abnormality of possession of thought. देखो दोनों rhyme भी कर रहे हैं ना, obsession, possession. Please remember. Where can we find obsessions? Can anybody tell me? In which condition can you find obsession? It can be seen in conditions such as OCD. So in OCD you can see obsession. So we'll discuss what are obsession when we'll cover OCD. These are repetitive thoughts. Patient के mind में कुछ repeatedly thoughts आ रहे हैं or some images or some impulses. But what are impulses? Impulses are urges. So repeatedly patient के mind में these thoughts are coming and is not able to control them. And another abnormality, remember, is thought alienation. Again, just see, alien. So again the term is telling you that these thoughts are not mine, they are influenced by someone else. Thought alienation, this is also known as passivity phenomena. Again, remember in psychiatry, whenever you see this term passivity, passivity means under someone else's control. So here the patient experiences that his thoughts are under someone else's control. So three important abnormalities come here. One is thought insertion. Patient says that somebody is putting thoughts in my mind. So there is a thought in my mind, but this is not my thought. Somebody is inserting these thoughts in my mind. Then next is thought withdrawal. But what do you mean by withdrawal? Somebody is taking away my thoughts. So patient says, few minutes back, sir, there was a thought in my mind, but somebody has taken that thought away. Then thought broadcast. Patient says that my thoughts are getting broadcasted outside. Patient comes in the room and says, everybody in this room is able to know my thoughts. My thoughts are getting broadcasted outside. So this is thought broadcast. Again, can anybody tell me thought insertion, thought withdrawal, thought broadcast? These can be seen in which condition? Can be seen in conditions such as schizophrenia. In fact, they are also included under Schneider's first rank symptoms, SFRS. Okay, so there are 11 SFRS and 3 of them are these thought alienation phenomena. I hope this is clear to everyone. It's a very important table and sometimes you will see questions being asked from this table. So please revise this carefully. Let's come to another important abnormality of MSc. So let's answer this question. A 40-year-old male patient is brought to psychiatry clinic with illness since 10 years. Family members report that when any happy moment and sad events occur at home, he shows no emotion. Can you tell me which is this phenomena here? There are no changes in this patient's emotion. So this is what we call as flat affect or affective flattening. Okay, he also doubts that his wife is not his wife but a neighbor in disguise and doesn't get convinced even if he tries, everybody tries to give contrary evidence. So this we have already covered. This is which delusion? This is Capgras syndrome. This is Capgras syndrome. He also reports of hearing voices of neighbors talking about me, not heard by others. Usko आवाजें भी आ रही हैं, not heard by others. So this is, can you tell me what is this likely phenomena? What is this likely symptom which has been highlighted in red? This seems to be an abnormality of perception. So this is hallucination. In fact, we'll discuss difference between hallucination and pseudo hallucination. So let's talk about some abnormalities of perception. Now what do you mean by perception? So how we experience the external environment, like you can hear me, you can see me, you can smell things around, you can taste things around, and also there is a sense of touch. So this is what is perception. So when there is abnormality of perception, hallucination is one important abnormality. Very good. Let's discuss what is hallucination. So hallucination is a false perception. So it's an abnormality of perception without any real object. So there is no real object, but still the person is perceiving something. So that is hallucination. So hallucination, remember, is clear. It is independent of the patient's will. Patient says, I don't have any control, and it is without any real object. Also tell me where the person experiences hallucination. Very important. This helps us differentiate hallucination from pseudo hallucination. देखो, both hallucination and pseudo hallucination, they have similar characteristic. Both are clear to the person, independent of the person's will, without any real object. But the difference is where the person experiences hallucination. But please remember, hallucination patient experience in the outer objective space. Patient says, I am hearing some voices coming from outside, coming from this room or coming from outside the room. So this is hallucination. If you've seen this movie, have you seen this movie? In this movie, Munna Bhai can see and hear Mahatma Gandhi. We know Mahatma Gandhi is no more with us, but उसको महात्मा गांधी दिखाई दे रहे हैं, सुनाई दे रहे हैं. A classical example of hallucination. While what is the difference between pseudo hallucination? Can anybody tell me? ये कहाँ पे होते हैं? Where do you know where the patient experiences pseudo hallucination? It occurs in the inner subjective space. So if you ask me, sir, give us an example. But any example of hallucination can be an example of pseudo hallucination. Ask the patient where he is experiencing. So patient says, I am hearing voices coming from outside. That is hallucination. So within my mind, I am able to hear my voice, or I can see someone in my mind. So this is pseudo hallucination in the inner subjective space. Very good. So please remember important difference. So just like we discussed, there are different types of delusions. There are different types of hallucination. Also remember, hallucination is also a psychotic symptom. Okay, so please remember, it is also a psychotic symptom. So there are different types of hallucination. Again, as we discussed, there are 5 important modalities, and you can see 5 different important hallucination. One is auditory. Auditory means patient is hearing something not heard by others, which is the most common hallucination in psychiatric disorder. Most common delusion कौन सा था? Delusion of persecution. अगर मैं आपसे पूछूं most common hallucination कौन सा in psychiatric disorders, remember most common hallucination is auditory hallucination. Second is visual hallucination. But a visual hallucination में patient is seeing something not seen by others. So very importantly, what is the one point which I want you to remember? देखो, hallucination is a psychotic symptom, can be seen in psychotic disorders, it can be seen in other condition also. But in the question, if they tell you that patient has visual hallucination, can you tell me what important diagnostic entity, कौन सा important diagnosis you will try to rule out in the patient? Please remember, organic mental disorder. In fact, in organic mental disorders, very good. Most common hallucination in organic mental disorder is visual. Of course, it can be seen in other condition like schizophrenia, but it's a very important point. Just see if they are talking about any organic mental disorder. Tactile means sense of touch. So patient says, I can experience some insects are crawling over or under my skin. Can you tell me? So this is tactile hallucination. Can you tell me some other names? Again, this is a repeatedly asked question in INI-CET exams. It is also known as formications, very good, also known as cocaine bugs or magnum bugs. Why cocaine bugs? Because it can be seen in cocaine users. So very important, remember, it can be seen in cocaine users. Suppose I ask you this question. A patient comes with tachycardia, tachypnea and scratch marks. Which substance is he consuming? Can you guess which substance might be the person is consuming? So can you appreciate he's having scratch mark? Again, that may be because of tactile hallucination and he's trying to scratch it out. So sometimes in the physical finding you may see scratch marks can be seen. And why tachycardia, tachypnea we'll discuss when we'll talk about the substances. Olfactory means smell. Patient comes in the room and says there is a bad smell which I can experience, nobody else can experience. So this is olfactory. Gustatory means taste. So there is no food on his tongue but patient ko taste aa raha hai. So these are olfactory and gustatory hallucination. Again, they can be seen in various conditions. Can you tell me an important abnormality or an important abnormality of a lobe in which you can see olfactory, gustatory? Very good. In the temporal lobe disorders. In the temporal lobe disorder. So patient had a head injury, develops these hallucinations. So one of the possible areas which may be affected was temporal lobe. So temporal lobe epilepsy, temporal lobe tumor, trauma, then these hallucination may be seen. Very good. So again, a very important table. Let's discuss one special hallucination. So again, we have discussed some important hallucination. There are various special hallucination. One of them is reflex hallucination. Can you tell me another name of reflex hallucination? It was a question which was asked in AIIMS. What is another name of reflex hallucination? It's a special hallucination. Another name is, it is also known as morbid synesthesia. Very good. Now, why I am saying it's a special hallucination? See, we've discussed that for hallucination, no real object is required. But here, in this case, a normal stimulus in one sensory modality, it is required. It produces hallucination in a different modality. So please remember this, that suppose a person experiences a normal stimulus. For example, patient says, sir, whenever I switch on my radio, तो उसने रेडियो टर्न ऑन किया, उसको सुनाई दे रहा है ना, इट्स अ ऑडिटरी मोडालिटी, ऑल ऑफ अस कैन हियर द रेडियो, इट्स अ रियल ऑब्जेक्ट. ही सेज, I see color in the sky. So can you appreciate this normal auditory stimulus has produced hallucination. Nobody else can see those colors. And what are And what is this hallucination? But it is visual hallucination. So auditory stimulus is producing visual hallucination. This is reflex hallucination. And remember, can you tell me an important substance with which these hallucinations can be seen? So it can be seen with hallucinogens such as LSD, lysergic acid diethylamide. So please remember, with substances like LSD, these reflex hallucination can be seen. I hope this is clear to everyone. Very good. Let's complete MSc, then we'll go to the important disorders. So the next heading under the MSc which we will cover are the cognitive functions. So now we're trying to assess some important cognitive functions. First is orientation. But what is orientation? Orientation means awareness of self and surrounding. So right now all of us are oriented. How do we assess orientation? Can you tell me? We assess orientation with respect to time, place, person. If I ask you what is the time right now, what is the place you are sitting, who are the people around you, you can identify. So this is orientation. Suppose patient is in the hospital, but he says, I am at my home. So can I say he is disoriented? So there is disorientation. Can anybody tell me an important condition where disorientation can be seen? So tell me disorientation, but I'll give you hint. D for disorientation, D for, so tell me disorientation can be seen. D for delirium, very important. So we'll discuss, in fact, delirium is an organic mental disorder. Delirium is an organic mental disorder which we'll discuss. In fact, please remember now organic mental disorders both in DSM-5 and ICD-11, they've given a new term to organic mental disorder. Can you tell me what is the new term for organic mental disorder? It is known as these are known as neurocognitive disorders. In fact, just see the term itself is telling you neurocognitive. So these patients in organic mental disorder, there is cognitive functions are impaired. So remember, orientation may be impaired in conditions such as delirium. So very important, we'll discuss. Next important point we'll discuss in cognitive function is attention. Again, what do you mean by attention? Beta, attention का मतलब क्या होता है? Attention means ability to focus. You know, in school days, teacher would come in the class and say, pay attention. So don't mug up any definition, understand the concept. Attention का मतलब है ability to focus on a stimulus. So how do we assess कि क्या patient की attention intact है या नहीं? We use this test known as digit repetition और digit span test. हमने patient को कुछ digits दिए and if the patient is able to repeat those digits after us, that means उसकी attention intact है. Again, in fact, there are two components. One is digit forward test. Digit forward test का मतलब है हमने patient को जो digit दिए, let us say I say 27, तो patient को forward direction में ही repeat करना, he says 27, then I will increase the number. If he is able to do this, I will say attention is intact. Then another is digit backward test. Backward test में क्या होगा? Patient is repeating in the backward direction. Suppose I say 3, 8, he will say 8, 3 and then I will increase the number. So these are under digit repetition test. अगर दोनों option में होता है and they ask you the test for attention, then digit forward test may be a better answer. Next is concentration. Again, just see the term, don't mug up any definition. Concentration का मतलब क्या होता है? Sustained attention. You know, sometimes you say, sir, after reading for half an hour, I lose my concentration. So concentration is sustained attention. Again, how do we assess concentration? One of the test is 100 minus 7 test or serial 7 subtraction test. हम patient को बोलते हैं कि subtract 7 from 100, जो भी answer आता है, keep on subtracting till you can. Suppose the patient says 93, then the patient again subtracts 7, then patient says, you know, keep on subtracting 86, then patient says 79, 72. If he is able to do at least 5 times, normally a person will be able to do it till 5 times, then we'll say the concentration is intact. So if he is able to not do, then we'll say the concentration is impaired. So this is how we assess concentration. Let's also discuss memory. Again, memory, based on the duration, we can divide into 3 categories. One is immediate. But what is immediate memory? Immediate memory is memory of the past few seconds. So again, we don't check immediate memory separately. All the tests of attention and concentration, you will appreciate they are also in a way checking the immediate memory. But again, specifically if they ask you tell one test, then again you can go with digit forward test. Again, digit forward test. Then what is recent memory? Can anybody tell me? Very good. Recent memory का मतलब क्या होता है? Memory of the past few minutes, hours or days. Something happened, you know, few minutes back or few hours or days back. अगर आपको याद है, that means your recent memory is intact. So very important test which we do. Please highlight this. 24-hour recall method पिछले 24 hours में some events might have happened in the life of the patient and we ask those events. If the patient is able to tell, then we'll say कि patient का recent memory is intact. Very commonly we ask this question, beta, what did you had in your last meal? Suppose if I ask you, what did you had in your lunch today? And you'll be able to tell me what you had. Some might had chapati or maybe rice or dosa, anything. So that is your recent memory is intact. देखो, if I want to frame some new question from this, they may just ask you this, that a psychiatrist is asking a patient who came to meet you in the morning today. So again asking some events which happened today. So again I am again assessing what recent memory. And the last is remote memory. But what do you mean by remote? Remote means far. So remote memory means memory of the past few months or years. So here how we check remote memory? By asking some old personal information. You're asking a 70-year-old male name of his school, name of his school friend. So again what are we assessing? We are assessing his remote memory. Is it clear to everyone? Very good. So I hope all of you will be able to answer such question if they ask you what is being assessed. Right, let's finish the MSc part with this question. A psychiatry resident asks a patient similarity between a car and a plane. The patient replies that both have tires and both have windows. Can you tell me which of the following function is being assessed here? Are we assessing abstract thinking, test judgment, insight or remote memory? Very good, yes. So we are in fact assessing his abstract thinking. देखो abstract thinking का मतलब क्या है? Ability to form concept or ability to understand hidden meanings. हमने पेशेंट से पूछा, tell me the similarity between a car and a plane. So what is this test known as? This test is known as similarity testing. So I'm asking similarity between two objects. Now can you appreciate if I ask you the same question, what will you tell me the similarity between a car and a plane? Can anybody tell me what would be the similarity? You will say, sir, both of are mode of transport, isn't it? So one is, you can see the functional similarity. You will see, sir, both are means of transport. So you are able to understand the larger similarity. But here, can you appreciate the patient is only telling the structural similarity, that both have tires, both have windows, both have seats. So here, can you appreciate that abstract thinking is present or absent? Here we can say that abstract thinking is impaired. Remember, abstract thinking when is impaired, it is known as concrete thinking. So please remember this very important point, कि if the abstract thinking is impaired, like in this case, it is known as concrete thinking. Concrete means superficial. He is not able to go deeper into the meaning. And where you may find concrete thinking can be seen in condition like schizophrenia. Another test, so this was one test. Another test to assess abstract thinking is proverb testing. But what is proverb? Proverb means muhavre. So we ask meaning of a proverb. Again, proverb, they have a hidden meaning. Suppose if I ask you, tell me the meaning of this proverb that pen is mightier than sword. I'm sure all of us must have heard this, है ना? कलम की ताकत तलवार की ताकत से ज़्यादा होती है. What is the meaning of this proverb? You will say, sir, that means that knowledge is more powerful than muscle. But one of the patients says, sir, I'll tell you the meaning. This means if I'm fighting with someone and I'm holding a pen, other person is holding a sword, I will win because I'm holding a pen. Does this mean this? No. That means he's not able to understand the deeper meaning. Here again I can say that the abstract thinking is impaired. Again, impaired abstract thinking is known as concrete thinking. Is it clear to everyone? Very good. Next is judgment. Judgment means ability to take the right decision based on the circumstances, and there is one judgment known as test judgment. But as the name suggests, test matlab I am taking a test. I will give a situation, an imaginary situation, and ask the patient what he will do. Suppose I ask this fire problem. I ask a patient, what will you do if the neighbor's house catches fire? अगर neighbor के घर में आग लग जाए तो क्या करोगे? So I am asking what he will do in this imaginary situation. Some of us may say, sir, I will call the fire brigade. I will try to help the neighbors. Patient says, sir, you know what I will do? I will pour kerosene in the fire. So tell me, test judgment here is intact or impaired? You will say, sir, test judgment here is impaired. Again, remember, it can be impaired in conditions such as schizophrenia, or remember in psychosis. So remember, in condition like psychosis, it may be impaired. Then what is insight? I am sure all of us know what is insight. Beta, insight means awareness of illness. So in psychiatry, sometimes you will see that patient, they are not aware of this of their illness. So they may say, sir, I am fine. I think my family members are abnormal. You treat them. But actually the problem is with the patient. So that is insight. So we'll discuss this classification. In fact, we talk about neurosis and psychosis. So can you tell me where insight is present and where it is absent? Neurosis mein insight is, you will say sir insight is present, while in psychosis insight may be absent. So please remember, and remote memory we've already discussed how to assess. So here the answer is abstract thinking. So we have covered some important headings of MSc. Again, very important, thought, perception. These are some very important areas, and you will see a lot of questions being asked from this. Now let's talk about the disorder. So let's discuss this classification. It's an old classification, but I always discuss this because it helps us understand the topics really well. See, nowadays we have two current classification. One is DSM-5 and another is ICD-11, which is giving us the criteria how to make a diagnosis. But in olden days, psychiatric disorders, were divided into these two important headings. One is organic, another is functional. What do you mean by organic? Organic means when there is a visible cause, when the cause is visible. For example, delirium. Like we'll discuss delirium, again it could be because of multiple causes. For example, patient has infection in his body, in his brain, or somebody had a head injury, or cases of hyponatremia, sodium levels are low, below 130. You'll see sometimes patient may present with certain psychiatric symptoms. And even dementia, in fact we'll discuss sometime. You will see in dementia, like in Alzheimer's disease, most common cause of dementia we know is Alzheimer's disease, right? So Alzheimer's disease we may see that there is atrophy of the brain, so you can see the cause. So that is organic. Functional means, so this functional term was used when there is no visible cause. See, I am not saying that there is no cause, but usually the cause is not visible. Like a patient with schizophrenia or depression, when we do routine tests, we may not find any cause. But of course, nowadays we say nothing is functional. There are some cause. It may be at a very, very micro level, but there are causes. So nothing is functional, but earlier times they were known as functional disorders, no visible cause. And they were further divided into neurosis and psychosis. Again, let's see the difference. Tell me, insight is present where and absent where? Neurosis mein insight is present. Usually psychosis mein we say insight is absent. We have already discussed judgment is usually intact in neurosis and impaired in psychosis. Now tell me, very important, delusion, hallucination. But again and again we are saying that these are psychotic symptoms. So remember, usually they are absent in neurosis, present in psychosis. Reality testing. Reality testing means touch with reality. Whether you are able to differentiate what is real, what is unreal. Remember, reality testing is usually intact in neurosis, and remember it is impaired in psychosis. So in psychosis, the person may not be able to differentiate what is real, what is unreal. So sometimes you will see question being asked like this. So they may give you a neurotic disorder and they may ask you which of the following statement is false. And one of the option is that reality testing is impaired. So remember, in neurosis usually reality testing is present. So that is why this classification is very important. Can you tell me some examples of neurotic illnesses, some examples of neurosis? So let's discuss some important condition like anxiety disorders. We'll discuss even OCD, somatoform and related disorders we'll discuss. These again, they are neurotic disorder. Even to an extent, mood disorder may be considered as a separate entity, but in mood disorder, depression may have symptoms very similar to neurosis. But can you appreciate, sometimes patient with depression may also develop delusions, hallucinations. So that is known as psychotic depression. So that is why you can appreciate that this classification is not a very clear-cut classification. Sometimes disorders can, features can go from there to there. It's an old classification but very useful. Now tell me some examples of psychotic illness. So give me some examples of psychotic illness. One of the example you can say, sir, schizophrenia. Then other example like acute psychosis, even disorder like mania. Again, mania, you call it mania or bipolar disorder. So again, that has characteristic of psychosis. So remember this classification. One is, it will help you solve question, and also when we'll read the disorders, when you'll understand the disorders, but always try to understand. We'll talk about organic disorders, we'll discuss psychotic disorders, we'll discuss mood disorder, and then we'll discuss neurotic disorders. So in your exam, if you have this classification in mind, you'll be able to solve and understand various topics. So very important to understand this classification. I hope this is clear. Let's now discuss this question. So let's now talk about the disorders. So answer this question. A 65-year-old male was admitted for knee replacement surgery. On the second post-operative day in the hospital, he started saying irrelevant things and would continue to say that he is at his home. He would appear irritable and would sometimes try to remove the catheter. Tell me the diagnosis. So can you appreciate here the symptoms have started suddenly. All these 4 options, they may start suddenly, you may see. Now tell me what is the answer and also tell me why. So what is the answer? Is it acute stress disorder? But I will discuss acute stress disorder. It has symptoms similar to PTSD and the duration is less than 1 month. And symptoms are similar to PTSD. We'll discuss when we'll discuss, PTSD. We know the symptoms mahi, hai na? So it is not PTSD. It is not acute stress disorder. Tell me what is the right answer. It is not mania here. It is not acute psychosis here. The answer is delirium. Very good. Very good. Can you tell me now, just tell me why you have chosen delirium as the answer. Tell me why it is delirium. So delirium and acute psychosis, they are very close differential diagnosis of each other in fact. Can you tell me how you have, how we have chosen the answer to be delirium? Very good. Tell me. Anybody? Why it is delirium? Yes. Very good. Now you're saying yes, it is delirium. Can you tell me one important point? See, I'm trying to highlight the keywords because I want you should know how you have reached to this conclusion. Very important. It is delirium. We'll discuss delirium. It has sudden onset. So we are talking about organic mental disorder or neurocognitive disorders, right? So there is acute onset, like in this case, they may give you certain risk factors. So there may be certain risk factors. For example, they may give you a surgical illness, or they may tell you patient in the post-operative period, like in this case. So they may give you this classical history. They may give you some medical illness. This classical history may be present. But why we have chosen delirium? Very good. Yes, because see, this patient is in the hospital, but he's saying I am at my home. So what is this important symptom? You can see here, there is impairment of consciousness. Very good. So let's talk about neurocognitive disorders, or organic mental disorder. It's a new term in both DSM-5 and ICD-11. So first is delirium. Now in delirium, please remember, there is impairment of consciousness. Awareness of self surrounding is impaired. And I'll give you 4 points. Any of those 4 points if mentioned in the question, that will tell you that patient ka consciousness impaired hai. Remember it with the mnemonic ACDC. A is altered sensorium, or they may tell you that there is clouding of consciousness. In the clear sky of consciousness, up clouds aa gaye, that consciousness is not clear. Or they may tell you D for disorientation, to time, place and person, or they may just fit this term confusion. Patient has confusion. So this is telling you that there is impairment of consciousness. Think of delirium. Very important. Can you appreciate here? The patient is saying I am at my home although he is in the hospital. So this is telling us that there is impairment of consciousness. See, it's a neurocognitive disorder. So यहाँ पे consciousness भी impaired है and cognition is also impaired. So patient also has cognitive impairment. So patient may have impairment in his memory, language, even perceptual abnormalities may be there. Can you tell me which important perceptual abnormality may be seen here? See, this is an organic mental disorder we discussed now. Perceptual abnormality may, can you tell me an important perceptual abnormality which can be seen here? Such as visual hallucination. And we discussed in organic mental disorder, most common hallucination can be visual hallucination. So this patient may report of seeing someone in the room when no one is around. So again, such hallucination may also be seen. So remember, both consciousness and cognition are impaired. Sudden onset you will see, and there may be some risk factor, they may tell you it's an elderly patient and some risk factors may be given. Now also remember, when we will see this patient delirium, we'll try to see the cause. So there may be so many causes, we'll try to find the cause and treat. Also tell me, when we do EEG in this case, can you tell me, so any patient, having delirium, cause can be any, it could be infection, it could be trauma, patient is having delirium. Can you tell me what will be the finding in EEG? What is EEG? Electroencephalogram. So remember, in EEG, what will be the finding? There will be diffuse slowing of the background cortical activity, diffuse slowing of the background cortical activity. Okay, remember this point, but there is one important exception. Can you tell me what exception I am talking about? Except one important cause of delirium. So remember, even alcohol withdrawal can cause delirium. That is known as delirium tremens. So alcohol withdrawal delirium, that is delirium tremens, may usually there is fast activity. If they want to ask a new question, such questions may be asked. So please remember this. Even benzodiazepine withdrawal se jo delirium hota hai, you will see there may be fast activity. So please remember this point. Also there is a assessment tool, one important assessment tool, remember CAM. So this question was asked once in one exam, confusion assessment method. Dekho, even if such new question come na, confusion assessment method is used for which condition? So in psychiatry, always try to read the name carefully. You may reach to the answer. Tell me, if they ask you confusion assessment method is used to assess, options are mania, depression, schizophrenia, delirium. See, even when you see this term, confusion we know can be seen in delirium. So remember, it is used to assess delirium. Very good. Now in the treatment, when we talk about the treatment of delirium, please remember we will treat the cause. So treatment is you treat the cause. We know that delirium is a medical emergency, but it is reversible. You identify the cause and you treat the cause, you will see that the symptoms would improve. Most of the cases it is reversible. If they ask you in the management, tell us the drug of choice or what are the drugs which you will use in the management of delirium. See, in delirium, patient may be very agitated. Patient may have delusions, patient may have hallucination. Like in this case, can you appreciate he is removing the catheter? Patient is very agitated. So tell me what drug you can give in such scenario. So can you tell me what drug can you give in this scenario? Patient is very agitated or there is delusion or there is hallucination. Please remember. So if they ask you the drug of choice, then you can go with antipsychotics. Now there are various antipsychotics. If one drug they ask you, remember it is haloperidol. Haloperidol is the most common antipsychotic which is used. Even olanzapine and other drugs can be used. So please remember, if they ask you out of the antipsychotic, remember most commonly the drug used is haloperidol. Also remember, when we talk about giving benzodiazepines in delirium, see, delirium may we say that already the patient has altered sensorium, consciousness is impaired. Benzodiazepine, we know they are stimulant or they are CNS depressant. They are CNS depressant. So remember, benzodiazepines, you know, it's a double-edged sword. They can even worsen delirium. So one has to be very careful when we are using benzodiazepine. Yes, sometimes we can give benzodiazepine, low doses we can give benzodiazepine for symptom like agitation. Can anybody tell me benzodiazepines are the drug of choice for one particular delirium? So please appreciate this question. एक question है the drug of choice for delirium. I am asking you any particular cause of delirium जहाँ पे benzodiazepines are the drug of choice. Can you tell me what is the right answer? Remember, so can you answer? In one particular cause of delirium, benzodiazepine are the very good. Yes, delirium tremens. We'll talk about this. देखो, delirium tremens is an alcohol withdrawal, symptom, and we know in alcohol withdrawal drug of choice is benzodiazepine. वहाँ पे you can prefer benzodiazepines. So these are two separate questions, right? And also remember one important differential diagnosis. देखो, acute onset है, fever की history है, delusion hallucination है. So tell me one important differential diagnosis. Patient को acute onset of symptom है, delusion hallucination है, fever भी दिया हुआ है. देखो, usually you will think कि sir fever may be associated with some organic condition. But remember one important differential diagnosis is acute psychosis. देखो, acute psychosis we will discuss, patient has symptoms of schizophrenia but duration is less. So in acute psychosis, patient has delusion, hallucination, sudden onset and fever की history can be given. So it's a close differential diagnosis. How will you differentiate? Tell me delirium and acute psychosis. Again, one important point is consciousness is impaired. But see this question, अगर यहाँ पे consciousness impaired नहीं दिया होता, then would have thought of some other possibility. Is it clear? So here the answer is delirium. I hope this is clear to everyone. So this is delirium. Let's discuss another important neurocognitive disorder, that is dementia. Again, you will see many questions nowadays being asked from organic disorders, and dementia is a very important topic. Now see this, we said that in delirium both consciousness and cognition both are impaired, but in dementia, remember, the consciousness is intact. Usually the consciousness is intact, it is the cognition which is impaired. So in dementia there is in fact progressive cognitive impairment. So you may read this even in neurology also, these terms. So let's discuss these terms. One is, they may tell you that patient has amnesia. But what is amnesia? Can you tell me what is amnesia? Amnesia means there is impairment in the memory. Okay. What is aphasia? What is aphasia? There is problem in the language. So patient is not able to use words properly. There is word finding mistakes are there. What is apraxia? Praxia means movement. So what is apraxia? There is problem in fine movement. Learn fine movements. There is impairment. Patient's family member report that person is not able to open or unbutton or button his shirts. He is not able to tie and untie the shoelaces. He is not able to use a pen. He is not able to use a laptop. So can you appreciate the fine movements they are lost? So that is apraxia. What is agnosia? the person is not able to identify, object. In medicine, in CNS examination, you do this, you show some object, like you show this pen, person is not able to identify. So that is agnosia. Sometimes person is not able to identify faces. Can you tell me what is the term we use when the person is not able to identify? Very good, yes. That is known as prosapognosia. Sometimes when you read such terms, see this, in the end agnosia is coming. So you will see some clues. If they want to ask some newer terms also, please read the options carefully. There will be some clues in the question. So patient is having cognitive impairment. So dementia mein kya ho raha hai? Patient is having only cognitive impairment. Then let's complete this table. Then we'll also talk about few points about dementia. Before that, there is something known as amnestic disorder. Please appreciate this transition. देखो, can you now tell me amnestic disorder में क्या impairment हो रही है? Very good. There is only one impairment, that is there is just memory impairment. Out of the cognition also there is just impairment in the memory. There are so many causes of amnestic disorder. CNS causes हो सकते हैं. There can be systemic causes. Can anybody tell me one important alcohol induced amnestic disorder? What is the term? What is the term we use for alcohol induced amnestic disorder? So we'll discuss two important neurocognitive disorders associated with alcohol. One is Wernicke's, another is Korsakoff. Very good. Korsakoff. So when we talk about Korsakoff syndrome, so you will say in Korsakoff syndrome, what is the important impairment? Remember, in Korsakoff, important impairment is impairment of memory. Very good. Very happy. Yes. So let's now discuss this table. Let's focus, some time on dementia. Let's answer this question. It's a PYQ. It's a INI-CET ka PYQ. So they have asked many questions from this topic of dementia. देखो, dementia usually we say it's a progressive condition. है ना? There is progressive cognitive impairment, but there are around 10 to 15% of cases which are reversible. So tell me, which of the following are reversible causes? Very good. NPH is reversible or irreversible? It is reversible. Hyperthyroidism, again these are reversible. Beta, Lewy body dementia, it is irreversible. So it is one of the neurodegenerative causes. And deficiency such as vitamin B12, again it is reversible. So the answer is A, B and D. So please remember. So let's discuss this table. So let's talk about some causes, reversible causes hain. This question has been asked. So they may ask you in a clinical way also. So let's talk about some neurosurgical causes like SDH, subdural hemorrhage or hematoma. So they may give you a case, patient had a head injury. They may also give you a image, brain scan also they may give you, and they may also give you that there is cognitive impairment and it is reversible. So subdural hemorrhage, patient is having any brain tumor or brain abscess, you treat it, the dementia is reversed. So again these are also causes. What is NPH? Can you tell me what is NPH? Normal pressure hydrocephalus. It has a triad, Hakim's or Adams triad. Sometimes we use cognitive impairment, gait abnormality, there is a magnetic gait, and urinary incontinence. So NPH. So they may just ask you, what investigation would you like to do in a patient who is come to you with dementia? Would you like to do a brain scan? Yes, we will try to rule out some of these causes, because usually we know dementia is progressive, but there are some causes which are reversible. You treat them, dementia is reversed. Now infections are also there, such as encephalitis, meningitis. You treat them, dementia may be reversed. In metabolic, very important, this is very important. So we've already covered. If I ask you one important deficiency, very good, that is deficiency of vitamin B12. But even other causes like niacin, folate, B1, thiamine, these can also cause reversible dementia. Would you like to do a vitamin B12 test in a patient who has come to us with symptoms of dementia? Yes. We'll try to rule out some of these reversible causes. Also in the endocrinal causes, remember, if one they asked hypothyroidism, even other like hyperthyroidism, even hyperparathyroidism also, you can see patient may have reversible dementia. Can you tell me an important substance? Patient एक substance consume कर रहा है and chronic use of that substance may lead to dementia. You tell the patient to stop that substance, dementia may be reversed. Which substance I am talking about? Can you tell me the substance? Very good. So please remember, even alcohol can cause reversible dementia. Let's answer this question. This is a very important topic and I want all of us to answer this question. A 70-year-old female brought by the family member, she is having difficulty in doing activities of daily routine. So somewhere it seems that there may be some cognitive impairment leading to problems in activities of daily living. Patient is also having visual hallucinations and there are also symptoms of rigidity, bradykinesia. Lewy body is present in the patient. Which of the following is incorrect about the condition? Okay. So let's try to answer this question. So tell me first what diagnosis you are thinking about. What is the diagnosis you are thinking about? So there are two, I think, two important differential diagnoses of this condition you might be thinking about. Can you tell me first what diagnosis you are thinking? One of you are saying Parkinson's, very good. Before Parkinson, any other also condition which is giving you all these symptoms may be present in one more important condition we discussed, very good, Lewy body dementia, and one is Parkinson disease dementia, very good. So these are two close differential diagnosis of each other, Parkinson disease dementia, right? So let's try to see. First let's talk about this, we can also divide dementia into cortical and subcortical. Again, very simple question like this may be asked. In cortical dementia, tell me some example. One is Alzheimer disease and another is PIC disease, also known as frontotemporal dementia. So नाम से ही पता चल रहा है, this question in fact was asked in the INI-CET that PIC disease is cortical या subcortical. नाम से ही पता चल रहा है it is frontotemporal dementia. So frontal and temporal lobes are usually more involved. So it is again a cortical dementia. Then some of the other causes like Parkinson disease, Huntington disease, multiple sclerosis, Wilson disease, PSP, progressive supranuclear palsy. These you will read in neurology, you must have read in neurology that patient may have a lot of motor abnormalities. But here also patient may develop cognitive impairment, and these are causes of subcortical dementia. So please remember subcortical dementia. Now can you appreciate in these subcortical dementias, usually a lot of motor abnormalities may occur initially. So can I say why motor abnormalities are seen here more? So we can say motor system usually may be normal here in the beginning and abnormal here in the beginning. Later on, even in cortical dementia also motor abnormalities can begin. But in subcortical dementia, can you appreciate that patient may present with some motor abnormalities maybe from the beginning? Why? Because areas such as basal ganglia, these areas getting affected first. So this is again an important point. Sometimes they may just ask you that patient started with some motor abnormalities and gradually also developed cognitive impairment. And they may ask you which is the dementia. They may give you 4 options and one of them is subcortical dementia. So please be very careful. Okay, so remember most common overall dementia. If I ask you the most common overall cause of dementia, you will say it is Alzheimer disease. Alzheimer disease. Can you tell me the second most common cause? Can you tell me what is the second most common cause of overall cause of dementia? Please remember now the answer is Lewy body dementia. Third you can say vascular dementia. Third you can say vascular dementia. Now tell me Lewy body dementia, vascular dementia, they are cortical or they are subcortical? They're cortical or they're subcortical? You can say, so these are mixed. Both cortex and subcortex may be involved from the beginning. So please remember, okay. So sometimes such questions are asked. Now let's talk about Lewy body dementia, Lewy body disease. It's a very important topic. Please remember this. Now Lewy body dementia or Lewy body disease. So there are 3 core features. One more has been added. So please be very careful. This can come as a new question. And how do we remember? So I gave you a trick. Suppose there is a person, Mr. Lewy, he goes for an interview and the interviewer asks Mr. Lewy, show your CV, Mr. So show your CV, MR. So what is C for cognition is impaired and the cognition is fluctuating. So there is variation in attention, alertness. So there is cognitive impairment is then that is fluctuating. But we have already talked about hallucination. One important hallucination is most commonly in organic is visual. See here it is in the core criteria. So remember V for visual hallucination. M for motor features of Parkinsonism. Remember it's a mixed dementia. So it also has features of the subcortical dementia. So patient may also have tremors, rigidity, bradykinesia. And R, please highlight this, very important, even REM sleep behavior disorders can be seen. So very important, REM sleep behavior disorder can also be seen. See, normally in REM there is atonia. No? We'll talk about this when we'll talk about sleep disorder. That जब हम REM में होते हैं, our muscle is in a state of paralysis. But what if this atonia is not achieved? So person is having dreams and person may start enacting in his dreams. Patient may have punching, kicking movements. Usually REM में person is in a state of paralysis, but यहाँ पे person may have such movements. So this is REM sleep behavior disorder. So please remember it's a very important point which can be asked. Also, there are certain supportive features. For example, severe neuroleptic sensitivity. Neuroleptic means antipsychotic. So patient may be having certain, EPS can occur. So certain side effects may occur because of antipsychotics, this patient may be more sensitive to these side effects like EPS. We'll discuss some of the important EPS. Person may have some other supportive features like there is repeated falls, syncope may be there, there may be transient loss of consciousness, severe autonomic dysfunction can occur, even hyper or hyposomnia, hallucination in other modality. Please remember systematized delusion like delusion of persecution, and see this Capgras syndrome. Sometimes patient may present to us with Capgras syndrome and आपने डिटेल में हिस्ट्री ली, एग्जामिनेशन किया, and you see that patient is actually having Lewy body disease. So please remember, they may just ask you Capgras syndrome is seen in. So again, this may be initial presentation in Lewy body disease sometimes. Even other symptoms like depression, these can also be seen. So please be very careful when they give you such supportive symptoms features in the history. They may be asking about Lewy body disease. Also remember, in the FDG PET scan, there may be hypometabolism in the occipital region, and there is relative sparing of the posterior cingulate cortex like in this scan. So what is this known as? This is known as posterior cingulate island sign. So this may occur initially, later on this may also be lost. In fact, initially if it is present, it may sometimes help us to differentiate it from Alzheimer's disease. Also in the pathology, now when you see microscopic examination of the patient's brain, so the name is telling you what finding you will see in the pathology. Can you tell me what are the findings you will see in pathology? Name is telling you, Lewy body. So please remember, such Lewy bodies can be seen. These are alpha synuclein deposits. See this, how a Lewy body look like. There is a central core, pinkish core, and it is surrounded by a halo. So sometimes they may just ask you this. So please remember this, very important. Now also remember, we just discussed. So in this scenario, in this question, see, most likely the options are telling me that they're talking about Lewy body, disease. So you have to choose which of the following is incorrect. Capgras syndrome may be the part of presentation, it is true. REM sleep behavior disorder can be seen, it is true. Repeated falls syncope is a core feature. Is it a core feature? No, it is a supportive feature. Posterior cingulate island sign can be seen on FDG PET, yes. Now also, can you tell me how will you differentiate? Sometimes we can differentiate clinically between Lewy body disease and Parkinson disease ka dementia. So both have similar features. Can you tell me how you can differentiate them clinically? This question was asked, in fact, एक बार they gave a similar history जो हमने यहाँ पे discuss की है, और उन्होंने diagnosis पूछा था, and diagnosis में option was Parkinson disease. Lewy body तो option में ही नहीं था, Lewy body disease. So that answer was Parkinson disease. But how can you clinically differentiate? Can you tell me? Can you tell me? Right, I appreciate, thank you. It was useful, I am very happy. Now tell me, बेटा Lewy body disease और Parkinson disease dementia में कैसे डिफ्रेंशिएट करोगे? देखो, पार्किंसन डिजीज डिमेंशिया हमने डिस्कस किया ना, ये सबकॉर्टिकल है, तो यहाँ पे मोटर फीचर्स होंगे पहले, मोटर सिम्टम्स आर प्रेजेंट फर्स्ट फॉलोड बाय कॉग्निटिव सिम्टम्स, एंड इनफैक्ट इन द रिसर्च क्राइटेरिया वी टेक दिस 1 ईयर का ड्यूरेशन, कि मोटर सिम्टम शुरू होने के आफ्टर 1 ईयर कॉग्निटिव सिम्टम बिगिन. वाइल इन Lewy body dementia, the cognitive symptoms are present initially and motor symptom may be present initially or may occur afterwards. So sometimes this clinical history may help you differentiate between the two categories. I hope this is clear to everyone. But please answer this question, a very important topic, and you will see even recently a question was asked from this topic. So I'll discuss some newer points also. An elderly patient with Alzheimer's disease is unable to tolerate medications orally. So I'm giving, we are giving oral medication, but he's not able to tolerate them. Which of the following acetylcholinesterase inhibitors can be used? So patient को कौन सा drug दोगे बेटा? Again, very good. So the answer is, so we know memantine is not a acetylcholinesterase inhibitor, so that is out of the question. Which you will use? Very good, yes. Why rivastigmine? Very good. So we are giving orally, but patient को, let us say GI symptoms हो गए, that is a possibility. Why you are giving rivastigmine? Because it is also available as transdermal patch. Very good. So please remember this point. So it is also available as transdermal patch. So in fact, see this, in the treatment of dementia, always correlate the etiology and the mechanism of action. देखो, we know that there is decrease in the acetylcholine, so we are giving a drug cholinesterase inhibitor. But what is this cholinesterase inhibitor doing? Normally we know acetylcholine is broken down to acetylcholine plus acetyl-CoA plus choline by this enzyme. हमने इस enzyme को inhibit कर दिया, we inhibited this, so क्या होगा? There will be increase in acetylcholine. So this is one of the drugs we use. So Tacrin is not much used nowadays. Can you tell me one important side effect? Very good. One important side effect of Tacrin, it is hepatotoxic. So please remember, it is hepatotoxic. Then we have also other drugs, donepezil is there, rivastigmine is there, and galantamine. As we have discussed that rivastigmine is also available as a transdermal patch. Dekho, since they have asked this question, also remember an important update. There is a new drug, a oral drug. What is the name of that drug? Remember, benzgalantamine. So it's a product of galantamine, and this is a oral drug. This is a oral drug which, remember, has very less GI side effects. So we know patient can have GI side effects. So this is one drug which is given orally which has less GI side effects. So if they want to ask a new question, this may also be a question which they may ask. Very good. Then we have another drug, mementin. Now please remember this, that in dementia like Alzheimer disease, initially glutamate. देखो glutamate क्या है? It is a excitatory neurotransmitter. So there may be excessive increase in glutamate which may cause excitatory damage. So mementin is a drug which is a NMDA antagonist. So please remember, this question was also asked. What is mementin? It is a NMDA antagonist. NMDA is basically a glutamate receptor. So हमने कहा कि glutamate increase हो रहा है, so we are using an NMDA antagonist. It can be used in moderate to severe cases, and this mementin can also be combined with these cholinesterase inhibitor like donepezil. So yes, combinations can also be given. So these are the drugs which are available in India. And usually we may start with cholinesterase inhibitor, and there is more severe symptom, we can also give mementin. Now there is a new class of drug, that is the monoclonal antibodies. Now please remember, when we talk about Alzheimer disease, one of the important etiological factor is there is A beta deposits. Now what are these monoclonal antibodies doing? Beta, they go to these A beta deposits and they help in the clearance. So please remember, so they go to these A beta deposits in the brain and they remove the A beta deposits from the brain. So remember, especially when they talk about these monoclonal antibodies, देखो these two drugs we can use even in other dementias, but where will you use these monoclonal antibodies? Can you tell me? Important condition जहाँ पे आप इन monoclonal antibodies को use करोगे in Alzheimer disease, especially they are approved in the mild cases of Alzheimer disease. And just remember the name Alzheimer disease and you can remember these three drugs. Remember the trick, Alzheimer disease. A say aducanumab. Can you remember the name? Yes, you can. So aducanumab, lecanemab, L say, and D say donanemab. So please remember, these are three important drugs approved for Alzheimer disease. And how do we give these drugs? Through IV route. So IV infusion say we give these drugs. Now also remember, one important side effect which can occur is ARIA. What is this? ARIA, amyloid related imaging abnormalities, can occur when we give these drugs. So that is why repeated MRI scans are done when these drugs are given. So remember this term, INI-CET is very notorious in asking such terms also, such questions also. So please be very careful if they ask this term. Okay, I hope this is clear to everyone. Right. Now also we know that patient, so we talked about managing the cognitive symptoms. The patient having dementia may also have certain other symptoms. There may be neuropsychiatric symptoms or behavioral symptoms. So remember, for agitation, delusions, hallucination. So a patient with dementia may be very agitated, may have delusions, may have hallucination. We know in the drugs we can give antipsychotics, but before giving antipsychotics, we can also use the non-pharmacological approach. And remember this important acronym DICE. So suppose a patient is very agitated in dementia, so we can use this non-pharmacological approach. Remember DICE. D say hai desirable, describe the problematic behavior. Suppose the patient is shouting, is agitated. I say investigate the cause, rather than just giving antipsychotic, first try to find out why he is agitated. Suppose, he is agitated because he is having dementia, he is not able to find his way to the washroom and he is, the urine is getting passed out in his clothes only. So when I have identified the cause, then C say create a plan. So what you can do is you can repeatedly, after repeated interval, take him to the washroom. And then again E for evaluate, see if this plan is working or not. So rather than just jumping to the drugs, try to use non-pharmacological treatment. So remember this acronym DICE. So very important, I'll give you these acronyms. So please remember this. Now also, can anybody tell me that usually a patient with dementia may not be aware of his deficits? For example, patient is not able to remember things. Family members are saying, sir, he is not able to remember things, but patient says, no, sir, I remember everything. So patient may not be aware of their deficits. But sometimes, person may get aware of those deficits, that, oh my God, I am forgetting things. and the person may become very agitated, may become very restless. There may be a very increased reaction. Can you tell me what is that reaction known as? Can anybody tell me what is that reaction known as? So normally patient with dementia may not be aware of the deficits, but sometimes patient may gain insight of his deficits and may react in a very agitated manner. Can you tell me what is that reaction known as? Better remember that is known as catastrophic reaction. Okay, catastrophic reaction, please remember. Okay, so patient when is very having such agitated reaction, again try to use non-pharmacological methods like make the environment calmer. Try to use non-pharmacological method, and if required then we may use drugs like antipsychotics. So please remember, very good, it is catastrophic reaction, very good. So these were some important points about the neurocognitive disorders. Let's now discuss the next topic. So let's now talk about the topic of psychotic disorders, right? A patient of schizophrenia says Lord Hanuman was a celibate. Celibate means brahmachari. I am a celibate too, therefore I am Lord Hanuman. Dekho, please be very careful. Again I am saying it was asked recently in your exams. They are framing such new questions, and sometimes you may not be able to answer it in just one go. Read the options carefully, rule out the options. Is it loosening of association? Very good beta, nahi. Loosening of association में तो आपको कुछ समझ में नहीं आ रहा what he is saying. Verbigeration, there is senseless repetition of words. Is it neologism? Please remember beta, it's just play of words. Celibate is not a new word, it's an English word. It's not neologism, it is autistic thinking. Very good beta, autistic thinking means क्या होता है? What is autistic thinking? There is illogical thinking. So can you appreciate here the patient is not able to think logically, he is applying such a wrong logic in this statement that Lord Hanuman was celibate. I am a celibate, so therefore I am Lord Hanuman. In fact, can you tell me, when we talk about the history, we talk about 4 A's of schizophrenia. Can you tell me who gave these 4 A's of schizophrenia? It was given by Eugene Bleuler, and Bleuler was also the person who coined the term schizophrenia. Can you tell me the 4 A's of schizophrenia? What are the 4 A's? Very good, yes. Tell me. One is association disturbances, like there is loosening of association. Very good. Another A is, yes, abnormality of affect, like affective flattening. Very good. Tell me one more A. This one more A is autism, and one more A is ambivalence. Very good. Ambivalence का मतलब होता है unable to decide. So there is a pen on the table. In the mind, patient is thinking, should I pick it up or not? So he's staring on this pen for hours and hours. So also remember, so can you appreciate sometimes they may frame questions from these topics also. So please be very careful. Let's answer this question. So again a very interesting question. Such similar questions have been asked. So just answer this question, read it carefully and then answer. 30-year-old male reports of having stabbing sensations in his stomach for the past few months. So patient को कुछ sensations experience हो रही हैं. These sensations would occur intermittently in the daytime and would lead to a lot of distress. He told his wife to distance herself from the new neighbors, as he claims that they have hidden an electronic chip in their house which is sending signals and causing this pain. So can you tell me what is this? Very good. See, it is not thought insertion, it is not made feeling. So this made phenomena is again in the SFRS. In fact, all these are in the SFRS, Schneider's first rank symptom. Made feeling में क्या होता है? Patient को लगता है that feelings which he is having is not his own, somebody is influencing them. ठीक है, here the answer is very good. Here it is somatic passivity. But again see the name. I always say just remember the name. What do you mean by somatic? The term somatic means bodily sensation. Passivity का मतलब क्या होता है? We discussed this in the beginning now, that controlled by someone else, imposed by an external agency. For example, this patient says that I am having pain in my abdomen because aliens are sending radio waves. Okay, so patient को sensations हो रही हैं, bodily sensation imposed by an external agency. So this phenomena is somatic passivity. But what is delusional perception? देखो, don't read it delusion of persecution. When you are in the hurry, sometimes you misread the option. So this is delusional perception. Again, what do you mean by delusional? Delusional का मतलब patient के mind में delusion develop हो गया after experiencing a normal perception. That is delusional perception. Patient एक normal perception को delusional meaning दे दिया. Suppose patient goes in a party and he sees a spoon with a crown over it. है ना, ये एक normal perception उसने देखा उसके बाद उसको लगा that he is the king of the world. He stood up on the table and सबको बोला kneel in front of me, your king has arrived, I am the king of the world. So can you appreciate, एक normal perception को patient ने एक delusional meaning दे दिया. ये कौन सा delusion है? Can you tell me? हाँ है ना, हो जाता है, डोंट वरी. हाँ, सो प्लीज़ रिमेंबर दिस, इट इज़ डिल्यूजन ऑफ ग्रैंडियोसिटी. बेटा एनी डिल्यूजन कैन डेवलप. सो ये है delusional perception. In fact, this question was asked in the recent exam that whenever a person sees the birds flapping the wings, उसको लगता है God is sending him signal to run. So again, this is what normal perception को patient ने delusional meaning दे दिया. वहाँ पे आंसर क्या था? Delusional perception. Here the answer is somatic passivity. I hope this is clear to everyone, na? Very good. Now let's come to this question again. But please see this question. So we have discussed patient को 10 years से symptoms हैं. Family members report that any happy or sad moment occur at home, उसके कोई emotions नहीं दिखते. That means what is this phenomena we have discussed? This is flat affect. Patient also doubts that neighbor in disguise is actually his wife has been replaced by the neighbor. This कौन सी delusion थी? This was Capgras syndrome we have discussed, and also he is hearing voices, hallucinations भी हैं. So can you tell me the diagnosis here? Can you tell me what is the diagnosis? Very good. Here the diagnosis is schizophrenia. Very good. So let's discuss schizophrenia. So when we talk about schizophrenia, we remember it with the mnemonic, the movie's name, Dhadkan. So again, movie में किसी को schizophrenia नहीं था. Don't worry if you have not watched the movie. But the name of the movie will help you remember the symptoms. So remember D से क्या है? D से है delusion. Remember any delusion, है ना? Any delusion can be seen, but most common कौन सा है? Delusion of persecution. HA is hallucination. Again, any hallucination can be seen. Most common कौन सा है? Auditory. D से remember disorganized speech. जो disorganized thought हमने discuss किया था ना, formal thought disorders like loosening of association, all those like neologism, they can be seen. Next is C for catatonic symptoms and N for negative symptoms. We'll discuss what are catatonic symptoms and what are negative symptoms. See, negative symptoms क्या होते हैं? These are the negative symptoms such as anhedonia. Can you tell me what is anhedonia? Anhedonia is one of the negative symptoms. Anhedonia का मतलब होता है decrease interest. Patient का जिन चीज़ों में पहले interest था, that interest has reduced. Avolition, बेटा volition का मतलब होता है will power. Avolition मतलब there is loss of will. So family members report that he does not show motivation. Will power नहीं दिखाता to do anything. So there is decrease in will power. That is avolition. बेटा what is alogia? Now you will appreciate. बेटा neologism हमने पढ़ा था ना, neologism, logia मतलब word. So alogia क्या होगा? What is alogia? There is decrease in the speech. So family members say that he speaks very less. Then A for another is affective flattening. But again we discussed na, affective flattening or flat affect, decrease in expression. And asociality. Please don't confuse asociality with antisocial. What is antisocial? Antisocial में he is against the society. Asocial का मतलब है less social, socially withdrawn. So there is decrease in the socialization. So these are negative symptoms. But this question, if they ask you that affective flattening is which symptom of schizophrenia? Is it a affective symptom or is it a negative symptom? It's a negative symptom. Can you appreciate why we are calling them negative symptom? Because everything is getting minus, है ना, सब कुछ कम हो रहा है ना. So these are known as negative symptoms. I hope this is clear. Let's now come to this very important topic of catatonia. Now catatonia, basically these are group of motor signs and symptoms. Sometimes you will see that patient may have motor signs and symptoms. See, we are discussing catatonia under schizophrenia, but remember it can be seen in other conditions also. In fact, remember catatonia is more common in mood disorders than even schizophrenia. So sometimes you will see that patient with schizophrenia may have catatonic symptoms and there may be multiple of these motor signs and symptoms. Let's discuss them in groups. So one is stupor. But what is stupor? Stupor is decrease in the psychomotor activity. Psyche का मतलब mind, motor मतलब body. Patient की psychic and motor activity is very less. So patient may be just lying down on the bed. Hardly he is moving, hardly he is talking. When we talk about stupor in medicine, we use this term akinetic mutism. Sometimes this term. So stupor can also be seen in medical illnesses. So there sometimes you use this term akinetic mutism. Akinetic is not moving, mutism is not speaking. So there is decrease in the psychomotor activity. Sometimes you will see in catatonia, patient may be opposite, excitement. So there is significantly increase in the psychomotor activity. Very good. And what is mutism? Again, as the name suggests, when you watch television, sometimes you mute the television. So you can see screen is moving, but you cannot hear anything. So as if हमने patient को mute कर दिया. So patient is doing activity, but he is not speaking anything. So that is mutism. Next is waxy flexibility. Again, very interesting, very important. But see, waxy flexibility means flexible, flexible, or bending like a wax candle. Suppose this is a wax candle. So when you try to bend a wax candle, there may be initial resistance and after that you can bend the way you want. So this is waxy flexibility. Remember, initial resistance is seen in waxy flexibility. Also, sometimes you will see patient may maintain such odd postures for a long time in catatonia. So patient is standing on one foot for half a day. So patient may have such abnormal posture. So this could be catalepsy. But please don't confuse it with cataplexy. Cataplexy कहाँ मिलता है? Remember, it is seen in a sleep disorder, narcolepsy. So कैसे याद करेंगे? Narcolepsy में we don't get catalepsy, we get the opposite, cataplexy. So catalepsy, remember, is seen in catatonia, and another is posturing. Very good. But a worst में you will go with simple. Worst में ना simple would be a better answer. Then second would be hebephrenic. देखो दोनों में difference है. Catalepsy में it is passive. So passive means that somebody else made the person stand like this and now he is maintaining. While posturing का मतलब है active. That means person himself got into this posture and now he is maintaining. Now please answer this question. You know, sometimes there is confusion. Sometimes there is confusion. Suppose patient number A, I tried to move his hand. There was initial resistance. After that I was able to move the way I wanted. I removed my hand. Slowly his hand came down. तो ये क्या है? Tell me what is this? This is waxy flexibility. Patient number B, I was able to move his hand, no resistance, and जैसे मैंने hand यहाँ रखा, I removed my hand, he maintained this posture. So now what is this? ये है catalepsy. I hope this is clear to everyone. Please remember that in waxy flexibility you will see initial resistance is there. That is, it is known as waxy flexibility. Let's discuss the next two terms. One is negativism and another is automatic obedience. See the terms. But negativism means as if the person has become very negative towards the examiner. So he is opposing anything you tell him, he is opposing your command, or he is not doing anything. Suppose you tell the patient come forward, he goes backward. आप patient को बोलते हो आ गया हो, वो और पीछे चला गया. So this is negativism. Automatic obedience का मतलब है now he is showing extreme cooperation. But even if it is harmful for him, he is showing extreme cooperation. Automatically वो obedient हो गया. Suppose I tell the patient that I have a needle, I will prick your tongue with this needle. And I tell the patient now to pull out the tongue, but he will pull out the tongue. Even if I slightly prick, again I ask him to pull out the tongue, again he will pull out the tongue. So ये क्या है? Automatic obedience. Now he has become extremely cooperative. Next two terms, let's discuss them together. One is mannerism, one is stereotypy. दोनों में क्या हो रहा है? Patient is having some abnormal movements. Again the difference you can remember from the name. बेटा mannerism is made from the word manner ना. So यहाँ पे जो repeated movements हो रही हैं, they have a purpose, they are purposeful. For example, a patient is having this movement. Can you appreciate this has become repetitive, odd हो गई, but इसका purpose है ना, it's a salute movement. So ये क्या है? Mannerism. जबकि stereotypies, these are non-purposeful. Suppose a patient is having this movement, no purpose, repeatedly is having this. ये क्या हो गया? Stereotypy. Let's discuss the next two terms. One is echolalia. But echo means to repeat, lalia means word. So यहाँ पे क्या है? Patient is mimicking the speech, the examiner's speech. You ask the patient, what is your name? What is your name? What do you do? What do you do? ये क्या? echolalia. What is echopraxia? Again, just see the term. बेटा praxia भी हमने discuss किया था ना, means movement. Apraxia मतलब loss of fine movement. Echopraxia क्या होगा? Echopraxia means very good. Now the patient is mimicking the movements. Very good. Suppose you are writing with a pen and paper in front of the patient. Patient के पास ना pen है ना paper and he is just copying your movement. So this is what? This is echopraxia. What is grimacing? Nowadays when you take a selfie, what do? You pout. And if you maintain that pout for a long time, वो क्या है? Grimacing. Grimacing means patient has odd facial features. So patient has maintained odd facial features. And remember last is ambitendency. But अब होता है ambivalence, मतलब it was indecisiveness at the level of thinking. ये ambitendency है ना. So here the person has inability to decide a movement. Now at the level of movement there is indecisiveness. There is a pen on the table. Patient is staring on this pen for hours and hours, thinking in his mind, should I pick it up or not? ये क्या? Ambivalence. He takes his hand forward, then backward. फिर forward, फिर backward. He is not able to decide, should I pick it up or not? तो ये क्या हो गया? This is ambitendency. Now when do we say patient has catatonia? we say when a patient has 3 or more of these symptoms, then we say patient has catatonia. Is it clear to everyone? Very good. Now answer this question again. See this. A patient comes to us with voluntary purposeless movements. Okay, so there are purposeless movements. So there is stereotypy, patient has negativism and waxy flexibility. So can I say patient has catatonia? What is the most appropriate treatment? देखो, treatment of schizophrenia we'll discuss is antipsychotic, but patient को अगर catatonia है, what is the treatment of catatonia? Very good, yes. So tell me the answer. Yes, it is lorazepam. Usually again we can give IV, even IM oral can give one. So lorazepam, benzodiazepine we can give. Very good. Lorazepam is not working, there is not much response, then what we can use? Anybody? What we can do? We can also give ECT. So first line treatment would be lorazepam, but best treatment puche, then you can go with ECT, that is electroconvulsive therapy. I hope this is clear to everyone. Is it clear? Very good. Right, now let's talk about, let's complete this diagnosis of schizophrenia. So we have discussed all these symptoms. How to make a diagnosis? So according to DSM-5, see this, out of these 5, at least two or more symptoms, so minimum 2 symptoms should be present, but there is a catch that at least 1 symptom should be from first 3. But the first 3 symptoms कौन से? Delusions, hallucination, disorganized speech. At least एक इनमें से होना चाहिए and total में कम से कम 2 होने चाहिए. What is the duration for schizophrenia in DSM-5? Remember, it is 6 months. Remember, there are some differences between ICD and DSM. ICD-11 में what is the duration of schizophrenia? It is 1 month. It is 1 month. I hope this is clear, right? So see the symptoms. So the answer here is it is schizophrenia. है ना? Patient में negative symptom भी है, delusion भी है, hallucination भी है, duration they have given 10 years. In delusional disorder, please remember, patient has 1 or more only delusions. Then we will call it as delusional disorder. देखो, if patient has only delusions, can I make a diagnosis of schizophrenia? No. Because for schizophrenia, at least 2 of those symptoms are required. So then we will say it is delusional disorder. And acute psychosis क्या होता है? If symptoms are similar to schizophrenia like delusions, hallucination, disorganized speech, but duration is less. So that is acute psychosis. Now let's discuss a very important topic. Again you will see repeatedly they are asking question from this topic. So let's talk about EPS. Answer this question. A 45-year-old female patient diagnosed with schizophrenia, treated for 1 year with antipsychotic medication. So these are all important points for you. Patient reports of restlessness and has a rocking motion while sitting and is pacing around in the ward. What is the most likely phenomena here? Very good. I'm very happy. Yes, देखो. So वो बोल रहे हैं आपको कि patient subjectively भी report कर रहा है कि सर मैं restless हूँ, I'm restless. And objectively also, beta, he is having this rocking motion. He is pacing around in the ward. So can I say objectively be patient is appearing restless? So what is this EPS? Very good. This is akathisia, and what is the treatment of akathisia? Propranolol. Very good. So again remember this, we have been talking about, see, I hope all of us have read this table. Now we always talk about this. When we talk about schizophrenia, there are 2. So dopamine pathways में we know 2 important dopamine pathways beta which are related with symptoms. Mesolimbic dopamine pathway हम बोलते हैं in schizophrenia. There is increase of dopamine जिससे patient develops positive symptoms, that is delusions, hallucinations. And mesocortical pathway में because of decrease of dopamine, patient develops negative symptoms. So 2 pathways of dopamine, remember, are related with symptoms, and there are 2 dopamine pathways which are related with the side effects of antipsychotic. Let's discuss those 2 pathways also, because INI-CET is very notorious in asking these detailed questions. So let's just appreciate this. So there are 2 more dopamine pathways we'll discuss. One is nigrostriatal pathway. But please see this. It is from substantia nigra to striatum. So this pathway, in fact, let's use our knowledge of Parkinson disease. Now we know in Parkinson disease, there is decrease of dopamine in this pathway that leads to motor symptoms. So can I say if I decrease dopamine in this pathway, patient will develop motor symptoms? Now when I'm treating a patient with antipsychotics, we know antipsychotics, they are dopamine antagonist. So these antipsychotics will decrease dopamine in this pathway, and that will lead to motor symptoms which is known as EPS. Is this point clear to everyone? A very important point. I hope this is clear to everyone, right? And another pathway is tuberoinfundibular pathway. But tubero means hypothalamus to anterior pituitary. Now in physiology, you must have read that in this pathway, dopamine and prolactin are inversely related. Now I am giving a patient antipsychotic. Antipsychotic may also block dopamine in this pathway. तो antipsychotic ने जब इस pathway में dopamine को block किया, तो what will happen to prolactin? Very important, there will be hyperprolactinemia. Please remember this point. Sometimes they may just ask you one important endocrinal change because of antipsychotic causes hyperprolactinemia. In fact, some of the side effects which occur with antipsychotic like decreased libido in males and females. A female who is not pregnant, who has not delivered, but she comes with galactorrhea, milk secretion from the breast. Reports of amenorrhea. Again, it may be because of hyperprolactinemia. Please remember, and one important drug, which is one important antipsychotic, which is least notorious for causing hyperprolactinemia. Can you tell me one important drug starting with A? Remember aripiprazole. Please remember this drug. So aripiprazole is one of the drugs, one of the antipsychotics which is least notorious to cause hyperprolactinemia. In fact, sometimes it is used in the management of antipsychotic induced hyperprolactinemia. I hope this point is clear to everyone. So let's now talk about the EPS, and EPS we use this mnemonic DP at night. है ना? In medical colleges we have dance party at night. So D say remember dystonia. Dystonia means there is sudden contraction. Acute means sudden contraction of a group of muscle. It is the earliest to occur. You know, sometimes if you are giving parenterally, it may occur within few minutes of giving the drug. So suddenly there is a muscle contraction in a group of muscle. Patient may come with the eyes are rolled upwards. There is oculogyric crisis. Patient says my neck is twisted to one side. There is torticollis. There may also be laryngospasm. He is not able to speak or swallow. What is the drug of choice? Can anybody tell me, beta, what is the drug of choice? Answer this. What is the drug of choice of acute dystonia? What is the drug of choice of acute dystonia? Anticholinergic drugs. Please remember. So we are using anticholinergic drugs. So can I say that anticholinergic drug, that is muscarinic antagonist, can I say why we are using muscarinic antagonist? Because muscarinic antagonist drugs, they may increase dopamine in this pathway, nigrostriatal pathway. In fact, this question was asked in INI-CET, a few exams back. So remember this. So drugs like promethazine, benztropine, these drugs we can use. Remember P for Parkinsonism, drug-induced Parkinsonism. So patient may report of tremors, rigidity, there is bradykinesia. Very good. Again, tell me what is the drug of choice? Again, we can use anticholinergic drugs like here. We can even use oral drugs like trihexyphenidyl. A for, remember A for very important, akathisia. It is the most common EPS. तो यहाँ पे patient restless है. Akathisia का मतलब है restlessness. Subjectively, he will report I am feeling restless from inside. मुझे अंदर से घबराहट हो रही है, restless feel हो रहा है. And when you see the patient objectively also, you will see he is very restless. So this is akathisia. And what is the drug of choice? Very good. We can use beta blockers like propranolol. I hope this is clear. Let's discuss what is T. T for tardive dyskinesia. But tardive means long-term use. Dyskinesia, abnormal movement. So they may give you history. Patient is using drug for few months or maybe years. And there are some movements like perioral movement, lip smacking, chewing movement, tongue protrusion movement, or hand there may be coriform movement. Piano playing movement or pelvic thrusting can be there. Can you tell me what is the drug of choice? Very good. We will use VMAT2 inhibitors. So VMAT2 inhibitors, very good, like valbenazine, deutetrabenazine. In fact, this question was asked recently. And remember, N say very important, neuroleptic malignant syndrome. But when I say something is malignant, इसका मतलब ये benign है या serious है? It is life-threatening, NMS. So patient is on antipsychotic. So patient is on a dopamine antagonist, and they give you a history कि patient को high temperature है, increase in the creatine phosphokinase level, muscle rigidity है. So they may give you this classical triad. Patient may have other symptoms. For example, sweating hai, tachycardia hai, confusion hai, increase in the TLC may be there. There may be deranged LFTs. What you are suspecting? You are suspecting NMS. Now please remember, in the management, two important questions. Beta, one is what is the first step? Agar they ask you what is the first step, then you have to stop antipsychotic. It is life threatening. And if they ask you the drug of choice, can you tell me? Very good. The drug of choice, you can say dantrolene. We can also use dopamine agonists like amantadine, bromocriptine. So these are two different questions, so please be very careful. Question में patient has a history of taking antipsychotic and they may give you a clinical picture like this. So please answer the question accordingly. So यहाँ पे क्या है? Patient has akathisia and treatment is propranolol. I hope this is clear. Let's discuss few points about the antipsychotics. So we know that we have two important major classes of antipsychotics. One is the first generation या typical. Why we call it typical? Because it is D2 antagonist. And second is second generation or atypical. What is the atypicality? It is not just D2 but also 5-HT2A antagonist. Please remember this. How to remember? Both are 2. D2 hai and 5-HT2. Which A? We know which 2. 2A, 2B, 2D. Which 2? Remember A for atypical. So remember it like this. So please remember that atypical, they are not just D2 but also 5-HT2A antagonist. But the EPS, we know they occur because of blockage of dopamine receptors. So tell me which has usually more EPS? Remember, first generation has more and usually second generation has less EPS. Now we also have metabolic side effects. See, can you tell me some metabolic side effects with antipsychotics? Metabolic side effects like weight gain, like hypertension, like diabetes. There may be hyperlipidemia or deranged lipid profile. So remember, patient may have these metabolic side effects. And why these metabolic side effects occur? Please remember, this question was again asked in INI-CET. How to remember? Again, it occurs because of 5-HT. Which 5-HT2 receptor? Remember, C से है ना, metabolic 5-HT2C antagonism. Now remember which group of drug, first या second generation, has more metabolic side effect? Usually we say it is more with the second generation and usually less with first generation. But there is an exception which I will discuss. So please remember, some of the questions may be asked like this also. So let's talk about some drugs. Let's talk about some drugs. First we'll talk about few first generation antipsychotics. But first is chlorpromazine. Chlorpromazine, this question has been asked in INI-CET previously. The mechanism of action is D2 blockage, but it also blocks other receptors like alpha receptors. So if alpha receptors are blocked, what will be the side effect? So blockage of these receptors will cause side effects. What will be the side effect? Alpha receptors block हैं तो hypotension can occur. If muscarinic receptors are blocked, then anticholinergic side effects. Histaminic, H से क्या है? Histaminic receptors are blocked. So patient may report of sedation. Also, can you tell me another important side effect which can occur? Weight gain. Please remember this point. Weight gain. In fact, it has a moderate risk of weight gain. Very important point. It has a moderate risk of weight gain. Please see this. In this table we discuss usually metabolic side effect like weight gain will be more with the second generation. But there is one important first generation drug, remember, which has a moderate risk of weight gain. Moderate risk of weight gain, that is chlorpromazine. So please remember this. Chlorpromazine can cause moderate risk. And also remember, in the second generation, usually they have more weight gain risk, but there are some drugs which have low risk of weight gain. Low risk of weight gain. Can you tell me what are these drugs? Can you tell me what are these drugs? You can remember it with the mnemonic A to Z. What is A and what is Z? You have to tell me what is this drug A and what is this drug Z. A say, remember again, aripiprazole. Aripiprazole is one of the drugs. So it is one of the drugs which is a second generation, but it has low risk. Can you tell me what is this Z? What is this Z drug which we are discussing, which has again low risk of weight gain, a second generation drug, but it has low risk of weight gain? Very good, ziprasidone. Very good, ziprasidone. So please remember, so out of chlorpromazine and these two drugs, remember chlorpromazine has a higher risk of weight gain. So please remember some exceptions also. Now also remember chlorpromazine, C say chlorpromazine, patient may come to us, may have some ocular side effect like corneal and lenticular deposits. Now let's talk about thioridazine, another first generation drug sometimes asked in MCQs. Remember, R is coming in between. So this drug, it causes retinal pigmentation. One more R, remember, rise, increase in the QTC interval, and one more R, remember, retrograde ejaculation, even decreased libido. Now usually we discuss that first generation ka EPS risk is more, but it is one of the first generation which has less EPS. Can you tell me out of the first generation, beta, which has maximum EPS? Can you tell me which has maximum EPS? I'll come to olanzapine. Olanzapine, there are two drugs which have high risk of weight gain. Okay, I'll come to that. Tell me which first generation has maximum EPS. Remember, it is haloperidol. Very good. Now let's talk about a very important second generation drug, clozapine. But again, clozapine pe they had asked many questions. It's a second generation antipsychotic. It blocks D4 more than D2. EPS occurs because of blockage of D2. So it is one of the drugs second generation which has less EPS. Also remember, it is one of the antipsychotics which has anti-suicidal property. But remember, three drugs which have anti-suicidal property. One is this clozapine. Can you tell me other drugs? One is a mood stabilizer and one drug has antidepressant property also. So can you tell me, please remember, a mood stabilizer with anti-suicidal property, remember, is lithium, and a drug which is having antidepressant property which has anti-suicidal property, remember, ketamine. Ketamine, very good. Okay, as a modality, in fact, you can remember even ECT. ECT will discuss, can be used when patient is having suicidal thoughts. So please remember that sometimes question may be framed like this. Now, what is the use of clozapine? Dekho, clozapine is not used for every patient with schizophrenia. It is used for treatment-resistant schizophrenia. Now, what do you mean by treatment-resistant schizophrenia? That means if there is no response to at least two antipsychotics. बेटा पेशेंट को हमने ओलैंजापिन दिया फॉर एडिक्वेट डोज एंड ड्यूरेशन, नो रिस्पॉन्स. हमने देन पेशेंट को एक और एंटीसाइकोटिक दिया, नो रिस्पॉन्स. देन आई कैन कंसिडर क्लोजापिन. So that means it's a very effective drug, but still I'm not using it as the first drug because it has some serious side effects. Before coming to serious side effects, remember some common side effect. Most common side effect, remember, is sedation. Then other side effects like cyalloria can occur. Cyalloria or hypersalivation. This occurs because of decrease in swallowing. Now, before giving any drug to treat cyalloria, can you tell me one practical method, practical step? देखो, patient wakes up in the morning and patient says my pillow, my bedsheet are all wet because of this cyalloria. So he may be embarrassed. So can you tell me one practical method which you can tell the person? You can just ask the person to put a put a towel over the pillow before sleeping. Okay, so one practical method before starting any drug, we can use this. Patient can develop hypotension, but a weight gain. So there are two drugs which have high risk of weight gain. Two important antipsychotic, but one is clozapine and another is olanzapine. Okay, maximum agar puche, then go with clozapine. Olanzapine is also one of the antipsychotic which has high risk of weight gain. Also remember, clozapine, it can cause constipation because it also has anticholinergic side effect. I hope this is clear. These are some common side effects. Let's now discuss serious side effects which you can remember with the mnemonic SAM. But a patient on clozapine has developed abnormal jerky movements, a rolling of eyes, clenching of teeth, urinary fecal incontinence. What is this S? Remember, seizures can occur. What will you do? You can treat these seizures with anti-epileptic drugs and then you can again restart clozapine. A is very important, is agranulocytosis. What is agranulocytosis? Decrease in the WBC count, especially the absolute neutrophil count. If the counts are reduced, stop. You have to stop clozapine. So they may give you his clinical picture. Patient on clozapine comes to us, he's having fever, he's having sore throat, there is tachycardia. So this is suggesting us that patient has developed infection. Check these levels. If the levels are decreased, then we have to stop because it could be because of agranulocytosis. Patient, so in fact, this is such a serious side effect. This question was asked. We have to monitor these values, for the first 6 months, every week we have to check the counts. For the next 6 months, every 2 weeks, and then afterwards for every month we have to check these counts. So which serious side effect of clozapine requires close blood monitoring? Again, the answer is agranulocytosis. Patient is on clozapine, comes with chest pain, tachycardia, abnormal ECG. Again, myocarditis could be a possibility. Again, we have to stop. I hope this is clear to everyone. So I'm trying to give you a clinical picture. Usually they'll give you a clinical picture. Now let me discuss, I always ask these FQs. Suppose a patient on clozapine develops seizure, but which is one important anti-epileptic drug which you will not give in this scenario? Can you tell me? So this may come as a new question. Remember, clozapine, contraindicated. Remember, carbamazepine. Carbamazepine, we know it is one of the drugs which causes bone marrow suppression. So again, it is causing bone marrow suppression, clozapine is causing agranulocytosis, lethal combination. I hope this is clear to everyone. Also remember, in fact, this question was asked that usually when we compare carbamazepine and oxcarbazepine, it is more of a topic of drugs, but let me discuss here only. But usually when we compare carbamazepine and oxcarbazepine, side effects like bone marrow suppression, sedation, neurological side effects are more with carbamazepine than oxcarbazepine. Can you tell me one side effect which is more with oxcarbazepine than carbamazepine? This question was asked twice in INI-CET. Can you tell me one important side effect जो oxcarbazepine में ज़्यादा है as compared to carbamazepine? What is that? Very good. So hyponatremia. Very good. Yes, hyponatremia. Very good. Very good. This question was asked twice, है ना? Generally, we are seeing that देखो in NEET PG they are not repeating the question, but in INI-CET you will see still some of the questions are getting repeated. So please be very careful. Topics, questions may get repeated. Let's discuss a new question. So beta, now in fact we have a new drug. This is one of the latest antipsychotic which has been approved for schizophrenia. So which of the following statement is incorrect about xanomeline? Please remember this name, xanomeline. You have to tell me the incorrect statement. Very good. So tell me which of the following is an incorrect statement about xanomeline. It is approved for schizophrenia, I just told you. Yes. So in fact it is given with a combination of trospium chloride. So xanomeline, trospium chloride. Xanomeline, remember in the name M is coming na, so it is M1 M4 muscarinic agonist. देखो in schizophrenia na always correlate etiology with the mechanism of action of drug. So we know in schizophrenia the acetylcholine is reduced, so we are using a muscarinic agonist. Please remember LBR है ना, in the name L is also coming. It is not recommended for mild liver disease. So you have to tell me the incomplete which is the incorrect statement. A is correct. It is a M1 M4 acetylcholine receptor agonist, correct. Now it is combined with trospium. देखो why we are combining it with trospium? Because we want the effect in the brain, but there may be peripheral effects also, agonist effects. So we are countering it by giving trospium, which is a muscarinic antagonist. So in the peripheral tissues we are giving to counter those side effects. Is it safe in liver disease? No. This is the incorrect statement. So just remember this name, xanomeline. Remember in the name itself, remember this mechanism. Okay, if they want to ask new questions, such question may be asked. It's one of the latest antipsychotic. देखो, it's a antipsychotic which is not affecting dopamine. Okay, so it's a newer mechanism, so please be very careful. So these were some important points about the psychotic illnesses. Let's now discuss the mood disorder. See this. So again, it's a question which was recently asked in the exam. Which of the following is not included in ICD-10? देखो, हम बात करेंगे DSM-5 में and even in ICD-11. Now there are 2 core criteria, but ICD-10 में there were 3 criteria. But still, even if you don't know that classification, I'm sure you can answer this question. Which is not included in the core criteria of depression? Low mood, yes we know. Loss of interest होता है. Decreased energy is also one very important symptoms. यहाँ पे क्या आंसर है? Loss of esteem or confidence, that is not included. So let's now talk about mood disorders, and in mood disorder we'll talk about depression. But I hope all of us know how to make a diagnosis of depression. The mnemonic is SIGE CAPS, है ना? CAPS with double S. So one is sad mood. Patient has sad mood. The symptoms should be present for at least 2 weeks. So what is the minimum duration criteria for making a diagnosis of depression? It is 2 weeks. So patient ka mood is sad. Let us say patient for the past 2 months is sad. Most of the time, most of the places. What happens to interest in depression? The interest is reduced. So there is anhedonia. There is anhedonia. G for, remember, feeling of guilt or worthlessness. So patient has guilt or worthlessness. Thoughts are there. What happens to energy? The energy is also low. Loss of energy is there. Okay. And CAPS is C for concentration. But a patient ka concentration kam ho gaya. So patient may present to us with forgetfulness. Patient says, a young female, 30-year-old female says, sir, I am forgetting things. Now this is not true dementia. Remember, this is sometimes termed as pseudo dementia. So please remember, if they ask you pseudo dementia is seen in, it is seen in depression. You don't have to treat it separately. Treat depression, even that will be taken care of. A for appetite. But what happens to appetite in depression? Usually it is decreased. Patient says, sir, I don't feel hungry. So what happens to the weight? Even weight is reduced, but sometimes it can even increase, and that can even increase the weight. But normally, more commonly it is decreased appetite. P is psychomotor activity. Again, patient may have decreased psychomotor activity. Patient talks very slowly, walks very slowly, but in some patient it may even be increased. Patient may appear very restless in depression. S for sleep. Sleep again, usually patient may report I am not able to sleep, but some patient may report I am sleeping more than normal. And last S is suicidal ideation or suicidal thoughts. Patient may have suicidal thoughts or even may have suicidal attempts as well. So these are the 9 symptoms. How to make a diagnosis? We say, let us say this is the first and second symptom, 1 or 2. So out of the first 2, at least 1 should be present, plus 4 or more of the remaining symptoms for a duration of 2 weeks, then we'll call it as depression. But sometimes they may frame questions from this also. If I ask you, what is the key feature of depression? Can you tell me? The options are sad mood, decreased interest, decreased sleep, suicidal thoughts. Suppose I've given you 4 options. Can you tell me which is the key feature of depression? Remember, depression is a mood disorder. Mood disorder. See, from the diagnosis you will say, sir, 1 and 2, they seem to be key feature. But agar dono option mein present hai, remember it's a mood disorder na, so there will be abnormality of mood. Very good. Abnormality of mood is very important. Okay. So if they ask question like this, then you can go with low mood. If that is not given in the question, then you can go with anhedonia. I hope this is clear to everyone. Also, there are certain specifiers, but this table is very important. So many times you will see questions have been asked from this table. So let's discuss. So there are certain specifiers. So one of the specifiers is postpartum depression. देखो specifier का मतलब है, suppose a patient has depression, but there may be certain unique features also present. So we may add some specifiers. Like for example, suppose a patient has depression, 2 or more episodes of depression. Suppose presently patient को depression है, and patient gives a history कि sir 1 year back also I had a similar episode. So can you tell me what diagnosis you will make here? Will it be just depression or MDD, major depressive disorder, या कोई और diagnosis बनाओगे? So we will add some specifier ना, क्या ये सिर्फ depression है, MDD है या कोई और diagnosis है? अगर patient को 2 या उससे ज़्यादा episodes of depression हो गए हैं बेटा, so tell me what diagnosis would you make in this scenario? It will not be just MDD, you will call it as recurrent depressive disorder. है ना? So 2 or more episode में then answer would be recurrent depressive disorder या MDD recurrent type. Similarly, let's discuss a specifier that is postpartum depression. So since we are talking about postpartum depression, let's discuss some other abnormalities also related with pregnancy. Okay, so let's talk about what is postpartum blues. But in postpartum blues, see this, it may be seen in up to 80% of the females after their delivery. So it is, again, it may be commonly seen. इसका onset usually कैसा होगा? Onset may occur within 3 to 5 days, after the delivery, and symptoms may last for days to weeks. Usually symptoms transient or mild होंगे. So patient may have mild symptoms and transient, like sadness, tearfulness is there. Patient may have decreased sleep. Okay, so these mild symptoms occurring within few days after delivery. So you're thinking of postpartum blues. Would you like to give any specific treatment? But remember, only supportive care is required, not specific treatment, because ये transient है ना. After some time they will go away. So supportive care, reassurance is required. Now we have postpartum depression. See this, it is also not uncommon. 10 to 15% of the females may experience onset occurring within 6 weeks after delivery. So during pregnancy or within 6 weeks of delivery, the patient may develop depression. So then we'll call it as postpartum depression. But DSM-5 uses the duration of 4 weeks. So just remember 4 or sometimes even 6 weeks can also be taken. Now here, how will you differentiate postpartum depression from blues? Very important, look for these symptoms like suicidal thoughts, guilt, anhedonia. So these symptoms are telling you that now it is no longer blues. Patient has developed postpartum depression. Again, in the treatment we'll discuss, we can give SSRIs, we can give CBT. So there is drug, there is therapy. Also remember, there are some new drugs which are particularly used, approved for postpartum depression. These are GABA A modulators. So two important drugs, remember, one is brexanolone, both are nolone, and zuranolone. Brexanolone, remember, it's a IV drug, and zuranolone, it's a oral drug. These drugs are only approved, especially remember zuranolone, they are only approved for postpartum depression. So many times you will see questions have been asked on both these. Let's discuss one more entity, that is postpartum psychosis. It is even less common, 1 to 2 per 1000 childbirth. Now what is psychosis here? Patient may start with vague symptoms, irritability, sleep problems, anger. So after delivery, patient may have these vague symptoms, and psychosis means now the patient has also developed delusions, hallucinations. So these delusions may be related with the baby. Patient may say this baby is not mine. I have not delivered any baby. Or patient may say that I am hearing voices telling me to kill the baby, I want to kill the baby. So delusions, hallucinations, after delivery, then you'll say it as postpartum psychosis. How will you treat this patient? Anybody? Can you tell me how you are going to treat this patient, beta? So since psychosis has developed, now you can give antipsychotics, and also remember even lithium has shown good results in this situation. So please see if they are giving you such scenario and then make the diagnosis accordingly. It's a very important table. Now also in the etiology, beta, there are certain theories in the causation of depression. So multiple factors may be there. One of the important theory is the cognitive theory, which was given by, remember, Aaron Beck. So Aaron Beck ne kaha, what is cognition? Cognition means thoughts. Aaron Beck said that normally all of us have automatic thoughts. Now if you're sitting here, if you just observe your thoughts, आप देखोगे आपके mind में automatically thoughts are like you might be having such thought like what will I have for dinner tonight, what will I do after the class, है ना, ऐसे automatic thoughts आ रहे होंगे. Aaron Beck said that those patients have depression, they have automatic negative thoughts. So there are certain cognitive distortions. These are negative, inaccurate ways of thinking. Many times patient says, sir, without any reason I am having these negative thoughts. So this is cognitive theory. In fact, in the treatment we use CBT. In CBT what we do, we identify, in the cognitive therapy we identify these thoughts and we correct them. So this is cognitive theory of depression. Aaron Beck also gave a triad of depression. Patient may have negative views of self, which is known as worthlessness. Patient may have negative views about the environment. Sir, environment is very bad, nobody can help me. Patient may have negative views about the future. Sir, there is no hope for tomorrow, hopelessness. So this is cognitive triad of depression. Please remember, this is cognitive triad and that was cognitive theory. Also in the neurotransmitter, agar I ask you, tell me two important neurotransmitters implicated in depression. You will say one is serotonin and another is norepinephrine. Both of them are reduced in depression. Even remember, dopamine is also implicated. So these were some points about the etiology. But let's answer this question. Again, seeing the way they are asking question, this is one topic which I feel may be asked now this time. So please try to answer this question. A 25-year-old female presented to the OPD with symptoms present since adolescence. She complains of low mood, lethargy, sleep disturbance. She reports of pushing herself every day to work, and she completed her graduation. Now she is working as assistant manager in a multinational company. Which of the following is the likely diagnosis? But please answer this question. Whenever you get such question, try to see the options and then answer. Is it recurrent depressive disorder? No. Recurrent depressive disorder means the patient will be having these episodes of depression in episodes, है ना? यहाँ पे तो they are trying to tell you that for a long time she is having continuously these symptoms, isn't it? Is it atypical depression? देखो atypical depression में क्या होता है कि patient को depressive symptoms होते हैं but they are atypical, जो थोड़ा less common symptoms हैं, they are seen here, so that is atypical. जैसे यहाँ पे mood reactivity होगी. Usually we know depression में mood is not much reactive, but यहाँ पे mood brightens in a positive event. यहाँ पे usually you will see that there is increase in sleep, increase in weight. Those symptoms which are usually less seen in depression, they are more. So that is atypical depression. This is not atypical depression. But a seasonal affective disorder, they will tell you that whenever a particular season comes, then only patient has depression. Like they may tell you कि the patient every winters patient को depression होता है, winters जाती है patient का depression ठीक हो जाता है. That is seasonal affective disorder. No, this is not seasonal affective disorder. The answer here is, it is dysthymia. So let's discuss dysthymia. It's a very important topic, dysthymic disorder or dysthymia. It is a persistent depressive disorder. देखो usually depression occur in episodes, but sometimes patient may have mild symptoms of depression. मतलब mild symptoms हैं, it is not qualifying for a diagnosis of depression, है ना? Remember हमने diagnostic criteria पढ़ा था, that is not fulfilling. So patient is having mild symptoms. Can anybody tell me in the chat box, beta comment section में बताओ, what is the duration to make a diagnosis of dysthymia? Tell me, to make a diagnosis of dysthymia क्या duration criteria होता है? Can you tell me? It is, remember, 2 years. Very important, 2 years. In children, 1 year is, if the symptoms are present, then also we can make a diagnosis. देखो, in psychiatry, duration is very important. Have anywhere they mentioned duration? See, she is 25 years of age and the symptoms are present since adolescence. They're trying to tell you the symptoms are present for so many years, isn't it? Very good. And since the symptoms are mild, the functional impairment is not severe. Can you appreciate in the question, she's been having the symptoms, but still they've told you that she has completed the graduation, she's working in a company, so they're trying to tell you that functional impairment is not that severe. She's pushing herself and she's able to do some of those work. So they are in a way trying to tell you that functional impairment is not severe. In fact, but a DSM-5 uses this term, please remember this term, persistent depressive disorder. It's a very correct name they've used, depressive disorder which is persistent. It includes chronic depression when it is more than 2 years and also dysthymia. So this is dysthymia. If you see, suppose if the patient touches this line, it qualifies for a depressive episode, and let us say this is 2 years duration. So can you appreciate patient for the past 2 years, the symptoms are mild, but they're continuously present. So this is dysthymia. Can anybody tell me what is double depression? Sometimes this term may be used. It's a historical term which sometimes may be asked. Suppose this patient who was having dysthymia ultimately also develops an episode of depression. So that is double depression. That is dysthymia followed by patient also develops a depressive episode now. So that is the meaning of double depression. Is it clear to everyone? In fact, 40% of the patients who have depression may also have dysthymia also. So please remember this is dysthymia. Please be very careful, see the duration, see the symptoms, see the functioning, and then make a diagnosis. Now let's talk about the next question. Again, treatment is very important. In fact, I'll discuss some important updates also. I'll discuss, INI-CET is very much, vulnerable of asking such latest updates. So I'll discuss some updates also. In the end also, high chances some questions may be asked. So please be very careful. A 25-year-old female diagnosed with PCOS was brought to the psychiatrist with the complaint of low mood, decreased interest, lethargy, disturbed sleep and anxiety. She is planned to be started on an antidepressant, so you have to start an antidepressant. You have to tell me which of the following statement is incorrect. Tell me. So if you tell me the incorrect statement, so what is the right answer here? SSRI, SNRI can cause sexual dysfunction. Is it true or false? Yes. While bupropion and mirtazapine causes less sexual side effect, it is correct. In fact, please remember bupropion and mirtazapine, this question has been asked, these are drugs which causes less sexual side effect. So sometimes they will give you a question, ki patient on antidepressant has developed sexual side effect, which drugs you can now use. So once bupropion was asked and even mirtazapine. HAM-D is used to assess depression, yes. Dekho, HAM is Hamilton rating scale of D for depression. Sometimes just try to read the names. I'll give you a list of these scales also in the end. Remember, paroxetine is safe in pregnancy. Tell me, is it true statement or false? No, please remember, usually SSRIs can be given in pregnancy, but remember, paroxetine is teratogenic. Paroxetine is teratogenic, it can cause cardiovascular defects. Patient with PCOS should be screened for depression and anxiety, but it is one of the latest updates in Harrison. So please remember, here pe incorrect statement is option C. So this may come as a question in medicine or even in obs and gynae, or they may just integrate it with psychiatry. We'll talk about this point. So remember, in PCOS now you also have to screen the patient for mental illnesses like depression and anxiety. A very important update we'll discuss. So let's talk about the management of patient with depression. So we can give antidepressant, we can use CBT, therapy, cognitive behavior therapy. In the drugs, the drug of choice is SSRI. Why? Because they have less side effects. Okay, remember these names like sertraline, fluoxetine, paroxetine, citalopram, escitalopram. Vilazodone is more for SPARI drug, that is serotonin partial agonist bhi and reuptake inhibitor. Which is the most common side effect? Remember, GI side effect like nausea, diarrhea, constipation, dry mouth. This question was asked twice, that SSRIs, they cause dry mouth or hypersalivation. They can cause dry mouth. Sexual side effect, in fact, most common long-term side effect agar aapse puche of SSRIs, yes, they can cause sexual side effect like decreased libido, delayed ejaculation. Sometimes patient may have vivid dreams, sweating, hyponatremia, especially in elderly patients, So one has to be very careful, especially drugs like escitalopram, even with other SSRIs also. Patient may have hyponatremia. So they may give you a picture of hyponatremia, tell you patient is on an SSRI. So that is one possibility which you have to check. Very good, yes. So this is SSRI, they are the drug of choice. Then we have SNRIs, that is serotonin and norepinephrine reuptake inhibitors. But please remember venlafaxine, desvenlafaxine, duloxetine, even milnacipran and levomilnacipran. Again, they also have side effects similar to SSRIs. Bupropion, a very important drug for your exams, because it is one of the drugs which has low risk of sexual dysfunction. One more drug we discussed is mirtazapine. Also, it has low risk of sedation and weight gain. Remember, but one side effect is seizures which can occur especially at higher doses with bupropion. So tell me psychiatric condition jahan pe you will avoid, you will not give bupropion. You will say, sir, any condition jahan pe seizure ka risk बढ़ जाएगा, I will not give bupropion. So can you tell me, in psychiatry, of course, you will not give it in a patient who has seizures. Okay, any psychiatric condition jahan pe you will avoid giving bupropion. Anybody? Remember, B say bupropion, B say bulimia nervosa. So in bulimia nervosa, we'll discuss patient is eating and then patient is having self-induced vomiting. That can cause electrolyte imbalance, it can cause seizures. Even anorexia mein, patient is not eating much, it can cause electrolyte imbalance. Again, it can increase the risk of seizures. So please remember some of these important points. Also remember, and a very important update, because this is from Harrison, that all women with PCOS should be screened for obesity, hypertension, glycemic control, and also remember, this has been now added, depression and anxiety at the time of diagnosis and even at regular intervals. So it's very important, because we have seen that endocrinal abnormalities such as hypothyroidism, it is an important endocrinal abnormality associated with depression even in PCOS. So we have to screen patient with depression and anxiety. Also there are certain rating scales, there are clinician rated scale. देखो clinician rated scales का मतलब क्या होता है, which are used, which require some expertise. So clinicians can use these scales. That is, one is HAMD, that is Hamilton rating scale for depression, and also there are other scales like BDI. It is patient rated. BDI is Beck Depression Inventory. Okay, so if you have to use any scale in community, so in community you may not be you may not be able to send a expert person to carry out the test. So in community sometimes we can use patient rated scale, while in clinical setting you may prefer scale such as HAMD. I hope this is clear to everyone. So answer to this question is option C. Paroxetine is to be avoided in pregnancy. Is it clear to everyone? Let me know if it is clear. Again, you will see a lot of these psychopharmacology questions. A patient was started on amitriptyline or a TCA was mentioned and was found unconscious. Which of the following is not suggestive of TCA toxicity? So they are suspecting that patient has TCA toxicity. कौन सा इनमें से will not be seen in TCA toxicity? Tell me. Write down the answer. Which of the following? Confusion beta can occur. Confusion can be seen. So there are CNS effects, like the person may have coma, seizure, confusion. CVS may, yes, there is increase in the QRS interval. Arrhythmias can occur. Also in the ANS, patient may have, there is pupillary dilatation can occur. Yes, it is not hypothermia, but it is hyperthermia. So sometimes they will ask such question. Please remember again, TCA toxicity may pupillary dilatation, mydriasis can occur. So please remember, so CNS, CVS and ANS effects can occur. It is hyperthermia and not hypothermia. And this question has been asked again and again. In the management, beta, what will you give? In the management, what will you give? Treatment में क्या use करोगे? Patient may develop acidosis in TCA toxicity. So what will be the treatment? You can give sodium bicarbonate. So yes, we can do alkalization. Very good. Also, we can, you should monitor ECG, and also if there is drug which is unabsorbed in the GI tract, we can remove it by using activated charcoal. Patient on MAO inhibitor consumes tyramine rich food such as cheese, such as red wine. Can you tell me what is this reaction known as? So they may just give you this question. It's a very old question, but again it has been repeated in INI-CET. But what is this reaction known as? Nahi. Serotonin syndrome is when you are giving many of the drugs which are increasing serotonin. Here I am saying with tyramine rich food you are giving MAO inhibitors. Very good. That is cheese reaction. Patient develops hypertensive crisis. Very good, very good. Patient is taking trazodone. Can you tell me an important side effect which again was asked in INI-CET as a clinical question? So what is an important side effect with the drug trazodone? Anybody? It can cause prolonged painful erection, that is priapism can occur. Very good. Yes. So they are asking such clinical questions. Please be very careful. Now such newer question may also be asked. Which of the following is least useful in TCA toxicity? देखो, if they ask such newer question ना, always try to rule out the options. हमें बताना है which of the following is least useful in TCA toxicity. Tell me, is there any role of benzodiazepine लाइक डायजेपैम का कोई रोल है इन द मैनेजमेंट ऑफ TCA टॉक्सिसिटी बेटा? सो सी द सिम्टम्स एंड देन ट्राई टू कोरिलेट विद द ट्रीटमेंट. इज देयर एनी रोल ऑफ दीज बेंजोडाइजेपिन? डायजेपैम का कोई रोल है? टेल मी. Yes, patient can develop seizures. We can use sodium bicarbonate, but we have just discussed that can be used. Lidocaine, antiarrhythmic drugs like lidocaine, that can also be used. Yes. Does hemodialysis have any role? Tell me. क्या hemodialysis का कोई role है in the management? देखो, drugs which have high volume of distribution like TCAs, their hemodialysis don't have much role. So please remember यहाँ पे आंसर है hemodialysis. Hemodialysis का कौन सी एक इंपॉर्टेंट टॉक्सिसिटी में रोल है? वी विल डिस्कस इन लिथियम टॉक्सिसिटी. ओके, प्लीज रिमेंबर. वेरी गुड. आई होप दिस इज क्लियर टू एवरीवन. नाउ लेट्स आंसर दिस क्वेश्चन. दे हैव बीन आस्किंग क्वेश्चंस, सो प्लीज नाउ आंसर दिस क्वेश्चन. व्हाट इज द आंसर? विच ऑफ द फॉलोइंग इज अ इनकरेक्ट स्टेटमेंट? आपको बताना है इनकरेक्ट स्टेटमेंट आउट ऑफ दिस. टेल मी. कीटामीन इज रैपिड ऑनसेट ऑफ एक्शन फॉर डिप्रेशन, हैज रैपिड ऑनसेट. देखो, कीटामीन इज अ it's an anesthetic agent, and now we are seeing that ketamine also has antidepressant property. In fact, is S-enantiomer S-ketamine, which is available as a nasal spray. It is approved for managing, treatment resistant depression. Along with oral drug, it can be used. Remember, ketamine, S-ketamine, they have rapid onset of action. Ketamine again can be given various route. IV ketamine, it has a rapid onset of action, and also remember it has anti-suicidal property. So this question in fact was asked in the INI-CET recently, which of the following is a rapid onset? So usually जो antidepressant हम use करते हैं, they take time, but ketamine has a rapid onset of action. S-ketamine is available as nasal spray. Yes, that is correct. But Japirone, again, it is a latest antidepressant. देखो, how to remember? Last में 1 is coming ना, so it is basically 5HT1A. So 1 is coming ना, so 1A agonist, partial agonist, partial agonist, and remember ECG है ना, Japirone के साथ remember ECG, it can increase the QT interval. So when we are giving Japirone, we have to monitor the ECG. Okay, this is also correct statement. Zuranolone is given through intravenous route. Is it a correct statement? No, we have discussed ना, ये oral route से देते हैं. So just discuss some points about these newer drugs. So please be very careful. Recently question abhi aaya bhi tha, so they may ask such questions. So just see this. Japirone, remember it is contraindicated in the prolonged QTC interval, and it's ketamine. It is approved for treatment resistant depression and also patient with active acute suicidal ideation or behavior. So please remember some of these important points. Let's discuss the next question. So we have covered some important points about depression. Let's talk about bipolar disorder. Let's talk about bipolar disorder. The bipolar disorder means that patient is having episodes of depression and also having episodes of mania, hypomania. So a 30-year-old female is brought with symptoms of excessive talking, decreased sleep, over grooming, excessive spending for the past 2 weeks. On asking any question, she becomes irritable and angry, and there is no history of previous psychiatric symptoms. What is the likely diagnosis? It's a very interesting question. So tell me the answer. देखो, cyclothymia is a milder form of bipolar disorder. जैसे dysthymia discuss किया था, वैसे cyclothymia, remember duration is 2 years. So this we have ruled out. Rapid cycling we will discuss. There are 4 or more episodes of mania, hypomania, depression. That is also ruled out. You have to tell me ये bipolar 1 disorder with current episode mania है या bipolar 2 disorder with current episode hypomania. It's a tricky question. Tell me B or C. Tell me, is it B or is it C? But please be very careful. Nowadays they are asking such question. So if you know the basics well, let's understand how to make a diagnosis of mania and hypomania. Chalo, some of you are saying it is B, some of you are saying it is C. Good. Let's see first what is mania. But to make a diagnosis of mania, we know symptoms should be present for at least 1 week na, and we know the symptom, the mnemonic is me, dig, fast. M से मूड पेशेंट का हैप्पी है, एक्सपेंसिव है या फिर इरिटेबल भी हो सकता है. पेशेंट के एनर्जी लेवल्स आर इंक्रीज्ड, मूड इज़ हाई, एनर्जी इज़ हाई. डी से पेशेंट डिस्ट्रैक्टेबल है, पेशेंट इज़ इम्पल्सिव, मतलब डूइंग थिंग्स विदाउट कंसिडरिंग द कॉन्सिक्वेंसेज. पेशेंट बहुत ज़्यादा स्पेंड कर रहा है, पेशेंट इज़ वेरी डूइंग थिंग्स विद इम्पल्सिविटी, पेशेंट इज़ ओवर रिलीजियस, पेशेंट में बिकम अग्रेसिव. G से grandiosity, not delusion of grandiosity, I'm saying grandiosity का मतलब है elevate, inflated self-esteem. Patient, is walking as if, king is walking. So there is inflated, increase in the self-confidence. F say remember, flight of ideas can be seen. Activity levels are increased. Patient is trying to do multiple things, not sitting at one place. And sleep may, very interesting, there is a decreased need for sleep. Patient is not sleeping for 10 days, let us say, and patient says, sir, sleep is a waste of time. Who requires sleep? So there is decreased need of sleep. And T say है talkative. So these are the symptoms of mania. We say to make the diagnosis of mania, beta, 1 plus 2, पहले दोनों symptoms होने चाहिए, plus 3 or more of the remaining symptoms present for at least 1 week. Then we call it as mania. What is hypomania? देखो hypomania का मतलब क्या है? Symptoms are similar to mania but hypo मतलब कम है. Duration is at least 4 days. Symptoms are similar to mania but they are not severe. So they are not causing much significant impairment in functioning. So somewhere in the question they may tell you that patient is able to do some of the work. So that is again giving you hints that patient is having hypomania. Sometimes remember, patient with mania may develop delusions, hallucination. Delusions, hallucination can occur even with depression, उसे कहते हैं psychotic depression. यहाँ पे भी patient may develop mania में delusions या hallucination. But primary diagnosis है mania and उसके बाद बीच में कहीं पे patient has also developed delusions, hallucination. But remember, in hypomania patient will never develop psychotic symptoms. अगर psychotic symptoms develop हो गए then you are considering mania with psychotic symptoms. Also remember, there is no need for hospitalization. But अगर somewhere in the question they tell you ना कि patient is hospitalized, that is again giving you hints कि now it is mania. And also remember, out of that me dig fast we discussed na, flight of ideas usually is seen in mania and not in hypomania. All of you have understood how to differentiate mania from hypomania. Now see this question. But if you are trying to see कि ये mania है या hypomania है, so they in this question they have not given you much clues. But you should know what is bipolar 1 disorder and what is bipolar 2 disorder. Bipolar 1 disorder we say when a patient has at least an episode of mania and at least one episode of depression. जबकि bipolar 2 we say patient has at least an episode of depression and at least an episode of hypomania. But now you will understand this, I have discussed this so many times, but even if a patient has a single episode of mania, then also we consider it as bipolar 1 disorder. Now see this question, उन्होंने आपसे पूछा है is it bipolar 1 or bipolar 2? They've given you a clinical picture which may fit in mania or hypomania. But now from the option, can you appreciate, I cannot make a diagnosis of bipolar 2 disorder with just a single episode, because they have told you there is no history of any psychiatric illness. So here by default I'll consider it as bipolar 1 disorder, current episode mania. I hope this point is clear to everyone now. So please be very careful if such questions are asked. Now see this, it was asked in this exam only. See, such a simple question was asked. We all the time discuss this table. Which of the following drugs are used for treatment of acute mania? See this. So tell me what is the right answer. So in bipolar disorder, patient may come to you with depression or may come to you with mania or hypomania. What is the drugs which we use in the management of mania? Tell me. So what is the answer? Do we use haloperidol, which is an antipsychotic, valproate, lithium, these are mood stabilizers, amitriptyline is an antidepressant. बेटा कौन सा drug हम use करेंगे? Answer this question. So we have been discussing this again and again. देखो, please remember the answer is we can use 1, 2 and 3. Okay? So many times we have talked about this. Let me give you this scenario again. Suppose a patient has come to us, let us say it is mania. Is it possible that past में patient को depression था? Let us say past में patient को depression था, so which drug you might have started? We might have started antidepressant. अब patient को हो गया mania. So this is the table, but we have these 3 first line drugs, remember. So we have these 3 first line drugs, that is antipsychotics, lithium and valproate. Okay, any of these drugs we can use. If they ask you drug of choice, then you can go with antipsychotics. So if I ask you, but a first step in this patient's management, what will you do? Please remember, before starting any drug, if the patient is on antidepressant, the first step will be I have to stop the antidepressant. It's very, very important, because antidepressant will elevate the mood, but the mood is already too much elevated. We will stop antidepressant and then we will start the drug. Out of the 3, if they ask you particularly, then you can go with antipsychotic. Especially Mania with antipsychotic, again, mania with psychotic symptom, again you can go with the antipsychotic. Both lithium and valproate, these are mood stabilizer. Remember, lithium takes a longer time. It's a slow onset of action. So for rapid management of symptoms, if they ask you out of lithium and valproate, then it has rapid onset of symptoms. Onset of the effect. So remember, then we can choose valproate if out of lithium and valproate they are asking. Okay. In pregnancy, suppose now they ask you that patient is, beta again देखो 2 weeks ड्यूरेशन तो दोनों के लिए है ना. मिनिमम ड्यूरेशन हाइपोमेनिया में 4 days है और मेनिया में 1 week है, तो दोनों का ड्यूरेशन क्राइटेरिया तो फुलफिल हो रहा है ना. सो प्लीज रिमेंबर, वो दैट इज नॉट हेल्पिंग अस डिफरेंशिएट, इजंट इट? नाउ सी दिस. Suppose this is again one of the questions they ask repeatedly about pregnancy, how to manage a patient who is pregnant. Suppose patient is pregnant, develops mania. Again tell me what is the drug of choice here. Again remember, in pregnancy antipsychotics are preferred. Lithium may be used, but remember lithium can cause abstinence anomaly. This is a repeatedly asked question. Try to avoid valproate as it can cause neural tube defect. Also remember, in a try to avoid valproate in female in child bearing age group. So this is again an important point, please remember this. Why, can anybody tell me why to avoid valproate in women of child bearing age? I'm not talking about teratogenicity, but because we know valproate can increase the risk of PCOS. I'm not saying don't give, but if you have other option you can avoid. And yes, valproate is more useful in rapid cycling, which I'll discuss. Is it clear to everyone? Right, so let's answer this question. This is again a INI-CET ka question. Rapid cycling is characterized by all except. So rapid cycling, we know in 1 year, if a patient has 4 or more episodes of mania, depression, hypomania. देखो, can antidepressant increase the likelihood? Yes. देखो, bipolar disorder में अगर आपने सिर्फ antidepressant दिया, it can increase the risk of rapid cycling. That is also correct. But please remember, even patient having hypothyroidism, again in bipolar disorder patient को hypothyroidism है, that can again increase the risk of rapid cycling. It occurs more commonly in men. It is a false statement. It is more common. Rapid cycling is more common in females than males. So the answer here is, it is option D. I hope this is clear to everyone. So this is rapid cycling. So in the treatment, see, can you appreciate, in 1 year patient has 4 of these episodes. But in the treatment, remember we have discussed now, valproate shown to have good result in rapid cycling. In fact, nowadays even lamotrigine is showing good results in rapid cycling. Okay, but yes, sometimes we can give combination. Yes, if the symptoms are severe, yes, we can use combination of those drugs like antipsychotics and those mood stabilizers. We can use a combination, yes, in severe cases. So these were some important points about mood disorders. Let's now discuss about the neurotic disorders. Okay, let's now talk about some important neurotic disorders. So let's answer this question. In the neurotic disorders, a patient is brought with symptoms of anxiety, palpitation, sweating, breathlessness, chest pain, and feeling she might have a heart attack or feeling of impending doom. Patient को episodes ये बार बार आ रहे हैं, 5 to 6 episodes in a month, 30 minutes duration, and they are present for 6 months. Can you tell me what is the likely diagnosis? Very good. What is the likely diagnosis? Yes, it is panic disorder. Very good. This is panic disorder. So this is a very important table which I always discuss. Anxiety disorders, there are 5 important disorders. We can divide into 3 categories. पहला है panic disorder. देखो panic disorder में ना patient को recurrently panic attacks आ रहे हैं. So sudden onset of intense anxiety के symptoms हैं. Patient को suddenly anxiety होने लगती है, and very important is ऐसा लगता है that there is impending doom. I am about to die. And can you appreciate, patient is having these episodes and they occur at different places. कभी patient को in the office एक attack आ गया, कभी patient को in the home, sometimes patient in a shopping mall. So please remember this. And can you also appreciate, beta in between क्या है, patient is absolutely normal. So ये classical case of panic disorder, like in that question. Next is phobias. Beta phobias में क्या हो रहा है? It is situational anxiety. 3 important phobias are there: agoraphobia, specific phobia, and social phobia. Agoraphobia, there are 5 situations, at least 2 or more of those 5 situations. जैसे कि पेशेंट को पब्लिक ट्रांसपोर्ट में, ओपन प्लेसेस में, या क्लोज स्पेसेस में, या फिर इन क्राउडेड प्लेसेस इन अ लाइन, या फिर अलोन आउटसाइड ऑफ द होम. इन 5 में से अगर 2 सिचुएशन में पेशेंट को एंजाइटी हो रही है, देन दैट इज अगोराफोबिया. स्पेसिफिक फोबिया मीन्स एनी पर्टिकुलर सिचुएशन. एंड सोशल फोबिया में क्या हो रहा है, इन पर्टिकुलर सोशल सेटिंग्स, पेशेंट को सोशल सेटिंग्स में एंजाइटी हो रही है बिकॉज ऑफ द फियर ऑफ एम्बैरेसमेंट. सो अगेन कैन यू अप्रिशिएट, पेशेंट को जब भी सिचुएशन आती है एंजाइटी होती है एंड बीच में पेशेंट बिकम्स एब्सोल्युटली नॉर्मल. सो सी, if they're talking about panic attacks, go with panic disorder. If they're talking about specific places patient is having anxiety, then think of these phobias. And what is GAD बेटा, generalized anxiety disorder क्या है कि पेशेंट को अब एंजाइटी जनरलाइज्ड है, फ्री फ्लोटिंग है. हाईलाइट दिस पॉइंट बेटा, एक्सेसिव वरीज हो रही है पेशेंट को, छोटी छोटी बातों पे पेशेंट इज वरीड. सो दिस इज जनरलाइज्ड एंजाइटी disorder. I hope this is clear. These are the 3 important categories and 5 important anxiety disorders. I hope this is clear. पेशेंट को बेटा अगर सिर्फ लिफ्ट यूज करते हुए पेशेंट को एंजाइटी है, टेल मी, इज इट अगोराफोबिया और इज इट स्पेसिफिक फोबिया? ओनली वाइल यूजिंग लिफ्ट, इज इट अगोराफोबिया और इज इट स्पेसिफिक फोबिया? आंसर, टेल मी, इज इट अगोराफोबिया और स्पेसिफिक फोबिया? देखो एक ही सिचुएशन में है ना, यू विल नॉट कॉल इट अगोराफोबिया, यू विल कॉल इट अ स्पेसिफिक फोबिया. कौन सा स्पेसिफिक फोबिया? स्पेसिफिक फोबिया, क्लॉस्ट्रोफोबिया. बट अगर उन 5 में से 2 सिचुएशन में एंजाइटी है, देन यू विल गो विद, then you will say that is agoraphobia. I hope this is clear to everyone, and I will share this slide, when you are seeing, I'll share this slide, agoraphobia, as I discussed, 2 of these 5 places. Specific phobia beta, there is a irrational fear of, it could be of any object or any situation. For example, once they asked what is nyctophobia, fear of darkness or fear of night. So please remember this. What is thanatophobia? Thanos, the villain in Avengers, it was derived from the Greek god of death. Thanatophobia means fear of death. And social phobia or social anxiety disorder, patient has anxiety in social situation because of fear of embarrassment. I hope this is clear to everyone. Let's answer this question. Dekho again. So please remember, that was about some important points about the anxiety disorders. Let's see this question. A female patient having recurrent distressing thoughts of dirt, contamination leading to repetitive hand washing. Tell me the diagnosis first and then tell me the treatment. What is the therapy of choice? Tell me the diagnosis beta first and then tell me the treatment. Kya diagnosis है? Very good. Yes, it is OCD. Very good. Tell me what is the answer here. Treatment में क्या करोगे? देखो, systematic desensitization is a behavior therapy which is used for phobias like agoraphobia, for specific phobia. ठीक है? Yes, we will use CBT specifically, more specifically बेटा आंसर होगा ERP, exposure and response prevention. बेटा dialectical behavior therapy, DBT, it is used in borderline personality disorder. We'll discuss when we'll talk about the personality disorder. Is it clear? Okay, so यहाँ पे better answer would be ERP rather than CBT. So let's talk about obsessive compulsive disorder, OCD, again an important neurotic disorder. But here patient is having obsessions and compulsions. देखो, how to remember what are obsession? There are different types of obsessions. All of them have this important acronym you can remember. All of them have features of ROSI. बेटा what is ROSI? Repetitive. Patient के mind में बार बार repetitive thoughts आ रहे हैं. Which patient says, sir, I know these are my own thoughts, but these are senseless. I know ये गलत thoughts हैं. These are irrational. क्या patient उनको रोक पा रहा है? Is he able to stop them? No. These are irresistible. Patient says, sir, मुझे repetitive thoughts आ रहे हैं. My hands are dirty. I know these are my own thoughts. I know these are wrong thoughts because see my hands are clean and I am not able to stop them. तो ये क्या है? Obsession. But obsession है repetitive thoughts, images या impulses. What is compulsion? Person is compelled to do something. ये है repetitive acts. Patient बार बार कुछ acts कर रहा है. It could be physical act or in his mind also. It could be even mental acts. Patient अपने mind में कुछ count कर रहा है. So that is a compulsion. So that is OCD. Again, there are different types of obsessions and compulsions. This table is very important, but please remember this table. What is the most common obsession? If I ask you, remember it is contamination. Second most common is pathological doubts. Patient को बार बार doubts आ रहे हैं. A housewife goes out of the kitchen and उसको बार बार doubts आ रहे हैं whether I have turned off the gas knob or not. She says, I remember I have turned off. ये senseless doubts हैं, but they are coming again and again. Patient has obsession of symmetry and precision. Everything should be symmetrical. Aggressive. Sir, I am getting thoughts to slap the person standing in front of me. No, sir, I don't want to do this. I am not that kind of a person, but I am having these thoughts. Patient is having sexual obsession. Sir, I am having sexual thoughts of touching the patient inappropriately. देखो, if I want to ask question, you know, sometimes they may ask you how to differentiate sexual obsession from, you know, some of the paraphilias. Like for example, in forensic also you would read this frotteurism. Beta, what is frotteurism? What is frotteurism? Double T है ना बीच में, touching. Patient is touching, you know, the person inappropriately and is getting sexual gratification. Okay, is getting sexual gratification. But what is the question? What is the difference between? देखो, ऑब्सेशंस repetitive thoughts हैं बेटा, एंड compulsions are repetitive acts. सिस्टमैटिक डिसेंसिटाइजेशन में व्हाट वी आर डूइंग बेटा, इट इज जस्ट, देखो सीबीटी क्या होता है, सीबीटी इज अ कॉम्बिनेशन ऑफ कॉग्निटिव थेरेपी एंड बिहेवियर थेरेपी. कॉग्निटिव थेरेपी में आई एम ऑल्सो चेंजिंग द थॉट्स, इन बिहेवियर थेरेपी आई एम ओनली टारगेटिंग द बिहेवियर. सो सिस्टमैटिक डिसेंसिटाइजेशन बेटा हम स्टेप वाइज धीरे धीरे करके जो एंजाइटी प्रोवोकिंग सिचुएशन है उसकी इंटेंसिटी को इंक्रीज करते हैं, एंड वी ओनली टारगेट द बिहेवियर. आई एम नॉट चेंजिंग द थिंकिंग. In CBT, we are also working on the thought, on the thinking also. So behavior therapy mein I am just changing the or targeting the behavior. CBT is a combination of cognitive therapy and behavior therapy. Tell me how to differentiate between sexual obsession versus frotteurism, paraphilia like frotteurism. But sometimes such question can be asked. Can you appreciate in sexual obsession patient know these are senseless thoughts. Patient does not want to do this. While in frotteurism, what is happening? Patient is wanting to do those behaviors because the person is getting sexual gratification. So these are some obsessions. Compulsion में remember C for compulsion, C for checking. Most common compulsion है checking. जिस patient को pathological doubt है बेटा वो क्या कर रहा है, बार बार जाके check कर रहा है. Second most common is washing. जिस patient को contamination है now is also washing multiple times. Counting is patient is doing something again and again. Symmetry and precision. Now the patient is doing things, arranging things again and again. This question was asked in one of the exams. But a 16-year-old female, she's cutting food in equal sizes, spending a lot of time eating her meal. देखो question शुरू हुआ है 16-year-old female eating food. First option is anorexia. No, it is not anorexia. She's doing something symmetrical. That means again it is OCD of symmetry or precision. A person is shaving and is spending a lot of time getting a lot of cuts and bruises, but he is trying to do it symmetrical. Again, it is OCD. Multiple का मतलब है combination. So please remember this, very important. हाँ, you know sometimes they will frame question like this. Always see you have 4 options. बेटा answer निकल जाएगा. If you see the options very carefully, try to rule them out. Try to think why that option is not the answer. Okay. Now coming to the treatment, बेटा we have drugs and we have psychotherapy. In the drugs we have 2 first line drugs. We have 2 first line drugs, one is SSRI and one is clomipramine, which is one of the TCAs. But again both these can be used, but remember अगर drug of choice पूछते हैं again it is SSRI because of less side effects. So in drugs we have these first line drugs. Also there is an important point of augmenting agent. Again remember INI-CET has asked this point twice in a direct indirect manner. देखो augmenting agent का मतलब है after giving these first line drugs we can add some drugs to increase the effect of these first line drugs. So one of the augmenting agent is we have antipsychotic. 2 important antipsychotic is risperidone and one more remember aripiprazole. So these can be used as augmenting agent. So one is we have drugs, another is we have therapy CBT, but especially exposure and response prevention. So हम पेशेंट को एक्सपोज करते हैं, लेटर से इस पेशेंट को हमने जो कंटामिनेशन को ऑब्सेशन उसको एक्सपोज किया टू कंटामिनेशन, एंड नाउ वी आर प्रिवेंटिंग हिज रिस्पॉन्स ऑफ hand washing. So this is ERP. So we know what is the drug of choice, we know the therapy. What is the treatment of choice? Can anybody tell me? Very good. What is the treatment of choice for OCD beta? Remember a combination of drugs and therapy is the treatment of choice. Is it clear? So this is OCD. In fact, remember this, both DSM-5 and ICD-11 they have made a new term, that is obsessive compulsive and related disorder. Certain disorders which were very similar, they have clubbed them in this category. देखो नाम से ही पता चल रहा है, पहला है OCD, सेकंड इज बॉडी डिस्मॉर्फिक डिसऑर्डर. बॉडी डिस्मॉर्फिक डिसऑर्डर में पेशेंट को रेपिटेटिव प्रीऑक्यूपेशंस हैं कि मेरी फिजिकल अपीयरेंस में कुछ एबनॉर्मैलिटी है, लाइक माई नोज इज लार्ज या नोज इज स्मॉल, ईयर्स आर लार्ज, ईयर्स आर स्मॉल. Remember in body dysmorphic disorder again beta drugs like SSRIs have shown good result and even therapy like CBT can be used. Hoarding disorder में क्या हो रहा है, patient is collecting things, maybe old newspapers, magazines, and he's not ready to throw them away. He's hoarding things. Remember, hoarding disorder में CBT can be used, but it is difficult to treat. This question was asked. Hoarding disorder, remember, is difficult to treat. What is trichotillomania? Here patient is having recurrent urges to pull the hair. It can lead to alopecia. Excoriation disorder में skin picking. Patient is picking his skin like this. Trichotillomania में any part of the body can be involved. Most common कहाँ से pull कर रहा है hair? From the scalp. And in excoriation, most common area is the face. Similarly, in ICD-11 also beta, they have made this similar category of obsessive compulsive or related disorder. And one question was asked in INI-CET from this table. देखो again see this, one is OCD, another is BDD, another is hoarding disorder. But they made a new term that is body focus repetitive behavior disorder. मतलब body पे focus करता हुआ repetitive behavior. In this term they had included trichotillomania and excoriation disorder, and this was asked which is included under this category, and one of the option was trichotillomania. Please see there is a new diagnosis beta which they have made, olfactory reference syndrome. देखो olfaction मतलब person is, olfaction means smell, reference syndrome मतलब patient thinks that his body is emitting foul smell. Is he able to smell it? No, because अगर उसको smell भी आ रही है then you're thinking olfactory hallucination. Here is thinking कि उसकी body is emitting foul smell. This is olfactory reference syndrome. Even hypochondriasis they have included in this table. We'll discuss hypochondriasis in a while. I hope this is clear to everyone beta. Please be very careful. This was asked in INI-CET. Somewhere they may ask such questions. Answer this. This is, I feel that this topic of somatoform and related disorder, slightly important because in so many exams, questions have been asked. So let's try to answer this question. A 35-year-old woman feels her social media handle is being hacked. She finds pictures of herself with other people on Instagram, appearing she is enjoying in that pictures, but she does not remember any of those events. Okay. Her husband also recollects that at times she behaves in a very different way than usual and doesn't appear to remember such instances. Okay, in a different, also talks in a different accent as if she is completely different person and does not remember such instances. Her brother reports there is history of childhood abuse and patient has no recollection of it. Can you tell me beta what is the diagnosis here? Very interesting. Read all the options beta then answer. It is not hypochondriasis. We'll discuss hypochondriasis में क्या होता है. Patient को लगता है that person is having some serious illness. Depersonalization में patient को लगता है as if I'm detached from myself. यहाँ पे तो patient does not remember. Person is acting as if there are two people, isn't it? But again it is not PTSD. Remember PTSD में तो duration is more than 1 month and symptoms of MAHI is there ना. A for avoidance, I for क्या होता है? Intrusion symptoms. Patient after the trauma avoid करता है memories को, उसको याद है, he remembers all those things. And intrusion symptom patient may have flashbacks and all those symptoms. It is not PTSD. What is the answer here? Dissociative identity disorder or multiple personality disorder. Very important, remember. Patient, there is 2 or more personalities which may exist in an individual. All of us have one personality here. Person may have 2 or more personality. Like in that case, देखो, patient is clicking photos with friends and one personality is clicking those photos, another personality does not have any remembrance of those things. So this is multiple personality disorder, and they have also given you history of child abuse. Sometimes yes, because of certain factors, these symptoms may develop. Also remember some other dissociative disorders like dissociative amnesia. Dissociative amnesia में देखो, amnesia means loss of memory. Person is not able to remember some personal information. For example, person was kidnapped for 2 days. Police rescued the person, but he does not remember what happened in those 2 days. So this is dissociative amnesia. Very important, but a fugue paid twice question was asked in 2 different exams recently. Fugue का मतलब to wander. So there is a sudden unexpected travel away from home or workplace. So patient has traveled so far. He is unable to recall the past event and may assume a new identity. For example, person had a financial loss. He went missing. 6 months later, वो मिला in another state. And he does not remember anything. So what is happening in all these disorders? See, the stress is too much. What is happening? The stress is too much that the mind is, to decrease the stress, is converting into various symptoms. And please remember, these symptoms are produced by the unconscious mind. Matlab person is not faking the symptoms. So you will see that in these disorders, but in somatoform and related disorders and dissociative disorders, you will see that symptoms are present maybe bodily symptoms, but there is no bodily cause. There is no bodily cause. So in the question they may tell you कि investigations are normal, examination is normal, है ना, and they may give you a stressor. Like in this case also they've given some stressor. They may give, they may not give. So then you are thinking of these disorders. So remember यहाँ पे amnesia तो है, but it is not that organic वाला amnesia ना. So the brain you see everything is normal. You do investigation, everything is normal. So this is dissociative fugue. But fugue मतलब wander. Patient को let us say there was a financial loss. Mr. A, he was living in Delhi. Financial loss हुआ and he was missing from his home for 6 months. One of his friend उसको मिला Mr. A, but in Chennai. But you know what he said to his friend? Who is this Mr. A? मैं तो Mr. C हूँ, who lives in Chennai and I work in a place, in a shop. तो ये क्या हुआ? इतना ज़्यादा स्ट्रेस था that mind made the person to travel and then past की life का there was amnesia and a new identity was created. And depersonalization, derealization में क्या हो रहा है? See the name. D का मतलब detachment, personalization from self. So patient says, sir, I feel as if I am detached from myself. Okay. While derealization में detachment from the world. Sir, सब कुछ unreal सा लग रहा है. Please remember, tell me, reality testing in depersonalization, derealization is intact or impaired? Now here that classification which we discussed will come into use. Remember that neurosis and psychosis का जो classification था? Tell me the answer in depersonalization, derealization. Reality testing present intact है या impaired है? बेटा देखो again go back to that classification ना, ये तो neurotic disorders है ना, तो हमने कहा था ना reality testing is intact. Patient will say, sir, I know it is not true. I know I am myself only. I know the things around are real only. But you know again I am having these chronic feelings. Is it clear? But answer this question. So again dissociative disorder, but just revise. Recently questions आए थे, so one has to be very careful. Let's talk about some somatoform related disorders. Mr. M, 35-year-old man, is chronically preoccupied with his health. For many years he feared that his irregular bowel functions meant he had cancer. Okay, he feels relieved for some time when test result comes negative, but again he starts worrying. Now he is preoccupied of having a serious heart disease, despite cardiologist reassurance, and that the occasional extra beats he detects, you know, when he checks his pulse are completely benign and nothing to worry. तो cardiologist तो reassure कर रहे हैं, there is no sign of any serious illness. So उसको बार बार लग रहा है ना कि उसको कोई serious illness है. Very good. बेटा please remember in the somatoform related disorder, somatic symptom disorder में patient बार बार preoccupied है symptoms को लेके कि मुझे ये symptom है वो symptom है, although everything is coming to be normal. Hypochondriasis में patient thinks that he is having a serious illness. New name in DSM-5 is illness anxiety disorder की serious illness की anxiety होना. So please remember यहाँ पे क्या है? He thinks that he has a serious illness. So the answer here is it is hypochondriasis. It is not OCD. Let's also discuss what is conversion disorder. यहाँ पे answer is hypochondriasis. देखो conversion disorder. Remember in DSM-5 has been given this term, new term, functional neurological symptom disorder. यहाँ पे patient is preoccupied with neurological symptoms. Patient को neurological symptoms which are functional. They can be sensory like hemianesthesia, blindness है. So a young girl listening to her parents fight and they are deciding to divorce suddenly starts saying, sir, mummy, papa, I am not able to see anything, where are you? Suddenly she reports of blindness. And with every investigation you did, सब कुछ normal आया. Gradually stressor को decrease किया, therapy start हुई and she is able to again see again. So this blindness is not because of any abnormality in the body. So this is functional neurological symptom disorder. Patient may have motor symptom like pseudo seizure, not true seizures. So they may tell you that MRI, EEG is normal. They may tell you that there is no injury, there is no loss of consciousness during those episodes. So then you're thinking of pseudo seizures, you're thinking of conversion disorder. Is it clear? If there are neurological symptoms but they are functional, there is no organic cause. Conversion disorder, tell me, is more common in males or females? Please remember it is more common in females, especially young females. Also this question has been asked so many times, but you should know this. But again the symptoms are produced by the unconscious mind. They are experiencing the symptom. But this girl is experiencing blindness. It's not that she is faking, but it is produced by the unconscious mind. Please remember this. Okay, so it's not that the person is faking the symptoms. What is la bella indifference? बेटा indifference का मतलब होता है फर्क ना पड़ना. hardly bothering about the symptoms. So careless attitude towards serious illness. Can you appreciate the child has such a serious symptom of blindness, but she feels, appears to be not much worried about the serious symptom. So this is labella indifference, which can be seen in condition like conversion disorder. But I hope this is clear to everyone. So we have covered another important category, that is neurotic disorder. Let's discuss some questions of child psychiatry, then we'll discuss substance and some miscellaneous topics. See this. Which of the following is not included in autism spectrum disorder, beta? So tell me, this is again a repeatedly asked, this question was asked recently only. So we know autism spectrum disorder, again this is a new term both in DSM-5 and ICD-11, है ना? And remember what they've done, there are certain symptom, disorders which are similar, so they've made one category autism spectrum disorder. Please remember now they are considered as neurodevelopmental disorders. Okay? They may ask this, what are these? These are neurodevelopmental disorders. So there are two core features of autism spectrum disorder. One is social communication is weak or there is deficit, and there is some repetitive restricted patterns of behavior. Certain behavior the child is doing again and again. So the disorders which are included here includes autism, Rett syndrome, Heller syndrome, Asperger syndrome. All of them will have these two core features. So answer this question. Which of the following is not included in the diagnosis autism spectrum disorder? Abnormalities in social communication, yes. Abnormalities in socialization, yes. There is deficit in social communication and there is repetitive patterns of behavior. Cognitive dysfunction may be seen, may not, but it is not the core feature. Please remember this. Is it clear to everyone? So that is the answer. Very good. Now also in the management, but in the treatment, I'll talk about Rett syndrome specifically, but in general when we talk about the management of autism spectrum disorder, psychosocial interventions can be used like behavioral interventions. So we're trying to improve the behavior and using ABA, but please remember applied behavior analysis, using ABA we are trying to manage the symptoms, okay. So ABA, it can be used. So for example, we are targeting social communication or behavioral skills. So we can use reinforcements, okay, to increase certain behaviors. So we are using reinforcements to increase certain behaviors and to decrease certain behaviors. So we're trying to improve the behavior. Also parent training, social skill training, behavior therapy, CBT, and even educational interventions can be used. So a lot of focus in autism spectrum disorder is on the psychosocial intervention. Remember, especially while using behavioral intervention, using applied behavioral analysis to increase certain behaviors, to decrease certain behaviors. Now especially let's talk about Rett syndrome, very important. Now usually when we talk about autism spectrum disorder, they are more common in males than females. Rett syndrome beta is an exception. It is more common in females than males. Please remember this. Also there is a known gene which has been identified for Rett syndrome, MECP2 gene on chromosome XQ28. So there is a risk factor, genetic risk factor which has been identified for Rett syndrome. Now two core features of Rett syndrome will be the same as in autism spectrum disorder. Something unique about Rett syndrome is that the first 5 months, the child will appear absolutely normal. So you will see the child is having normal development. Problems will start from 6 months to 2 years. So here will be abnormality when it will start during this time. There may be stereotypic movements such as hand wringing, but please highlight this, please remember. So child may be having such midline, such hand wringing movements. Also you will see the child may have microcephaly. So there may be decrease in the head circumference growth. At birth, tell me, the head circumference growth will be normal or abnormal? It will be normal. So it will not be microcephaly at birth. So they may just play with words, remember, and it's not macro, it's microcephaly. Also certain other abnormalities like loss of speech, muscle coordination may also appear to deteriorate. So these are some other associated symptoms which can be seen. Now we have one drug, FDA approved drug for this particular condition. This drug was approved in 2023 and twice this has been asked already in INI-CET. Can you name that drug? Anybody? Can you tell me the drug which I am talking about? Remember, it is trofinetide. Very good. Tide means it's a peptide, it's a tripeptide. Please remember this. So it is approved for Rett syndrome for children whose age is 2 years or more. Okay, so this is approved for Rett syndrome. Let's see this question. Untreated, again this is a PYQ, untreated ADHD. So ADHD, the child develops. Usually when we talk about ADHD, the symptoms have an onset before 12 years of age. So please remember this, onset is before 12 years. Many of the children, the symptom may improve, but some children may continue to have symptoms in adolescence and even adulthood. Okay, so in an untreated ADHD child, increased risk of development of which of the following is seen in adolescence? Beta, tell me what is the answer. Remember, selective mutism and separation anxiety disorder, these are also anxiety disorders which have an onset in usually childhood, adolescence. Okay, so tell me what is the answer here. Very good, very good. The answer here is conduct disorder. Very good. In adolescence, it can cause conduct disorder, and in adulthood, some children may even develop antisocial personality disorder. Very good. So let's talk about ADHD. See this, as the name suggests, attention deficit hai and hyperactivity disorder. So again, there are two core features, attention kam hai and hyperactivity or impulsivity seen. It is also a neurodevelopmental disorder. Please remember this. 40% of the cases better show remission at puberty or in early adulthood. And पहला symptom जो remit होता है, it is hyperactivity. Last to remit is inattention. But some who have partial symptoms, they are at risk of in adulthood antisocial personality disorder, even substance use, even mood disorder in future. In adolescence, they have risk of developing conduct disorder. So please remember this, very important. Let's also talk about the treatment. This table again is very important. Please remember this table. In the management of ADHD, if they ask you what is the first line treatment, is it drugs or therapy? Remember, for ADHD, in the treatment we have drugs. Pharmacotherapy is the first line treatment, and we have two categories of drugs. But one is CNS stimulants and another is non-stimulants. So tell me, what is the drug of choice under CNS stimulants? Tell me what is the drug of choice in CNS stimulants. Can anybody tell me what is the drug of choice? It is methylphenidate. Remember, the drug of choice is methylphenidate. Okay, methylphenidate works on dopamine as well as in norepinephrine. Now, two important side effects of methylphenidate, better remember. One is growth suppression. So growth suppression can occur. So child ka weight, height is not improving. You don't have to stop. You can give drug holiday from drug. Tell the parents stop the drugs on weekends, stop the drug on summer vacation, winter vacation. The growth may come back. Child started on methylphenidate, parents come and say the child is having such abnormal movements, such abnormal vocalization. But what are these? What are these abnormal movements or vocalization? Tics can occur. Very good. Tics can occur. Now, in fact, CNS stimulants, they can cause tics. Then you have to think of some other drugs, which we will discuss. So one is methylphenidate, another is amphetamine, and also remember even modafinil. These drugs can be used. Modafinil, what it is? A alpha-1 agonist. In fact, modafinil is used for which important sleep disorder? Can you tell me? For narcolepsy. So in fact, remember it with the mnemonic MAM, MAM. We are talking about child psychiatry. Remember MAM. Drug of choice is methylphenidate. Suppose methylphenidate is contraindicated like in cardiac illnesses, or they are not showing effect, then we can also use non-stimulants. In non-stimulants, one important drug is atomoxetine. Beta, what is atomoxetine? Remember, it is a NRI drug. This question was asked once. It is a NRI drug. NRI क्या है? Norepinephrine reuptake inhibitor, or you can say SNRI. SNRI मतलब not serotonin, selective NRI. There is one more drug which has similar mechanism, reboxetine. It is not approved by FDA, but in some European countries even reboxetine is used. So remember, see the name atomoxetine, reboxetine. Again, they have similar mechanism of action. They are affecting norepinephrine reuptake inhibitor. Can anybody tell what is this? Clonidine, guanfacine. What are these drugs? Clonidine, guanfacine. These are what? These are alpha-2 agonist. Alpha-2 agonist. Now tell me, suppose a child is having ADHD and tics. So you may not consider giving the child these stimulants. You may prefer these non-stimulants. And out of these non-stimulants, which drug you may prefer? Remember, clonidine, guanfacine, they are also used as first-line drugs for treatment of tics. So there you may use these drugs because they will also take care of the tics. And remember one more drug, B for bupropion, that it's also an NDR. Okay, we have discussed it's an antidepressant. So here you can remember the mnemonic MAM teaches A to B. So what is A? Two A's are there, atomoxetine and alpha-2 agonist, and one B. So remember, these are some important drugs and questions have been asked from this table. So they may give you a permutation combination of situation and they may ask you the question. So please be very careful. I hope this is clear to everyone. Let's talk about one more topic, that is mental retardation. What is the new term for mental retardation in DSM-5? Better remember, intellectual disability. Okay, so the child is having deficit in the intelligence, so there is intellectual functioning is impaired, and as well as the adaptive behaviors are getting affected. What is the most common genetic cause? Can you tell me what is the most common genetic cause of mental retardation? Tell me. So there may be so many causes. Causes can be, when the mother is pregnant with the child, so in the pregnancy, during delivery, and even after the delivery, even in childhood, factors can cause mental retardation. Usually, again, remember, mental retardation, we say it is onset before 18 years. Please remember, onset is before 18 years. Which is the most common? Very good. Down syndrome. Very good. What is Down syndrome? It is trisomy 21. So second most common, remember, is also remember even Fragile X syndrome. But if I ask you which is the most common inherited cause, yeah, which is the most common single gene cause, which is the most common single gene cause of mental retardation? Because the question is different. So please read the question carefully. Most common genetic cause is Down syndrome, but अगर single gene cause पूछते हैं या most common inherited cause पूछते हैं, then you will go with Fragile X syndrome. So the question may appear very simple, but read it carefully. They may just twist the language. I hope this is clear. Also, based on the IQ, we can divide it into 4 categories: mild mental retardation, moderate, severe, and profound. But a mental retardation, we say when the IQ less than 70. So what is mild mental retardation? Can you tell me? When it is 50 to 69. What is moderate? When it is between 35 to 49. What is severe? 20 to 34. Very good. And what is profound? Remember, if it is less than 20. Sometimes they will just give you these values and ask you the diagnosis. So please be very careful. So such questions may be asked. So we have discussed some important topics in child psychiatry. Let's discuss a very important topic, that is substance. But usually if you ask me one topic which they have never left in the exam is this, substance use disorder. It's a very important topic. Please revise this before the exams. And nowadays they're asking a lot of tricky questions from this topic. See this. Let's answer this question. A 45-year-old male presently complaining of tremors, sweating, confusion, auditory hallucinations, altered sensorium, anxiety for 2 days. On taking a history, the patient is taking alcohol for 13 years but not taking for the past 2 days due to some religious reasons. On examination, hepatomegaly is seen, LFTs are deranged. Likely condition बताना है, drug of choice बताना है आपको. But tell me, what is the likely condition here? Very good. It is delirium tremens. Very good. And the treatment you are saying is lorazepam. Tell me why you have said it is delirium tremens. I'm very happy. So it's a withdrawal state we have seen. Can anybody tell me why you have said it is delirium tremens? What is there in the question which has told you that it is delirium tremens? Tell me why it is delirium tremens. Because you will say what is hinting you towards impairment of consciousness. Delirium का मतलब consciousness impaired है ना. So they mentioned confusion, altered sensorium, isn't it? So this is telling you it is delirium tremens, and you're saying it is lorazepam. Very good. So let's talk about this table. Very important. So in the alcohol withdrawal state, so when the person may decrease or stop taking alcohol, in the next 6 to 8 hours, patient may develop tremors. So tremor is the most common or earliest withdrawal symptoms. Other withdrawal symptoms may also occur like anxiety, sweating, increase in the blood pressure, all those symptoms. If this state continues 8 to 12 hours, patient may develop alcoholic hallucinosis. So patient may develop hallucinations, auditory can occur, even visual, even tactile hallucination, these can occur. In the next 12 to 24 hours after stopping or decreasing, patient may even develop seizures. These are alcohol withdrawal seizures. They are generalized tonic-clonic seizures, also known as rum fits. Fits due to rum fits, okay? And up to 72 hours, peak in 48 to 72 hours, but a patient may even develop delirium tremens. Very important, it's a medical emergency. In delirium tremens, there is impairment of consciousness. Now you will appreciate, we discussed na ACDC. So any of those 4 points if mentioned, that is telling you that consciousness impair ho gaya. Now you will make a diagnosis of delirium tremens. But a delirium tremens maybe patient can have hallucination. Can you tell me which hallucination may be more common? Tell me. So again, remember visual hallucination. How will you differentiate alcoholic hallucinosis from delirium tremens? Not on the basis of duration, not on the basis of hallucination, but on the basis of this impairment of consciousness. Alcoholic hallucinosis में the consciousness will be intact, while here the consciousness will be impaired. Now coming to the treatment, when you treat the patient, this is again a very important table. So the patient is treated in two phases, but पहला है detoxification phase and another is maintenance. Detoxification मतलब हम क्या manage कर रहे हैं? We are managing the withdrawals of the patient, है ना? Patient may come to us in the withdrawal state. Tell me what is the drug of choice for treatment of alcohol withdrawal symptoms? Tell me what is the drug of choice? It is benzodiazepine. Please remember the drug of choice is benzodiazepines. So we can use benzodiazepines like lorazepam, diazepam, oxazepam, chlordiazepoxide. Usually these are the benzodiazepine which we may use. But what if in the question they tell you that the LFTs are deranged? Like in this scenario, no, they told you there is hepatomegaly, LFTs are deranged. So remember, drugs, liver okay drugs, matlab drugs which can be given if the liver is compromised. Remember lorazepam, oxazepam, even just to complete, remember the mnemonic liver okay treatment, even temazepam. So these are drugs relatively safe to be used in liver disease. So agar aise question mein they ask you to choose a benzodiazepine, then go with these because they are relatively safe in liver disease. Very good, yes. Now along with these benzodiazepines, beta, would you like to add something else also in this patient? Very good. Yes, you will also add thiamine, है ना? Thiamine may also be deficient. देखो, if they ask you treatment of alcohol withdrawal, best, the drug of choice is benzodiazepine. If they ask you benzodiazepine या thiamine, go with benzodiazepine. If they ask you benzodiazepine या benzodiazepine plus thiamine, that will be a better answer then. Is it clear? So we'll start benzodiazepines depending on the withdrawal symptom and gradually we'll taper and stop. In the next 7 to 14 days, we may taper and stop these benzodiazepine. Now let's talk about the maintenance phase. We have treated the withdrawal. Now in the maintenance phase, we can give drugs, we can do therapy. In the drugs, remember one drug is we have disulfiram. It's a aversive agent. Remember the mechanism of action, it's a aldehyde dehydrogenase inhibitor, ALDH inhibitor. Also we have anti-craving agents, but two approved anti-craving agents for alcohol. There are other anti-craving agents also, but FDA approved are two. One is naltrexone. What is naltrexone? It is opioid mu antagonist, and another is acamprosate. It is a NMDA antagonist. So please remember, this is maintenance. So we don't want the patient to go home and again start drinking. So we then come in the maintenance phase. I hope this is clear to everyone. Now let's come to this. Again, this is a very important table. Alcohol, everything is important. Okay, so please remember. Also tell me, beta, alcohol is a CNS depressant or stimulant? Beta, alcohol CNS depressant होता है या stimulant होता है? Does it vary with dose? Alcohol is a CNS depressant or it's a stimulant? Please remember, very good, at all the doses it is a depressant. But please remember, alcohol is a CNS depressant. And initially some people feel excited, this occurs because of disinhibition. But alcohol is a CNS depressant. That is why, can you appreciate, a patient is taking alcohol regularly, suddenly stops. So now the brain goes in excitement. So can you appreciate, there is seizures, tremors, even delirium tremens में हमने discuss किया था ना कि delirium tremens में अगर हम alcohol delirium withdrawal delirium में if we do EEG, there is fast activity. So in withdrawal state, the brain now goes in the hyper excited state because it's a CNS depressant. Is it clear to everyone? Always apply the concept and you will be able to remember things. The chronic use of alcohol can also lead to some neurocognitive disorders. Two important disorders, one is Wernicke's and Korsakoff. I'm sure all of you must have read about them. I'll just briefly discuss. Wernicke's, remember, it has an acute onset. And what are the symptoms? Remember, global confusion. Goa, है ना? Goa is very famous for Fanny. Remember, G से global confusion है. O से ophthalmoplegia. So patient may have ocular signs, symptoms. Sixth cranial nerve is affected more than third cranial nerve. A for ataxia. Patient is trying to walk, he falls down. So patient is having these symptoms. Please remember, यहाँ भी confusion है, delirium tremens में भी confusion था, but वहाँ पे withdrawal state mentioned होगा. They will mention some other withdrawal symptoms. While here, they will not tell you it's a withdrawal state, and they will mention these other symptoms as well. So this is Wernicke's encephalopathy. Can you tell me, beta, what is the cause of these alcohol-induced neurocognitive disorder? इनका actual cause क्या है? Is it alcohol or something else? Remember, it is deficiency of vitamin B1 or thiamine. That is actually causing these symptoms. So treatment में क्या करेंगे? We will give thiamine and it is reversible. So you will see the symptom are usually reversed. Is it clear to everyone? Very important. Now, Also remember, let's go to some important points. देखो why thymine deficiency is causing. देखो, we know thymine pyrophosphate, it is required. You'll read this in biochemistry also. In so many enzymes, it is required in the Krebs cycle. Remember ATP, alpha ketoglutarate dehydrogenase, trans ketolase, pyruvate dehydrogenase, even in other enzymes like branched chain keto acid dehydrogenase, thymine is required. Okay. Now, please remember this point. Suppose I am treating a patient who is consuming alcohol. He comes in the emergency with hypoglycemia. Okay. And you have to give this patient, so you have to give this patient IV glucose. So it's very important, this has been asked in one of the other exams. तो इस patient को हम कैसे treat करेंगे? If you get a chronic history of alcohol use in the patient, patient may be deficient in thymine. If I give plain glucose, can you appreciate patient may be having deficiency in thymine, so the metabolism of glucose may not occur, normal metabolism, because thymine is deficient. So please remember, in such patient we will always give thymine followed by glucose. Very important point. This was asked in fact NEET PG, so they are asking some two extra points I always discuss. This is one of them, and it was asked. One more point I want to discuss. Suppose I am giving a patient thymine, he is having symptoms of Goa, I gave him thymine but no response. Iska matlab it is not because of thymine. So can you tell me what will be the next step? What will be the next step? So this may occur because of pellagra encephalopathy, that may also have similar symptoms, and now you will give niacin. So please remember, very good. So please be very careful if they want to ask more deeper question from these topics, so such questions can be asked. Now coming to Korsakoff usually has a chronic onset. So it's a chronic sequelae of Wernicke's. Symptoms may develop slowly. You will tell me the symptom. We have talked about Korsakoff just one and a half hours back. Tell me one important symptom of Korsakoff. We discussed under amnestic disorder, so amnesia can occur. Remember, both anterograde and retrograde occurs, anterograde more than retrograde amnesia. Even confabulation, filling of memory gaps with false stories, that can also occur. But the cause again remains the same, thymine ki deficiency hai, so again in the treatment you will give thymine, and remember it is, some symptoms may remain, so it is partially reversible, or you can remember irreversible. Okay. It's again a very important table. Please revise this table when you're revising psychiatry. Substance use, especially alcohol, very important. In fact, substance is one of the very important topics. See this question. A very interesting question. Dekho, sometimes when you see such questions, always try to rule out the option. You'll come to the right answer. You have to tell me all of the following are correct except batane. Cannabis use can result in self-driven repetitive behavior. Suppose you have a doubt in this. Let us say, let's move on to the other options. Volatile inhalational agents are toxic to humans. It is correct. Yes, it can cause in fact damage to the brain, to the kidneys, to the peripheral tissues. Yes. Opioids are very effective analgesic. This we know. Yes, opioids are used as analgesic agents. Morphine we know. Alcohol acts as a stimulant at low dose and depressant at high dose. Now tell me the incorrect statement. Very good. I hope it is clear now. Answer is, it is incorrect. It is depressant at all the doses. Yes, sometimes cannabis use, you will see that person may have some repetitive behaviors. Person under the influence of cannabis may be eating something, maybe just laughing and laughing. So yes, sometimes repetitive behaviors can occur. And sometimes even the drug seeking behavior, repetitive behaviors can occur. So incorrect statement here is option number D. So please be very careful. Also, let's talk about one important substance, beta, cocaine. Now cocaine is a stimulant. There are two important stimulants. One is cocaine and another is amphetamine. Okay, let's discuss cocaine, and similar symptoms can also occur with amphetamine. So cocaine is derived from the leaves of the plant Erythroxylum coca. See, it's a stimulant now. So patient may have hypertension, may develop tachycardia, tachypnea, cardiac arrhythmias, seizures can occur. Can you tell me patient develops meiosis या midriasis? Tell me, meiosis होता है या midriasis होता है with cocaine? With these stimulants, is it meiosis या midriasis? Tell me. Remember midriasis. Even in TCA toxicity हमने discuss किया था ना, there is midriasis. Here also remember midriasis. Cocaine bugs, we have already covered this. So patient may develop these cocaine bugs or magnum bugs. So scratch marks can occur. Now you will appreciate this question, which I discussed in the beginning. Patient comes with tachycardia, tachypnea, scratch marks. Which substance he is consuming? See, it's a stimulant now, so it can cause tachycardia, tachypnea, and scratch mark may suggest that it is because of these tactile hallucination. What are speedballs? Remember, it's an old question, a combination of cocaine with opioids like heroin. The person is consuming cocaine, and many times you will see the person may use cocaine while snorting. It can cause nasal stuffiness can be there, and over the course in the nose it can even cause nasal septal perforation. So they may ask an image based question. In the tongue you may see jet black pigmentation, so please be very careful. Such questions can be asked. Also remember, stimulants like cocaine, amphetamine, they can also cause symptoms like delusions, hallucinations can occur, tactile hallucinations, even auditory hallucinations, these can occur with the stimulant use. Is it clear? So it's a very small topic, but you will see many questions have been asked from cocaine. Let's answer this question now. A very similar question was asked even in INI-CET. Sometimes they may ask less questions from psychiatry, but substance is one topic which they never forget to ask. See this, so you have to tell me column 1 में substance है and drug है, column 2 में you have to match. So tell me alcohol withdrawal में what is the drug you are going to use? Remember, you can give drugs like benzodiazepine, that is lorazepam. Opioid intoxication, tell me that classical triad of opioid intoxication. Beta, what is that classical triad of opioid intoxication? Remember, respiratory depression, pinpoint pupil. See, opioid intoxication mein there is meiosis and even coma can occur. And drug of choice, this has been asked so many times, IV naloxone, opioid antagonist, short acting. So remember, for opioid intoxication, naloxone. Nicotine dependence mein which drug you can give? You can give drugs like varenicline. So one is varenicline and another drug is bupropion. And also we have NRTs, nicotine replacement therapy. If they ask you most effective, remember then it is varenicline. Varenicline, bupropion, we know they are anti-craving property for nicotine. And for heroin withdrawal, so if a person comes with opioid withdrawals, there you can use drugs like methadone and also you can use buprenorphine. है ना, morphine से rhyme कर रहे हैं ना, remember it's a partial agonist of opioid mu receptors. I hope this is clear to everyone. Please revise this topic very carefully. A lot of questions have been asked. Okay, so 1 is D, 2 is A, 3 is B and 4 is C. So this is the right answer. I hope this is clear to everyone. Answer this question. A 30-year-old male with symptoms of abdominal pain, yawning, diarrhea, rhinorrhea, sweating, lacrimation, pupillary dilatation, piloerection. So ये कौन सा substance is associated? See, in intoxication of opioid we have discussed that triad. In opioid withdrawals, please remember, in opioid withdrawals patient may develop these symptoms, isn't it? So patient may report of pain in different areas. There is leakage of body outlets. Pupillary dilatation occur in opioid withdrawal. So please remember this. Okay, so here the substance most likely is opioid withdrawal. Even yawning, piloerection, all these can be seen with opioid withdrawal. This we have covered. Tobacco may remember, one is we have NRT and another is we have drugs. Varenicline, it is partial agonist of alpha 4 beta 2. 4 is coming first, beta 2 is coming later. 2 is later. N-acetylcholine receptor. And remember bupropion, it is a NDRI. But the most effective, remember, is varenicline. Most effective is varenicline. Now tell me all the uses of bupropion which we have discussed. Can you tell me all the uses? This may come as a new question. It is an antidepressant, also used for ADHD and also used for smoking cessation. Suppose a 24-year-old male who is having depression, has adult ADHD and has has been using cigarette, is smoking. So which drug you can use? Remember, we can use bupropion. I hope this is clear to everyone. Let's discuss some miscellaneous topic. One is eating disorder. So again, eating disorder is a very important topic. First eating disorder we'll discuss is anorexia nervosa. Remember, these eating disorders usually are more common in females than males. Now anorexia nervosa mein what is happening? The patient is not eating much food. Patient is having this fear of gaining weight. Patient feels that I am, my weight is more or I am normal. My body structure is normal, although the person is very thin. So remember, there is low body weight or BMI is less than 18.5 kg per meter square. This is very important. For your MCQs, but please look at this. If they have not mentioned weight or they have not mentioned that patient's weight or BMI is low, then don't think of making the diagnosis of anorexia nervosa. It has two subtypes. Restricting type is more common, where the patient is eating less food, but is not taking much food. And also there is one more subtype, binge eating purging. What is the meaning of binge eating? Binge eating का मतलब है patient is eating large amount of food in less time, and purging means now the patient realizes, oh my god, I've eaten a lot. So patient may do purging behavior like self-induced vomiting. So remember, self-induced, this binge eating and self-induced vomiting, this is also seen with bulimia nervosa. How will you differentiate it from this anorexia nervosa subtype? Remember, here the weight or BMI is low. This is very, very important. Okay. Okay, I hope this is clear. But try to give your best, even if you're starting today, give your best, whatever, things. So you have to be very selective. Try to give your best and then see. And let's study. Suicide rate more in binge eating purging type than restricting, है ना? Give your best. Don't think about the outcome right now, है ना? These are the days in which you have to give your best. That's it. Try to read all the important topics from all the important subjects and then try to give your best. Focus on previous year questions and topics. Very important, because INI-CET you will see there will be asking a very similar trend of questions. So it's very important. Now, in the management, better please see, sometimes admission may be required. For example, there is complication. Weight by height ratio, is decreased by 20%. There is, complication with like dehydration, electrolyte imbalance is there. So then we may have to admit, even when the weight by height decreases by 20%, then also it becomes an important indication for admission. Now see this scenario, you have admitted a patient and we have given the patient, adequate amount of calories, but after 1 week there is no increase in weight. What is the next step? Increase the calories, give antidepressant, give anti-anxiety drug, or observe the patient 2 hours after each meal. But what will you do here? Remember, observe the patient 2 hours after each meal. What if the patient is doing purging? Isn't it? Now also see this extra point, very important. But see, suppose I am feeding a patient of anorexia nervosa and patient lands up into these complications. Low phosphate, potassium, magnesium, cardiac arrhythmias, rhabdomyolysis, thiamine deficiency, seizures. So can you tell me, okay, can you tell me what is important point here? What is this complication? But what is the complication here? Can you tell me what is this complication you're dealing with? This may come as a new question. They may give you a clinical scenario. Okay, this you must have, even in surgery and other treatment also you read this. Can you tell me what is this? Very good, it is refeeding syndrome. So that is why when we are feeding this patient who was in a relatively state of starvation, we start with low calories and gradually we increase. Suppose if we give very high calorie in the beginning, the person may land up into this refeeding syndrome. So please be very careful. Now let's talk about second eating disorder, that is bulimia nervosa, but again it is more common in females than males. Here patient is having binge eating episodes and compensatory behavior, but please remember, it could be purging like self-induced vomiting. Patient may use drugs like diuretics, laxative, but patient may also use other behaviors like exercise or diet. So please remember this. So patient after binge eating, suppose is dieting for few days or doing rigorous exercise, that is also bulimia nervosa. Remember here the weight or BMI is normal or increased. So patient who is doing self-induced vomiting or purging, patient may have some complications like, see this, dental caries can occur. So patient repetitively is having the acidic content of the stomach in the oral cavity and it's going out. So that can lead to complications. There can be parotitis, swelling of the parotid gland. See the hands. What is this sign known as? Because of repeated vomiting, there may be callus on the knuckles. But what is this sign? It is known as Russell sign. But why increase? Because patient is eating too much. Of course, patient is trying to compensate, but he will not be able to compensate that much. No? So he is eating excessive calories. In less amount of time, he is eating too much of food, and then he is trying to compensate. Okay. Also remember, but HCl, acidic content is going out now, so patient may have complication like decrease in chloride, even sodium, potassium can be decreased. And tell me, patient will develop acidosis or alkalosis? Please remember, metabolic alkalosis, and HCl is going out, so metabolic alkalosis can develop. Again, remember, in the management of anorexia nervosa, bulimia nervosa, treatment usually we will give CBT can be used, and drugs like SSRI can also be useful, but CBT is preferred. So please remember this. These are some important points about eating disorder. It's a topic which they're asking again and again. Now see this question. Please revise this for INI-CET, you can revise it from physiology also. It's a very important topic which they are asking a lot of time. So EEG in different sleep stages. So this is again asked in the last exam only. EEG recording was done in a resting normal state, awake patient, and was asked to close the eyes for some time. Okay? And now on opening the eyes, which wave is likely to decrease? So you should know, normally in awake state, so when we are awake, so beta and alpha waves can be seen. Can you tell me beta waves kab hoti hain? When the eyes are open. These are high frequency waves. And alpha waves kab hoti hain? You are awake when, but the eyes are closed. The eyes are closed. Okay. So here they are saying that patient was awake, eyes were closed, and now he has opened the eyes. So there will be decrease in which waves? There will be decrease in the alpha waves. So please remember this point. Very important. Please remember. I hope this is clear to everyone. Also, let's talk about few EEG findings. See this. So we know that sleep is divided into two states, beta, NREM and REM. Two states में divided है. NREM is further divided into N1, N2 and N3. Remember N2 and 2. So two important EEG findings. See this. What is this? Can anybody tell me? Sudden burst of electrical activity. What are these? What are these spindles? These are sleep spindles. And can you appreciate these sharp positive and negative waves? ये क्या कहते हैं इन्हें? K complexes. So sleep spindles, two important findings remember in N2. Okay, N2 में. And REM में, can you appreciate these high frequency waves are there? These are in fact beta and alpha waves. So high frequency है, but can you appreciate the height is not much. So these are, amplitude is low but high frequency waves. देखो even REM में ना, we are sleeping but brain is showing beta alpha waves. So very interesting. Can you tell me what is this appearance known as? It is known as sawtooth appearance. So many times they will show you this images and ask you what is the stage or what are these findings. So please be very careful. Is it clear? In fact, can you appreciate REM में, it's a paradoxical phenomena. That is why REM को कहते हैं paradoxical sleep. So REM में, remember, we are sleeping but the brain is showing beta alpha waves which are seen when we are awake. So brain is active. So what nature has done, the muscle tone is in a state of paralysis. When we are in REM, our muscle tone is in a state of paralysis. Because again, if there is not paralysis, we may move and we may hurt ourselves, injure ourselves. Okay. So please remember this point. In fact, see this. Again, so many questions on these images have been asked. See, when we divide sleep stages, we divide into these parameters EEG, EMG and EOG. You have to tell me, let us say this is A, B and C. You have to tell me what is this B state telling us. See this. Can I say EEG here is fast? Here also EEG is showing fast activity, it is showing slow activity. EMG is electromyogram. So muscle activity we are seeing it is present, here also it is present. Can I say here it is relatively absent? EOG is eye movement. So can you appreciate NREM का मतलब क्या है? Non-rapid eye movement. REM मतलब rapid eye movement. So based on the ocular movement we have given the name. So here I can say it is fast activity seen. Here again can I say it is fast? Here again it is slow. So eye movements are slow here. So can you tell me? See, EEG is fast, EMG is fast and EOG is fast. It is awake state. B, can you appreciate that EEG is showing fast activity we discussed, muscles in a state of paralysis, and REM, rapid eye movement. So this is REM and this is NREM. Possibly these are delta waves which are seen in N3. So remember N3 mein such high amplitude slow waves are seen. These are delta waves. These are delta waves. I hope this is clear to everyone. Always try to apply the concept and you will be able to see what is this phenomena. Clear to everyone? Now coming to the sexual disorders, see this. Two important disorders, but one is erectile dysfunction and another is PME, premature ejaculation. But see this. In the sexual stages, remember it with the mnemonic. Desire state is there, then there is excitement, then orgasm and then resolution. So anybody under going in the sexual activities, they pass through these four stages: desire, excitement, orgasm and stage of resolution. So remember erectile dysfunction, when there is problem in erection, remember it's a disorder of excitement state. So E for erectile dysfunction, E for excitement. And what is the treatment? Can you tell me the therapy used for erectile dysfunction? Remember it is sensate focus technique. So remember the therapy is sensate focus technique. So very important, remember this technique. Many a times they are asking questions on these techniques. Okay, let me show this slide again. Yes, and sometimes in drugs, remember PDE5 inhibitors, all these drugs ending with phil, that is sildenafil, tadalafil, vardenafil, avanafil. So premature ejaculation, that is ejaculation is occurring early, remember it's a abnormality of orgasm phase. And what is the important therapy or important techniques which can be used? Please remember these names: squeeze technique and stop start technique. Can you tell me any drug which we can use for premature ejaculation? Side effect of one drug we use in the management of premature ejaculation. Remember SSRIs, they have a side effect, very good. They have side effect of delayed ejaculation. Isn't it? That is required in premature ejaculation. So we are using SSRI ka side effect in the management of premature ejaculation. Is it clear to everyone? Now answer this question. This again I will say relatively an important topic, because in many exams you are seeing questions from this topic. Okay, please tell me what is the answer. So we know that personality disorders, but please revise personality disorder cluster A, B and C. Cluster A ka group characteristic hai, they are odd eccentric, that is 1W, remember weird. Cluster B mein 1W, remember wild, they are very dramatic, and 1W for cluster C, remember they are worried. Okay? So please remember these personality disorders. Tell me, borderline personality disorder out of all these four, which is matching? So the person is having certain abnormalities in the behavior, which is deviant from the normal behavior in the society, which you will see. So what is? Yes, unstable relationship, impulsivity, suicidal behavior can be seen. Very good. So it is cluster B mein aata hai na, very good. Dependent is in cluster C. The person is dependent on even small daily things on others. So what is this? So there is fear, separation, relies on others, need for validation. That is dependent personality disorder. What is histrionic? Beta histrionic mein attention seeking behavior. The person wants to be the center of attention. Very good. And what is schizoid? Schizoid, remember the person is having social withdrawal. The person does not want to mingle with people, does not want to, be much involved in group activities, is confined and is socially isolated most of the time. So this is schizoid personality disorder. I hope this is clear to everyone. Na? So 1 is B, 2 is C, 3 A, yes. So the answer is option B. Very good, yes. Is it clear to everyone? So please read these personality disorders, very important. And we also know, we have discussed what is the treatment of, so treatment of all these disorders is therapy. Can you tell me one important therapy for borderline personality disorder is dialectical behavior therapy. So please remember dialectical behavior therapy for borderline personality disorder. Okay, clear to everyone? Now let's answer this question. But a slightly controversial. Dekho, lithium is a very important drug. Please revise lithium. And this in fact is a slightly controversial topic. So again, they may repeat this question. It was asked in 23, but sometimes such controversial questions get repeated at least once more. A pregnant female with bipolar disorder with previous history of 4 episodes, and there is no episode for the past 1 year, well controlled on lithium. Now she is in the 3rd trimester. देखो जब lithium हम दे रहे हैं in 1st trimester, one of the concern is abstinence anomaly, but we have considered giving, we have weighed the risk benefit, and with the consent of the patient we continued this. Suppose in this question, अब 3rd trimester में patient has come, what is the next step in the management? See, please remember, when the lady is in 3rd trimester, there are physiological changes in pregnancy which will alter the maternal lithium pharmacokinetics. So the changes would be such that may decrease the lithium levels. But should I increase the lithium dose? They have given in the question that the patient is maintaining well. So best answer would have been that I will monitor the levels and I will check the levels, or if they have given in the question that levels are reduced or the symptoms have resurfaced, then I would have considered to increase the dose. Increasing the dose is one option, but not in every case we will increase. We will definitely monitor, but that is not the case here. Also remember, just before delivery, we reduce and sometimes temporarily we discontinue the drug to decrease the risk of toxicity in the newborn. After the delivery, again we may again restart the drug. So please remember, decreasing the dose may still be a better answer here. Okay, we will not consider stopping the, again let be drug free nahi. We will again, if we stop again, we will restart after the delivery. So yes, for that small period to prevent toxicity in the newborn, we may decrease or we may stop temporarily. Better answer would have been monitor, but please remember, I will not increase in every case. They have not mentioned any situation in which I have to, increase. Suppose they had given कि symptoms आ गए फिर से, then I would have considered to increase. So please be very careful, otherwise toxicity can occur, and very difficult might be in pregnancy, especially to manage that patient then. Is it clear? Slightly controversial, but still remember this, such questions may get repeated. Now let's talk about few points about lithium beta. One important person for lithium who did a lot of studies to establish its role as a mood stabilizer, John F.J. Cade. Therapeutic range, it has a narrow therapeutic index, it is 0.5 to 1.5 milliequivalent. Acute mania में 1 to 1.5, maintenance में it is 0.6 to 1.2, and toxicity कब होती है? When it is more than 1.5. We have already covered this, that it has anti-suicidal property. But once in INI-CET they had asked that what is the lithium range for acute mania and maintenance. तो मतलब in a way they had asked you therapeutic range. तो उसमें option था 0.6 से 1.5. That was a better answer. ठीक है? So please read the question carefully and then answer. Now also let's talk about some side effects of lithium which you can remember with the acronym lithium. So L say loss of hair. In fact, there can be other dermatological issues with lithium like acne, psoriasis, rash can occur, and also decrease in appetite. Although there is decrease in appetite, but lithium causes weight gain because of other factors, like it can cause hypothyroidism, increase in the fluids intake, so many other reasons. Lithium causes weight gain. Increase in the leukocyte counts. T for remember tremors. Lithium induced tremors, usually side effect wale tremors are fine tremors. And what is the drug of choice for lithium induced tremors? Remember beta blockers like propranolol. Okay, I hope this is clear to everyone. And remember, even patient can develop endocrinal abnormalities. Very important is hypothyroidism. Even hyperthyroidism and hyperparathyroidism can occur. It can increase urine, increase in the urine, polyuria, polydipsia, diabetes insipidus हो सकता है बेटा. What is the treatment for lithium induced diabetes insipidus? Again, we will, supportive care can be given, and if they ask you drug, thiazide diuretics and even potassium sparing diuretics can be used. One important interaction of thiazide and lithium, beta, very important, is that thiazide decreases lithium clearance. So lithium we know is excreted unmetabolized excreted होता है via the kidneys. So थायजाइड क्या करते हैं? लिथियम की क्लियरेंस को कम कर देते हैं. लिथियम टॉक्सिसिटी हो सकता है, तो वन हैज टू बी केयरफुल. व्हेन आई एम गिविंग थायजाइड टू अ पेशेंट ऑन लिथियम, डिक्रीज द लिथियम डोज. एंड मैटरनल में बेटा वी हैव ऑलरेडी कवर्ड ना एब्स्टीन अनोमली. इज इट क्लियर टू एवरीवन? सो दीज आर सम एडवर्स इफेक्ट्स. नाउ ऑल्सो कमिंग टू द डोजिंग, बेटा प्लीज सी द डोजिंग. Okay, please tell me, suppose I am starting a patient on lithium today. Suppose I start the patient on lithium today, or I increase the dose. So when will I take the blood sample? I will wait for 5 T halves. T half of lithium is 1. So we will check after 5 days. So after 5 days or on the 6th day, I will check the lithium levels. And when I am checking the lithium levels, when will I take the blood sample? Remember, we will take the blood sample 12 hours plus minus 30 minutes after the last dose. But please remember, both are two different questions. Suppose patient is on lithium for the same dose, then I can take the sample today only, 12 hours after the last dose. But suppose today I have increased the dose or I have started lithium, then I will wait for 5 days. On the 6th day or after 5 days, I will take the blood sample. Is it clear to everyone? But both are two different questions. Lithium toxicity. Remember, our body treats this. I have been repeating this point again and again. Our body treats lithium like sodium, है ना? हमारी body lithium and sodium में कोई भेदभाव नहीं करती, treats them same. So suppose a patient has dehydration, body will reabsorb sodium, will reabsorb lithium, toxicity can occur. Patient develops diarrhea, diarrhea, vomiting, body will reabsorb sodium, will reabsorb lithium, toxicity can occur. So mild toxicity, when it is 1.5 to 2 milliequivalent, GI symptoms can be there, even CNS symptom like ataxia, nystagmus, muscle weakness. In moderate 2 to 2.5, patient may have more GI symptoms, even hyperactive DTRs, convulsions, stupor, even coma can occur. And severe may see generalized convulsion, oliguria, renal failure can occur, but death can also occur. So one has to be very careful if you are suspecting lithium toxicity. And in the treatment, better stop lithium, correct hydration. If there is any unabsorbed lithium from the gut, we can remove it by using PEG, polyethylene glycol, and sodium polystyrene sulfonate. Activated charcoal has not much role, more role in TCA toxicity. In severe cases, yes, hemodialysis may also be used. Hemodialysis का role कहाँ नहीं discuss किया? TCA toxicity में, यहाँ पे yes, in severe cases. See this, but a lot of questions are being asked. Antipsychotic, antidepressants, mood stabilizer, these are very important topics of pharma and psychiatry integration. Please revise them carefully. A patient on mood stabilizer has developed hyperammonemia, hepatitis, raised hepatic enzymes. Which drug is most likely the cause? Tell me. What is the right answer here? Remember, it is valproate. Okay, remember it is valproate. But lamotrigine is also a mood stabilizer, which is used more for depression than mania. More useful in the depressive phase than mania. It's also a mood stabilizer. In fact, remember the adverse effects of valproate with the name valproate only: vomiting, nausea, ace, alopecia. In fact, more serious side effect you can remember with the acronym PLATE. So remember, P say pancreatitis, decrease platelet thrombocytopenia, L say liver toxicity can occur, A say hyperammonemia, then T say teratogenicity, we know, neural tube defect, even tremors can occur, and remember, excessive sedation in elderly can also occur. So these are some serious side effects you can also remember with the acronym PLATE. So here the answer is hyperammonemia, hepatitis, they can be seen with, yes, they can be seen with valproate. Answer this question. I think this question is relatively easy. A 30-year-old female comes to psychiatry OPD with symptoms of hypomania. History of manic episode was there 1 year back, and she is planning to conceive. Which drug you will avoid? But please remember, if they ask you which drug to avoid, yes, valproate, yes. Suppose valproate is not in the option. So let's talk about relatively safe drug. Again, it's not a list which is given somewhere, but please remember. So from relatively safer to least safe drug, if you ask me, lamotrigine followed by oxcarbazepine followed by lithium followed by valproate. Please remember this. Suppose in this question, if they had not given valproate as the option, then you would have marked lithium, because we know lithium is also teratogenic. It can cause abstinence anomaly. Is it clear to everyone? Let's answer this question. One point about lamotrigine also let's discuss in this question only. So lamotrigine, we know it's a mood stabilizer, can be used. We also discuss even rapid cycling maybe after valproate. This also drug is showing good effect. One important serious adverse effect you should know. Stop lamotrigine. You have to tell me the false statement. Stop even if benign rash develops may represent early manifestation of Stevens-Johnson syndrome or toxic epidermal necrosis. This is correct. Yes, because it is notorious to cause the toxic rash. Yes, rash likelihood increases if started at higher doses or speed of dosing than recommended. Yes, it can again increase the risk. Concomitant valproate increases the risk. Yes, that also is an important risk. If dose is missed for 4 days, then restart if not already been on, as if already not been on medication. So restart again when you're starting the dose again. So if the patient has missed 4 days, it is not useful for rapid cycling. This is a false statement. Very good, beta. It is useful for rapid cycling. We discussed. Few points, but a few more slides and then we'll stop. I think another 10 minutes and we'll stop. Mental Health Care Act, again a very important act, MHCA 2017. Few points. One is advanced directive. But advanced directive का मतलब है all of us we can make our advanced directive. Anybody who is 18 and above in India, we can write down in this advanced directive the way we wish to be treated or not to be treated if somebody develops a mental illness in future, and at that time they are not able to take a decision. So their advanced directive can be followed. Nominated representative matlab we can nominate a person who will take treatment related decisions if we are not able to take those decisions in the mental illness. Also remember, there is decriminalization of suicide. But earlier there was IPC 309. Okay, there was if somebody attempts suicide and he survives, it was punishable under 309. But this has been now removed. So now we have IPC is replaced by what? Can anybody tell me? It is replaced by Bharatiya Nyaya Sanhita. And there is no corresponding section of IPC 309 because it has been removed. Maximum duration of admission in a patient is 30 days, but it can be extended. If a patient is admitted, suppose he does not has the capacity to take decision, we have admitted the patient under supported admission. So we have taken the permission of nominated representative. So we can admit that patient at a stretch for 30 days, but it's not that we have to discharge. If we feel admission needs to be continued, we can extend. We can ask the mental health review board, but at a stretch, remember, maximum duration of admission is 30 days. Let's remember two important terms. बेटा वन इज ट्रांसफेरेंस. ट्रांसफेरेंस का मतलब होता है कि समटाइम्स इन साइकाइट्री when we are talking about, when we discussing so many things, patient might have not discussed with other people in his life, so patient may share a lot of personal information. There may be certain phenomena which can develop. Transference होते patient की feelings towards the therapist. These can be positive, these can be negative also. Patient की feelings towards the therapist. Counter transference क्या हो गया बेटा? These are the feelings of the therapist towards the patient. So please remember these phenomena. They may just ask a clinical question on these phenomena. Now this is a very important topic. Remember they had asked this recently in one of the exams. Telemanas. In fact, I'll discuss some newer points also expected to be asked in the exam. So I'll discuss some points. Beta, see, Telemanas, it's the national tele mental health program. And nowadays everything is getting digitalized. We have even a national tele mental health program. Even remember the number 14416, hai na? 14416, and even in this number 180089. Remember in the end it is again coming 14416. Remember this number. They may just ask you the number only. What is this Telemanas? Tele mental health, A for assistance, N for networking across states. It was launched, it was relatively a newer program on 10th of October. 10th of October is the World Mental Health Day. Recently we had, and there was another update. So very important, I'll discuss those update chances that may come as a new question. So it was launched in 2022 by the Ministry of Health and Family Welfare, Government of India, right? So what is this? Basically there is two-tier system. So anybody can call here, and one is the state Telemanas cell is there, and subsequently if further help is needed, the person can also be referred to in-person services through this e-Sanjeevani app. So remember this point, very important, that is Telemanas. Please remember. Also there is a very important update, but please remember this, may come as a new question just recently, and that update came on 10th of October. So today is 15, just 5 days back. So there are basically, there is a person, there is a very famous celebrity. Can you guess the name? If I just give you some hints, who has been designated as the mental health ambassador for raising mental health awareness in India, and she's a female celebrity, a Bollywood actress. So can you guess? So they may just ask you this, who is that person? Any guesses? She has spoken about the mental illnesses at since quite some time. So who is that celebrity I am talking about? Very good, yes. Please remember Deepika Padukone. She has been made the first mental health ambassador. So this may come as a question also, can come, because these are some important points. Also, new initiatives have been launched in this Telemanas app. It has been made multilingual. So again, now other than English and Hindi, in different languages like Assamese, Bengali, Gujarati, Kannada, Malayalam, Marathi, Tamil, Telugu, Odia, Punjabi. So there are more, 10 more regional languages it is available to increase the accessibility. Also remember now a chat bot feature with the name Asmi has been also included. So they're trying to make it more accessible, and also emergency response module has also been added. So there are some updates. Remember this, it is relatively new, and mental health, Telemanas, again it's something which is going on. A lot of changes have been made recently, so please be very careful. A question may just come on this. In fact, also remember, you must have read this in other topics in PSM or even in Obs and Gynae, that there was recently a Swasth Nari Shashakt Parivar Abhiyan, which was from 17th of September to 2nd of October, 2025 only. So you must have read, just go through this once, because it may come as an Obs and Gynae or PSM question. Also remember, in that also, even this Telemanas facility, it was included. So please be very careful. But defense mechanisms क्या होते हैं? These are, suppose there is stress, so the mind may use, unconscious mind may use these defense mechanisms to handle stress. For example, just read the names. Like projection में क्या होता है? In projection, person is projecting his own inner conflicts, his own emotions onto someone else. For example, person is having an extramarital affair, but he is convinced that wife is having an extramarital affair. So just try to read these names of these defense mechanisms, and you will be able to understand these defense mechanisms and practice MCQs. But just see some important points. This is a very important topic. You can read this in psychiatry and even in forensic. They ask usually questions from this topic of paraphilias. Can you tell me what is frotteurism? Double T. I told you, T for touching, so rubbing private parts of other person. What is eonism, also known as transvestism? So wearing clothes of opposite gender. But a necro क्या होता है? Necro means dead. So sexual intercourse with dead body. And algolagnia, it's a combination of sadism and masochism, so sexual gratification by pain. Is it clear? So please remember these important points, very important. They ask sometimes question from this topic, so remember sexual paraphilias are very important. Let me just give you this list of some important slides in the end. So many of these disorders, beta, see, they are more common in females than males. Remember, there are a few disorders which are equally prevalent in males and females. Schizophrenia, bipolar 1 disorder. All these anxiety disorders are more common in females than males except social phobia. Remember, social phobia is equally prevalent in males and females. Let's discuss few one-liners. देखो, patient with schizophrenia who commit suicide, it is 5 to 6%. And most common cause of premature death among people with schizophrenia, again remember, suicide. And lifetime prevalence of schizophrenia, but earlier data was 1%, now studies show it is 0.7%. So these are just some one-liners. Rate of suicide in India, remember the data of 2022 which we have is 12.4 per 1 lakh population. Reversible causes of dementia we've already covered. Mean age of onset of depression is 40 years. Mean age of onset of bipolar 1 disorder, remember it is 30 years. Sometimes they will ask you epidemiology question, few of the data you may not know. But remember some of the important ones and you will be able to solve many of those questions. But a lifetime prevalence, this has been asked many times, of OCD in general population is 2 to 3%. Mean age of onset of OCD, remember, is 19 years. Onset occur more in early in males than females. And prevalence is, overall prevalence more in females than males. Also remember, most common comorbidity. Patient with agoraphobia sometimes may also have some other psychiatric illness. Remember, it is panic disorder. OCD में most common comorbidity कौन सा है बेटा? Depression. And anorexia nervosa में patient may also have depression. Beta, which drug a patient with depression with anorexia nervosa, beta, which drug you will not give in this patient? Can anybody tell me? A patient with anorexia nervosa develops depression. कौन सी drug you will avoid? Which antidepressant you will avoid in this patient? Remember, we have discussed na bupropion. है ना, bupropion should be avoided in bulimia nervosa, in anorexia nervosa. Also remember some of these scales. Cough criteria, this has been asked, it is for eating disorder. Confusion assessment method we have already discussed na, confusion hai, it is for delirium. MMSE, mini mental status examination, it is used to assess cognitive functions, it is used in dementia. Score of less than 24 is suggesting of dementia. PAN-SS, beta, positive and negative syndromes, positive and negative syndrome scale. So we know positive or negative symptoms कहाँ होते हैं? Schizophrenia में. For alcohol use disorder, remember the CAGE criteria, very good. And even audit क्या है? Alcohol use disorder identification test. So these are some scales which you can remember. And let me just discuss few acronyms. This question was asked in November 2023. But this heads assessment usually we do in adolescents. तो जब हम किसी adolescent को assess करते हैं, we also cover these headings. H से home, his home environment. E से education, employment. A से his activities. D से drugs. And 3S, sexuality, suicide, depression, self-image and safety. So just the question was heads assessment is used in, okay, in infants, in adolescent, young adults, elderly. So remember it is used for adolescents. For breaking any bad news, suppose you have to break a bad news to a patient, we follow this criteria, remember, spikes. Setting should be comfortable, what is the perception of the patient, invite any question, knowledge, emotions, and what are the strategies the person can use. So remember this spikes protocol. And when we are building rapport with a person, remember the acronym PEARL. So just have an idea about some of these terms, because INI-CET is notorious of asking some of these acronyms. Also remember, when we are treating any patient with such as substance use disorders, we can use some of these brief interventions which has 6 elements. So remember this with the acronym FRAMES. Beta, frames में क्या होता है? We give a feedback. We tell the person it's his responsibility to change his behavior. We can give advice. We give a menu of options to him. E for always have empathy for the patient and make the patient self-efficacious. That he has the responsibility, change is in his hand. And when we are doing motivational interviewing in the patient, remember this acronym DARES. And develop discrepancy, जो वो behavior कर रहे हैं, try to develop discrepancy. Avoid argumentation, don't argue. Roll with resistance. If there is resistance, roll with it. Don't argue. And again remember E and S are the same, empathy and self-efficacy. Is it clear? And stages of change. Anybody, again this question was asked in November 2023. Anybody, let us say he is stopping any substance, they may pass through these stages, which you can remember with the mnemonic PC-PAM. P से है pre-contemplation. Patient says, sir, who drinks alcohol? I don't drink alcohol. Family member saying, nahi sir, for full 1 bottle every day, but he's in this pre-contemplation state. No, I don't have any problem. A से contemplation, he realizes कि problem तो है, but he's not committed to any action. P से, he's now preparing, he wants to change, he's making a plan. A से finally he has stopped taking the substance, and maintenance से he has sustained the change for at least 6 months. So remember this PC-PAM. So these are bit of some important points which we have discussed. I hope it was clear. Revise, take each day at a time, and again, I always say it's not the strongest nor the most intelligent of species that survives, but the most adaptable to change. So take one day at a time, don't worry too much far ahead, don't see things at such a far off thing. Take one day at a time. Get up, before, in fact, sleeping today, make a plan for tomorrow. Always have a plan a night before, what all important topics I'm going to read and revise. Also practice MCQs, and again, I'll always show this slide. We're waiting to listen to your success story, and do really well. Take one day at a time, take one session at a time, and always keep a smile. Smiling will not change the situation, it will change the way you're handling situation, and take one day at a time, keep moving forward. Thank you very much. All the very best. May God bless you all. Thank you so much. Thank you. So I hope this is clear, right? Any doubt? Right. Thank you so much. So just let me know if there is any doubt. And please do PYQs, previous year topics, very important, especially for INI-CET. You will see a lot of time these questions are asked. Okay. May God bless you, beta. Thank you. Thank you so much. But a defense mechanism, again I said, just try to revise some of the defense mechanisms. For example, projection was one, है ना, like displacement में क्या होता है, what is happening in displacement, person is displacing the emotions from one object to another. Like the person is angry on the boss, but he becomes angry, goes and becomes angry on the wife. Wife को आया गुस्सा, she becomes angry on the son. So this is displacement. So just read the names and you'll be able to understand the concept. Okay, try to understand the names and you'll see, you'll be able to understand the concept and practice MCQs. Okay, again, so thank you. May God bless you all.